Gaurav Chhaya right here. Dr. Vijay Desai was here somewhere, yes. Dr. Vishal Bhai, Dr. Kubawat, Dr. Khimisra, Dr. Jignesha, Dr. Dilip Patel. Whenever they come, they can just join us on the dais. And Dr. Cecil Parmar, Dinesh Parmar, Dr. Jay Mehta, Dr. Maulik Sanghvi. I think Hiren should be joining us at any moment. Should we start, Dr. Gaurav?
Yes, good morning
Let's start
everyone.
right on time.
So,
Breakfast area में announce कर दो.
so
चलो.
we are supposed to see this interactive ECG and Dr. Ajay is going to start it and Dr. Keval will join with us later. Thanks.
Okay. So there are going to be about 14 ECGs. We'll do as many as we can. Others we can discuss over breakfast, lunch. And okay. So these are interesting cases which have seen over the last few years. I try to bring in the latest ECGs. People accuse me that I am showing old ECGs again and again and interpreting differently. But you can see this is June 25. Okay. So it is every year there are new ECGs. This is a 56-year-old gentleman and patient is having frequent PVCs. I'll give you a slight history slightly later. But when you see these PVCs, you can see they're coming every 4 to 5 beats and they're pretty consistent in nature, consistent in morphology, right? You can actually look at the PVC and you can all localize where it is coming from. So you are having this PVC here and this is predominant positive QRS in V1. So it's RBPP-like pattern. So right side is getting activated later, the left side is getting activated earlier. So it's coming from the, where did the laser pointer go? Here it is. So positive QRS in V1, it's coming from, it's right, RV is getting activated later, LV is getting activated earlier, so it's coming from the left ventricle. So that is what you see from the precaudal lead. And then you look at the inferior leads, it is predominantly positive in the inferior leads and very tall R waves. So the ventricle is getting activated from up to down, from superior to inferior. So from the left side, what is on the superior aspect? It is the left ventricular outflow tract. It is the basal region, anterobasal region of the LV. So you already know, looking at the ECG, it's probably coming somewhere from the left ventricular outflow tract. So let me give you a little history. This is actually a doctor and he is having palpitations, uneasiness, going on for few months and years. He has coronary artery disease, he's undergone bypass surgery, and then he has undergone angioplasty also. But the LV function was fairly good, it was around 55% or so. He, as happens with doctors, we try to manage with medication. So Holters, ELR have been done multiple times for him. And the number of PVCs, we always look at PVC burden in the Holter. So here, total beats are about 220,000 and 17,000 are PVCs, approximately 7.82% PVCs. And every once in a while you are getting a flurry of PVCs. So you are getting couplets, triplets, sometimes a non-sustained VT. And because of that, or for whatever reason, the LVF had dropped from 55 to 45 and he was very symptomatic. That was in April 2025 and this was a month later. His symptoms had increased. And you can see here, the PVC burden has also gone up. It's around 10% here. But now he is getting what? More sustained episodes. So you are getting sinus beats here and couplet, sinus beats, couplet, and then a long train of ventricular tachycardia is going at about 120 beats per minute. So everybody is with me here. Yeah, we have tried this patient on beta blocker, we have tried verapamil, tried amiodarone, tried sotalol, tried flecainide. All antiarrhythmics have been tried. And he is very asymptomatic and is not able to function properly. So then the next thing is, like I have said earlier, antiarrhythmics are only effective so much and they have fair number of side effects. So at some point of time, you have to go ahead and ablate, or you have to have a device to solve the problem. And the treatment provided by ablation or devices is so good that antiarrhythmics pale in front of that. So this patient was taken in for EP ablation. So you can see these are clips. Patient has undergone bypass surgery, and the catheter. Here we already know the patient has PVCs coming from somewhere from the left ventricle. So catheter is going from the femoral artery, descending aorta, arch of aorta, ascending aorta through the aortic valve, and you've already localized it in the left ventricular outflow tract region. So this is the left ventricle, and this is the left ventricular outflow tract. Now when we come to this area, we have to be very careful because the coronary arteries are also right there. So we have to localize very carefully. We have to make sure we catch the target, at the same time don't cause any problem to the left main or right coronary artery. Because when we are giving radio frequency energy, we are giving heat, you are denaturing the protein, and that can affect the left main ostia. So 3D mapping really helps in this. We are doing also simultaneous angiogram in the left coronary to see how far I am from the coronary ostium. If I am more than 5 millimeters away, I am relatively safe. If I get any closer than that, I'm likely to cause problem to the left main. So we do simultaneous angiogram, localize. This is 3D mapping being done, and what it shows is color coding of the PVCs. We are looking at the activation signal. White is the earliest point from where the PVC is seen to emerge, and successive activation points we are looking at are later and later. So yellow is blue, purple is latest, yellow is less late, red is earlier, white is the earliest. So this is the place from where the PVC is arising. So it's like in a pond, you throw a stone and wavelets come out. So you have to trace where those wavelets are coming from, and that is what we get. That is not all. We have to look at the electrical signals, and there are certain clues which we find which we may be able to target better. So this is intracardiac ECG, intracardiac signals. It is going at a speed of 75 millimeters per second. This is the sinus beat, PVC, sinus beat, sinus beat. And when this PVC comes, we are looking at the signal. During sinus beat, the ventricular activation, where my ablation catheter, is almost simultaneous with the QRS. But at the PVC, you are getting a potential which is earlier than the QRS. So probably that is the point from where the PVCs are arising. So we have to actually, bhagte chor ki langoti, we have to catch the focus from where it is coming. So this is where we are looking at. We localize the left coronary. The focus was in the left coronary cusp. We located that place and started ablation, and immediately the PVCs which are coming every third bit, they were suppressed completely. So, but we don't stop at that point of time. We have to make sure we complete the energy, get rid of the focus completely. The focus may not be exactly there, it may be a little deeper. So when we deliver energy, we have to make sure the energy is effective and it is completely suppressing the focus. So this is 3-dimensional mapping being done. This is left ventricular outflow tract. The LV is like this. And this is superior aspect near the LV outflow tract, left coronary cusp. We are looking at the electrical signals. It's not like 3D mapping will provide complete solution. You have to use your brain. You have to maneuver the catheter to likely places, map, and then ablate. We cannot continue to keep ablating. So end of study, the patient is in absolute stable sinus rhythm. In the next 24 hours, he did not have a single PVC on the ECG monitor. And ELR was done a month later. ELR is extended loop recording. Okay, we apply a patch and it records the rhythm for the next 7 days. And look at this now, what was showing 7% and 10%. Now there were only 4 beats in 7 days, 4 PVCs. So 0.01%. This is the Holter which showed this. So completely the PVCs were gone, and this patient has come 9 months later, follow-up a few days ago. PVC is less than 0.01%, completely active, and no symptoms whatsoever. So patients who have a high burden of PVCs, more than 15 to 20% out of those 24 hours, out of those 100,000 beats, whatever, there are chances that it will cause PVC-induced cardiomyopathy, and the LV function may go down, which happened in his case. The LV function, which used to be around 55%, had dropped to 45% or so. There were other Holters and ELRs which were showing PVC burden of almost 20%. So we had a good range, and despite antiarrhythmics, he was getting this. Once this was gone, his symptoms disappeared, and LV function came back to completely normal, and the patient is doing. So you have to be aware of this problem, and you have to be able to pick it. Some of these are notoriously resistant to antiarrhythmic drugs. Whatever you try, whatever in the armamentarium we have, whether beta blockers, verapamil, diltiazem, you can try the class 1C agents, flecainide, propafenone, you can try. If it's active ischemia, you cannot give flecainide and all. But if the patient is post-revascularization, LV function is good, this is something you may try. And there are class 3 agents, amiodarone, sotalol. Nowadays, we have dofetilide. Dofetilide not as good for this as for atrial fibrillation. But all these drugs we have now, but some of these you have to take in the lab. You will not be able to manage with antiarrhythmic drugs. Often doctors and doctors' families have the most peculiar problems also, as you all know. So it may not be easily solved, and you have to take in the lab and manage it. Okay, so that was a slightly interesting case, but very satisfying case. Let's come to more mundane, more usual problem. This is a 80-year-old lady who has, in 2023, undergone bypass surgery and mitral valve repair. LV function at that point of time was 60%. And she came with palpitations. Your interpretation, this ECG is in your booklet. What do you see here? It's bradycardia, tachycardia. Tachycardia? Tachycardia, yes. It's narrow complex here, and then it becomes wide complex, then becomes narrow again. And is it regular or irregular? It looks regular, but a lot of times, if the rate is very fast, and even irregular arrhythmias can start looking a little regular. So just eyeballing is often not enough. You actually have to have calipers and see if the RR intervals are constant or not, whether it's regular or irregular. Very fast rates of more than 140, 150 beats per minute. Often it is difficult to make out whether the RR intervals are constant or not. So this patient is post-bypass surgery and has undergone mitral valve repair, and she presents with 80-year-old. What is the arrhythmia likely to be? LV function is good. What is the subset? Slightly irregular arrhythmia. And you are getting this. Atrial fibrillation, somebody just said, and that is likely to be most common in this subset, isn't it? So the patient was given beta blockers and amiodarone, IV amiodarone, and the rate slightly slowed down. But previously, what was looking as wide complex in between, now it is almost it is narrow complex all the time. So what is the difference which has happened there and here? Why is the patient getting fast, broader complexes here and all narrow here? Absolutely, absolutely. Suresh Bhai is there. So here the rates are particularly fast. So the patient may be getting rate-dependent bundle branch block. And here the patient is getting, you can see one beat in V1, patient is getting rate-dependent left bundle branch block. Yeah? Everybody is here okay with me? Everybody is here with me? Okay. There is some phenomenon, have you heard of this? There is a long RR interval and then a short RR interval. Long short sequences often cause this bundle branch block. You are aware of that, what that is called? Speak loudly. It's Ashman's phenomenon, isn't it? In atrial fibrillation, irregular RR intervals, long RR interval followed by short RR, and then you get bundle branch block. Ashman's phenomenon. That is what you are seeing here. And as the rate slightly slows down, the patient goes back into narrow QRS. After drugs, the patient's ventricular rate is a little better controlled. So QRS is narrow all the time. It looks fairly regular. But now it is probably possible to see that some irregularity is there here also. So you are more convinced about atrial fibrillation. And here the rates are faster, but the patient still has narrow QRS. So it is not necessary that at particular rate, 140 beats per minute, patient will get bundle branch aberrancy. Sometimes the patient may get, sometimes the patient may not get. It depends on a variety of factors. Something else has come up here. What do you see here? Something has changed. Look at the STTs here and STTs here. The patient is getting some T-wave inversion, isn't it? Patient is post-bypass surgery, so you start wondering about whether the patient is getting ischemia now or not. But patient doesn't have any chest pain. And patient was converted to sinus rhythm after having amiodarone, etc. So here you are getting P waves, QRS, narrow QRS, but the STT changes are persisting. Anything else that you are, do you notice here? And you have to be careful about this. 80-year-old, you are giving amiodarone. I have given you enough clues. What do you think is happening?
QT.
This is something you have to be worried about. Can you see this? QT is prolonging and the patient is getting T-wave inversion. So QT is prolonging, 80-year-old IV amio, these patients are likely to get problems like R-on-250 phenomenon, torsades. So after, but probably that was not noticed and patient continued to be on amio, and this is what has happened. What has happened here? He had got nice sinus rhythm at this point of time, and here, yeah, patient has gone into sinus bradycardia and then junctional escape rhythm. So too much of a good thing, isn't it? At this point of time, probably you should have taken the patient off amiodarone itself because already the QT is getting prolonged. Anyway, so at this point of here, the patient was taken off amio because the patient went to brady and then presented again in October with her because the patient is now off amiodarone. Now what is this? Wide complex tachycardia, and here you are getting LBBP pattern. Again, looks fairly regular, very fast. And again, amiodarone was given. The patient, the rate became slower than the previous ECG. Is it regular or irregular? Irregular. So you have a clue here, the patient is again probably in atrial fibrillation, fast ventricular rate. Here also the irregular, but narrow QRS because the rate is slower. And sometimes regular, and sometimes bradycardia. So you are having an interplay of a patient having all sorts of rhythms. Atrial fibrillation, regular narrow complex tachycardia, sometimes irregular arrhythmia, wide complex, narrow complex, atrial fibrillation, fast ventricular rates on and when patient is put on antiarrhythmics, patient goes into severe sinus bradycardia, junctional escape rhythm. One side there is a mountain and the other side there is a deep gorge. It is tachy brady syndrome. Patient is 80-year-old. This is what you would expect. It gets very difficult to control with medicine. So what would you do at this point of time? What would you advise young people? For tachy, you want to give beta blockers amiodarone. Patient lands up with brady. Now do you want to give the patient orsipronolin? If you give orsipronolin to increase the rate, patient will go to atrial fibrillation, atrial tachycardia. So kabhi khushi, kabhi gum. One side there is mountain, other side there is God. So you have to, getting the middle path with medication gets very difficult. So the next logical thing here would be to implant a pacemaker, yes. With atrial fibrillation, the final common pathway is via the AV node. So we would implant a pacemaker, at least take care of the brady component. Patient will not get into severe bradycardia. But then the tachy component, now you can safely give patient beta blocker amiodarone, knowing that the patient will not go into brady. Despite that, after putting in a pacemaker, giving beta blockers amiodarone, if patient continues to get fast ventricular rates, we have an option of just going ahead and blocking the AV node completely, doing AV node ablation. So this is what was done on this patient because she was having problems which are going on for years together. So this is sternal clips of the bypass surgery. This is the mitral valve ring of mitral valve repair. AV node ablation is a fairly straightforward thing. This is the ablation catheter with the thick tip. The sinus node is here. AV node is in this region. This is the His-Purkinje system. We localize it with looking at the electrical signals, give ablation energy, and completely block off the AV node. But that time the ventricular rate will become 0, isn't it? So we have a temporary pacing wire in place and go ahead and implant a pacemaker at the same time. So the patient now has pacemaker for the brady, and for tachy, even if the patient gets atrial fibrillation, will never go into fast ventricular rate. So patient will be symptom free, but you have to anticoagulate the patient because patient is getting AF. And patient was back in sinus rhythm, so we could provide AV sequential pacing to this person. That way the symptoms were relieved and patient was doing well. Did everybody get that 80-year-old tachybrady syndrome, what you would expect at that age? Okay, let's have another case. This is a 14-year-old boy, complains of palpitations. You are seeing this, I've already taken in the patient in the lab. See only first half of the ECG. What do you see here? Anything remarkable? Anything remarkable? Patient is having palpitations for a long time, for years. Episodes which have abrupt onset, abrupt termination, lasting for few minutes to few hours. Yeah, looking at only this ECG, probably it would be totally unremarkable, isn't it? Looks almost normal. But I told you I have taken this patient already in the lab and I have started certain maneuvers at this point of time. Here you can see CS stimulation. I am doing atrial stimulation. Now what do you see here? Alternance. Yes, the QRS alternate beats are different. And alternate beats are wider. So this is narrow QRS, wide, narrow, wide. Anything particularly about these wider beats? Somebody already said it. Yeah, the patient has WPW. But here during atrial stimulation, only alternate beats are getting, you are able to see the pre-excitation. Alternate beats you are getting the delta wave. So this patient has intermittent pre-excitation, okay? With this, when even in normal routine time, when you see a ECG with intermittent pre-excitation, that means the accessory pathway is probably not able to conduct very fast. I am saying probably because nothing in medicine is 100%, nothing is 0%. So these patients, in other patients with WPW, you are worried that if they go into atrial fibrillation, they may land up with problems like this. What is this? Atrial fibrillation with pre-excited tachycardia. Yeah, fast, broad, irregular, which can become life-threatening. So in case any patient gets atrial fibrillation, because the accessory pathway is able to conduct very rapidly, all those 300, 400 beats will go down the pathway and activate the ventricle, and the patient may end up with problems like these, what is happening? AF pre-excited tachycardia and patient is going into ventricular fibrillation, which can cause sudden cardiac arrest and it can cause sudden cardiac death. So 2 to 3 people out of 1,000 can get this. Often what we read nowadays in the newspapers, 20-year-old got heart attack, 18-year-old got heart attack. Often it's problems like this, or it's hypertrophic cardiomyopathy. Not all these patients are technically getting heart attack. It's not coronary artery disease or MI. It is problems like this which these patients are getting. So theoretically, patients with intermittent pre-excitation means the pathway is not conducting very rapidly and less likely that the patient will land up with problems like this. But like I said, it's not 100%. And since the patient was having palpitations, documented tachycardia, you need to go ahead and ablate, and that is what we had done. But here it becomes tricky because the pre-excitation is intermittent. So sometimes this is how we put in the ablation catheter here and localize the pathway. Here this P wave, delta wave, QRS, so atrial signal, accessory pathway and ventricular signal. And when there is no delta wave, you get atrial signal and ventricular signal, which are far away from each other. So you have to map while that delta wave is there and ablate. And it is fairly close to this is what is called right posteroseptal region. It is in the posterior aspect of tricuspid, mitral annulus. This is the pyramidal region here, and this is where the pathway was. Once ablation was done, you can see this alternate beat pattern which you are seeing. Now the alternate beat pattern is gone. So the delta wave is gone, pre-excitation is gone, WPW is gone. At this point of time, the patient is cured of his problem. So we complete the ablation and the patient is in sinus rhythm after that and asymptomatic. So 14-year-old, for years he is suffering from this, and you do a procedure and patient is now asymptomatic, never needs a medicine again in life. So intermittent pre-excitation, not likely to cause life-threatening problems, but you can never be sure. If the patient is having symptoms, better to go ahead and treat it, especially young people. So just on the flip side, this is a similar ECG, 38-year-old gentleman with palpitations. What do you see here? This is pretty straightforward, I think. QRS looks narrow, but there is some abnormality, isn't it? Short PR, absolutely, and you see the delta wave here. But here, all beats have delta wave. Here you are not getting intermittent pre-excitation. This is manifest pre-excitation. And when you look at V1, it is predominantly R wave, predominantly positive. The delta wave is positive in V1. So delta wave positive in V1 means the right side is getting activated later. The pathway is probably in the left side. And when you see delta wave, which is negative in 3 and AVF, probably on the posterior aspect. So looking at the ECG itself, you may roughly localize the location of the pathway, somewhere in the posterior region. But this is what is called mild pre-excitation. See, you had difficulty in seeing whether the delta wave was there or not, isn't it? In other ECGs, you see very prominent delta wave. Here, the delta wave is not very prominent. It's called mild pre-excitation. So what you have to do is see maximally pre-excited ECG. We can do it with atrial stimulation in the lab, and then you can localize it further. So this patient had a posterior accessory pathway. Getting a little complicated for you. I'll show you one more complicated ECG, and then we can go on to the simpler ones. 9-year-old boy with severe palpitations. Now what do you see? Very rapid, narrow, complex tachycardia. Yeah? And the rate is almost going at 223 beats per minute. Do you think it is, can you see P waves? Sometimes with these fast rates, it's very difficult to see P wave also. Maybe there are P waves in lead 2 and they look positive in lead 2. It's merged with T wave, it's on the downstroke of the T wave, yes. Probably maybe what we are seeing P wave is not P wave at all, but possibly it is positive P waves in inferior leads. In V1, soon after the QRS, there is probably a negative P wave here. Okay, so do you think this is normal? It's a 9-year-old boy, 220 beats per minute. Less likely, and even with exercise, they will go, or playing, heart rates can go to 180s, 190s. Having a very rapid rate like this, 220 beats per minute, slightly less common. There were many ECGs which were recorded like this, 220, 250 beats per minute. So the patient was taken in the lab, and this is sinus tachycardia. Often we see this in young children even when they are taken in the lab. And this is clearly sinus beats, positive P waves in lead 2, 3, AVF, and negative in AVR. Everybody agrees with me here? It's sinus tachycardia? Yes? So, this is what I found in the lab. It's a little complicated, but it's a nice concept to understand. Here I am stimulating the atrial coronary sinus and getting 1:1 AV conduction. Atrial stimulation, QRS. Atrial stimulation, QRS. Then atrial stimulation, and I stop. This is the last beat I am stimulating the atrium. I get one QRS and then another QRS. So same one single atrial beat is producing 2 QRSs in this patient. And when I stop stimulating, then normal sinus beat resumes. Why should one beat in the atrium produce 2 QRSs? That can only happen if there is one pathway and there is another pathway. And this is what is called 2-for-1 response. I have stimulated the atrium once, but I have got 2 QRSs coming out of that one P wave. You've heard of dual AV nodal physiology. Patient has a fast pathway and slow pathway, alpha pathway and beta pathway. That is the basic tenet, basic mechanism of re-entrant arrhythmia. You've drawn it in your medicine books, re-entrant pathways, alpha and beta. This is actual example in the lab of how 2 pathways can be activated by a single beat. So, it's not circus phenomenon. Circus phenomenon is when circus movement tachycardia is occurring. This is a non-re-entrant arrhythmia which can be produced in the AV node. So normally you have fast pathway and slow pathway, and they give rise to AV nodal re-entrant tachycardia. Okay, there is a circuit inside the AV node. But here you are having one P wave, one atrial activation. Once it goes down the fast pathway, activates the ventricle. The same impulse takes a little more time to go through the slow pathway and is able to activate the ventricle again. So you are getting 2 ventricular responses for one. So it is 2-for-1 response. And just sinus tachycardia or atrial tachycardia can in fact produce this 2-for-1 response, and patient may get a very rapid tachycardia, 200, 250 beats per minute, even if the sinus rate is only 100 or 120. But it is a non-re-entrant tachycardia. It is produced by by the activation, sequential activation of 2 pathways. But this is also, these patients have dual AV nodal physiology, and they are capable of getting activated. They are also capable of having re-entrant arrhythmia. So this child at other points of time probably must be having rapid AV node re-entry also. So this is another schematic showing the same thing. Fast pathway and slow pathway, single atrial beat. When it goes down the fast pathway, produces this QRS, and then the same impulse gets time to go through the slow pathway and produces the next ventricular activation also. So single P wave giving rise to the green QRS and red QRS. So it's a tachycardia, but not a re-entrant tachycardia. It's a non-re-entrant tachycardia produced due to dual AV nodal physiology. Isn't this an interesting phenomenon? Yeah. How do you treat it? The patient has AVNRT, the patient has this kind of problem. The treatment is the same. You get rid of that slow pathway, which is capable of giving rise to this. So we put in catheters, target the slow pathway, and ablate it, and let the normal fast pathway conduct as usual. So fast pathway is going like this, slow pathway is going like this. I target this and ablate, and after that the patient doesn't have any problem. Patient is having normal rhythm, never got arrhythmia again. Remember, this was a 9-year-old boy presenting with years of palpitations, and one procedure and the patient is treated. So it is important to recognize this phenomenon also. Okay. I hope it is not getting too complicated. Let's get to simple part. 45-year-old gentleman with palpitations. Half the time the diagnosis is also already here. Hiren is here. Wide or normal? Narrow. Narrow complex tachycardia, perfect. Regular and very fast. What else do you see here? You have been taught that when you get a rapid narrow complex tachycardia, you try to look at P waves, Cherchez-la-Femme, Cherchez-la-P wave. And if it is soon after the QRS or at the terminal part of QRS, it's likely to be a AV node reentrant tachycardia, AVNRT. Here, what do you see? You're not able to see the P waves very well, but the ST segments are getting pulled down here, 2-3 AVF. And even in the lateral leads, the ST segments are getting pulled down. You start thinking of ischemia here, but patient doesn't have angina, never has had angina. And when you see during tachycardia, the STs are getting pulled down, probably it is because of a P wave, which is at the terminal part of the STs. So the RP interval here becomes around 120, 140 milliseconds. So it's not as short as a AV node reentry, but not very long either. This is probably likely to be a circus movement tachycardia, accessory pathway mediated tachycardia, what somebody just talked about. Okay, so when we take these patients in the lab, sometimes, okay, let me talk about this. So here you have sinus node, AV node, normal conduction system. These patients, when they have accessory pathway, most of the time the pathways are able to conduct from ventricle to atrium retrogradely. So the impulse comes down the normal conduction system, produces QRS, which is narrow, goes up the accessory pathway. So it's a orthodromic tachycardia. Impulse ventricular activation is via the normal conduction system. So you get a narrow QRS tachycardia. Occasionally the activation may be coming down from atrium to ventricle via the accessory pathway and then go up the AV node. Here, since the activation is via accessory pathway, you are activating the myocardium first, you get wide QRS, okay? Pre-excited tachycardia or antidromic tachycardia here. If this is a circus movement tachycardia, we call it antidromic tachycardia. If it's like a atrial fibrillation, atrial tachycardia and coming down the pathway, we'll call it pre-excited tachycardia. So the AFib fast ventricular rates, AFib pre-excited tachycardia is what we are worried about. And in this patient in the lab, I produced atrial fibrillation. But this person now in atrial fibrillation does not have any wide QRS, okay? Because this pathway, which happens in the majority of accessory pathways, is not majority, in a fair number of accessory pathways, it is able to conduct only from ventricle to atrium. It is only able to conduct from in the retrograde fashion. So during tachycardia, the circus movement tachycardia, the impulse goes like this, down the AV node, up the accessory pathway. But this pathway is not capable of conducting from the atrium to the ventricle. So even if the patient gets atrial fibrillation, the impulses don't go down the pathway. So you are not getting a FBI in this patient. You are just getting atrial fibrillation, fast ventricular rate, narrow QRS. Yeah, so this is a patient less likely to have any sudden cardiac arrest sort of thing. But the patient gets very fast tachycardia, so we go ahead and ablate it, and patient's ECG is as normal as it was before. So this is called, since there is no manifest pre-excitation, There is no manifest pre-excitation in this case. There is no delta wave during sinus rhythm. This is called a concealed accessory pathway. Okay? This pathway is able to conduct only retrograde from ventricle to atrium. There is no delta wave that is seen on the ECG. It's a concealed accessory pathway. Remember that child where I showed you intermittent pre-excitation? That pathway had no robust conduction from atrium to ventricle. So you get intermittent pre-excitation. Here the pathway is not able to conduct at all from the atrium to ventricle. So it's a concealed accessory pathway. Did everybody get this? Yes? Okay, let's go to this one. 45-year-old gentleman with exertional dyspnea, palpitations which last for a few minutes to hours, terminate on their own, sometimes causing breathlessness. What do you see here? PVCs, and I just told you what the PVC morphology. You can decide where this PVC is coming from. This is positive in V1. It has RBBB-like pattern. So it is coming from the left ventricle. And looking at the inferior leads, it's negative in 2, 3, and AVF. So it is coming from the inferior aspect, isn't it? And getting activated superiorly. When you see this kind of morphology, RBBB-like pattern and left superior axis, in a person with a normal heart, having repeated palpitations episodes, this is a clue that the patient may probably be getting PVC, so maybe getting a ventricular tachycardia, and coming from where? The patient has a normal heart, normal LV function. These are probably coming from the normal Purkinje system, from the normal conduction system of the heart, which have become overactive. It's from the left posterior fascicle. Okay? Idiopathic LV tachycardia. So this is the his bundle, and then it splits into right bundle branch, left anterior fascicle, left posterior fascicle. You already looking at the ECG told me the PVCs are coming from the left ventricle, LV, and they are coming from the inferior aspect. So they are coming from the left posterior fascicular region. These are very peculiar problems. They arise from the conduction system. They are exquisitely sensitive and respond to medications like verapamil. You can give this verapamil. These are verapamil sensitive tachycardias or verapamil sensitive VT. Again, can be difficult to control sometimes, so we can actually go ahead.
I would like to invite chair for
the left posterior fascicle would be here. This is the left ventricle 3D mapping is done. This is a different patient having a problem arising from the left anterior fascicle. So left posterior fascicle is here, left anterior fascicle is here, and we can localize it very well and ablate it, and the patient is cured of his problem. Hiren, any input to that?
Inside there is gone. So you have to getting a middle path.
We see this disease more in our part of the world, Eastern Hemisphere. It's more seen in India, it's seen in China, Japan. That is where we see these more. It's very rare in the western part of the hemisphere. We don't know for what reason. Yeah? Okay, 70-year-old gentleman is having episode of syncope. Something was done. What do you think was done? I have already written it on the ECG for you. What was done?
I would like to invite
yeah, possible, but some maneuver was done. Sorry?
I would like to invite chairpersons for this session.
Carotid sinus massage is done and the patient gets? Yeah, but a little more asystole.
2 minutes remaining.
Cytokines, this will finally also lead to the heart failure,
AV block.
mostly in the fields.
AV block, isn't it? And then again, to reconfirm, we did CSM again, and this time patient gets AV block or something else. Here the patient is getting sinus pause, sinus brady. Here
You
the
show
left
in patient-
carotid sinus massage was done. Patient got AV block. And here right carotid sinus massage was done. Patient got sinus bradycardia. Same patient, same time, 2 minutes from each other. So elderly people, when they have this hypersensitive carotid sinus syndrome is a problem. What is the mechanism here? He gets presyncope while shaving. What is the mechanism here? You've just reproduced it with carotid sinus massage. While shaving, you're pressing this region, okay? Yeah. Or if anybody is wearing a tight collar or wearing a tie, this kind of problem would happen in an elderly person. Now, interesting problem is when we do left carotid sinus massage, the patient is getting AV block. And when we do right, you're getting sinus brady. Why do you think that is happening? Conjectures, any hypothesis? You've read in your anatomy, neuroanatomy. Carotid sinus hypersensitivity is an exaggerated response to pressure applied in the carotid sinus located in the carotid bifurcation, can cause brady, vasodilatation, hypertension. If there is asystole of 3 seconds or more, BP fall more than 50, then it should be considered positive. Interesting thing, possibly here what is happening is, you know, the vagus, the sympathetic ganglia from the right side are supplying the sinus node more. Okay, and from the left side are supplying the AV node more. So when you are doing carotid sinus massage here on the right side, patient is getting sinus brady. And when you are doing left carotid sinus massage affecting the AV node, the patient gets AV block. This was an interesting phenomenon that I saw in this. Isn't this interesting? Very interesting, isn't it? It was not very reproducible, but we could see it 2-3 times. What is the treatment in this? It increases with age, more common in men, especially with chronic medical conditions. There is association of neurodegenerative disorders. And treatment is, one is lifestyle changes, avoid neckties, tight collared shirt, not to apply pressure while shaving. And hypersensitive carotid sinus syndrome, unfortunately, if the patient is very symptomatic, medications will not help. This is degenerative disease. And often the only thing which will help is a pacemaker, but it may not take care of 100% of the symptoms. It may reduce the frequency, it may reduce the severity, but the patient may still have some issues, okay? Okay, 80-year-old lady, sudden loss of consciousness. What happened here? P wave, P wave, P wave. It's not too much of a complicated, it's very simple. Patient has gone into a paroxysmal AV block. Suddenly the patient has gone into AV block. And the patient would have had a sudden cardiac death. Only thing is, some QRS has come here and then it's gone again. And then the relatives performed a maneuver and some QRSs started coming. Isn't this an amazing 5 lines of asystole? Here there are 7 lines of asystole and then some QRS beats. So patients, relatives did a CPR sort of thing, and that is why you are seeing these, the noise here. And then by God's grace, suddenly the rhythm started appearing. तो जाको राखे साइया मार सकिनो को. Yeah, the patient was on extended loop recorder, and that is the time the patient had this at home. So isn't this amazing, getting this record? This is another, the patient is having fast rates, slow rate, fast rates, slow rate. You already know the treatment, you already know the problem. It is kabhi khushi, kabhi gum. Patient had tachybrady syndrome. And here again, patient is having bradycardia. and then 2 lines, 3 lines of asystole, and some escape rhythm comes up at this point of time. So elderly people, etc., when they are getting this, be very careful because that can cause sudden cardiac arrest. However, young people, vasovagal like problem, here we are doing a head-up tilt test. Tilt table test is being done. And during the tilt table test, during isoprenalin, when there is intense parasympathomyomatic activation and sympathetic interplay, the patient here is getting sinus bradycardia and AV block, isn't it? And then we bring the patient back down and normal rhythm has started again. So this is a young person, this is a 14-year-old boy, goes to the school, is standing in the assembly line, gets dizziness, falls down, but gets up in 2-3 minutes and is absolutely fine. So this is neurocardiogenic syncope or vasovagal syncope or reflex-induced syncope. Here when you provoke it by doing head-up tilt test, whether you produce sinus bradycardia or AV block, pacemaker is not a treatment for this. Okay, it's going to be hydration, exercise, if required, some drugs, but pacemaker is not a treatment for this. Hiren, any comments on this? Just say something. What is the difference between this group of patients, which we just saw 80-year-olds, and this young 14-year-old patient?
I mean, these young patients are usually having neurocardiogenic syncope. They usually have some trigger, some unpleasant situation, which leads to basically vagotonia. So the syncope may be because
5
of
minutes
either
remaining.
cardioinhibitory response, where there is only bradycardia, or they can have vasodepressor response, where there is only hypotension. Or it may be mixed response, where there is hypotension and bradycardia both. So as you told, if the patient has vasodepressor response, where there is hypotension as a cause of syncope, pacemaker will not help. They need something else. And if they have a mixed response, vasodepressor and cardioinhibitory both, you put a pacemaker, cardioinhibitory response goes off, but vasodepressor response is still there, so patients still have a syncope. But
So-
those patients who have pure cardioinhibitory response, where there is only bradycardia without hypotension and getting syncope, that patient will respond to pacemaker, and they should have specific pacemaker which has a CLS technology which senses the prodrome symptoms of vasovagal syncope before patient is getting syncope, which is available with the Biotronic company. So we usually go for Biotronic pacemaker when there is a pure cardioinhibitory response as a cause of vasovagal syncope.
Those who got early bird prizes, they are from Biotronic company. But tell me just one more point, you already said this, but why would you not give a pacemaker to a young patient with AV block when you see during the test, compared to a 80-year-old with a previous disease and you would give a pacemaker? So what is the difference here? Because
This is
once
a
you see AV block, you
yeah,
are worried. So how worried should you be looking at this? Yeah.
In young, because it is all physiological AV block. Actually, it is just a vagotonia which is causing AV block. And most of the time, these kids, when they grow up, they don't have that vagotonia, and their syncope also sometimes goes off, actually. It is more common in a second decade, and by the time they enter into the beyond 18 and all, they get rid of vasovagal syncope, sir. It's a reversible in elderly patients, because they have already degeneration of conduction system. If they develop syncope, they will develop fracture, femur fracture, neck fracture, pelvis fracture, and once they develop fracture, their life is almost done. So a single fall in an elderly patient is disaster.
Yeah.
In a young kid, a single fall may not going to injure him, actually, sir.
Perfect, perfect. I'm going to straight to the last ECG, because the in-between ECGs are very common. So 80-year-old child has undergone VSD surgery in the past, okay, and has come with repeated episodes of syncope. This is a Holter which was done, and it shows post VSD surgery, patient has had syncope. This is straightforward.
2 minutes
Lot of P
remaining.
waves and less QRSs. This is a patient getting AV block. Yeah. So the patient has AV block, and that is the cause of syncope. VSD, very close to the normal conduction system, and patient can get, oh, this is different. Anyway, so the treatment for that child would be putting in a pacemaker. Now, if it's a very small child, 3 months, 1 year, the body size is too small, and we may have to put in a epicardial pacemaker. The surgeon will do a sternotomy or lower sternotomy, xiphoid region, put in an epicardial lead, and that pacemaker is put in the rectus sheath. If the child is a little bigger, 5, 6 years old, with a slightly more body weight, we can get away with a single chamber pacemaker, one lead in the ventricle, that's it. If the child is a little bigger and we are being aggressive, we can actually put in a dual chamber pacemaker and give AV synchrony to this patient, which may be important. But there may be other problem. Here is a 8-year-old, so this is pretty straightforward. Epicardial pacemaker for neonates, infants, slightly older children, we could put in a ventricular pacemaker. Others will require a dual chamber, can be given a dual chamber. This is a slightly different problem. 8-year-old boy, seizures, loss of consciousness, history of elder sib dying suddenly. And this ECG is seen. This is something you should not miss. What do you see here? And I have put in a rectangle. The QT interval is quite long QT. And the T wave is labile, it is changing morphology. This is a very ominous sign. And the patient has long QT syndrome. Here treatment would, and when you start getting T wave alternance, that means it's very labile and patient can get R-on-T phenomenon and can get torsades. So you have to be very careful. 2 minutes and I will stop. Yeah. Yeah. Speak into the mic.
Hello. Yeah. So there is interesting learning point here that you should not always look at the number given by the computer.
Oh, yes.
Okay.
Yeah.
So you can see there the QT has been shown as 432, or maybe sir, just go on the previous slide.
Yeah. Even that is around
One more
440.
back. One more
That
back.
is a put I, here it is saying.
One more
showing
back, sir.
correctly.
One more back. Yeah, this one.
452.
You can see the corrected QT has been shown by a computer is 452 millisecond. But if you look at the ECG, the QT is
very long.
almost 700 milliseconds. So don't always look at the computer number. Huh? Okay, so you should
that
always
is-
look at the ECG and
Yeah,
calculate.
that is the
the
reason I put in these rectangles, that don't look at the numbers only, look at the ECG. And long QT syndrome, this patient was given beta blockers. Otherwise, during the episode, the patient started getting this torsades. So the treatment is we just put a atrial pacemaker, young child, only a atrial pacemaker, and then give high dose beta blockers. So the QT is still prolonged, and but the patient did not get any torsades. Over a period of time, things were okay. And some of these children, we have actually done carotid sympathetic, cardiac sympathetic denervation, either giving stellate ganglion block or doing a thoracoscopic procedure and doing sympathetic blockade. So let me stop here. 2 8-year-old children with syncope, different causes, different problems. You have to be able to discern each one of them. Let me stop here. We'll have a couple of minutes of questions and then go on to the next session. Dr. Vijay Bhai, Dr. Gaurav, any points? I hope you enjoyed this session. The initial part was very complicated, but every year I give a little more challenging, so you are stimulated to go back and read.
Prolonged QT syndrome, can we call congenital prolonged QT?
Yes,
In
yes.
that last
Yes,
AJ?
absolutely.
That is-
This patient has congenital long QT. There was one sibling elder child who had died suddenly
died.
at home. So, and we often get genomic testing done. It's fairly inexpensive nowadays. In 20,000 you can get full genome and you are able to pick it up. You can warn the parents for other children. You can screen the parents and their siblings for all this. So it is
So
important you
lifetime
should be.
he has to take beta blocker.
Yes, lifetime beta blockers. If despite that the patient is having problem, they sometimes require defibrillators also. But putting defibrillator in a young child is a big decision. It's not easy because the device will give shock. And at 8, 10, 12-year-old, you don't want the device giving shocks. So you have to try to manage it in other ways.
So some of the common pharmacological medicines here that increases the QT interval.
Yes.
And we commonly use this in the general physicians use it, and that create a problems.
Yes,
So how
yes.
can you enumerate?
So you have to be very careful in these patients, especially older patients who have been admitted in heart failure, respiratory tract infection, LV dysfunction. You are giving these patients multiple drugs, amiodarone, etc. Then you've started erythromycin. Then the patient gets diuretics because of failure and gets hypokalemia. These are potent factors which all come together and can cause QT prolongation, and patient can have ventricular arrhythmias. So you have to be careful, maintain the potassium between 4, 4.5. Don't give drugs like erythromycin or azithromycin, and also give drugs like levosulpride. They will all cause QT prolongation. So you have to be careful in these patients. And there is a website, you can just put in the drugs, there is a whole list of drugs, and your pharmacist should also be aware. In fact, in the West, when you have a prescription of 10 drugs, they will actually tell you these 3 drugs together can cause problems. Yeah, Hiren.
And the drug-induced prolonged QT, I mean, it sometimes create problem mainly by multiple factors together, especially in patients who are in ICU. And suppose they are in heart failure or something, and they have been given diuretics. A lot of Ditor has gone. Patient had poured almost 5-6 liters of urine. Potassium is now below 3.5. Once the potassium goes down to 3.5 and less than that, over and above patient is on drugs which can prolong QT, like azithromycin, as I told, or in fact sometimes ondansetron. It's a very commonly used drug. Ondansetron can cause significant QT prolongation, erythromycin, and hypokalemia. Both together, then it induces polymorphic arrhythmias. So that's why those patients who are in ICU, we should strictly monitor serum potassium. Hypokalemia is very dangerous for otherwise normal-looking patient.
Okay, I'll just quickly move on to the next topic. I'm going to talk about 25 years of EP in Gujarat. I'm here since 2001. It's 2026, 25 years we are doing this. When I came in back from the US, and I did my EP fellowship in Los Angeles, Cedars-Sinai. That time, number of EPs in Gujarat were 0. And there was no EP center between Delhi and Mumbai. People used to visit and do EP procedures. 3D mapping was non-existent. Mainly single chamber pacemakers used to be implanted. Dr. Milan Bhai used to put VDDs. CRTs were not there, and AICDs had just been introduced at that point of time. So that was completely, nothing was happening, virtually nothing. So, and the group established this cardiac arrhythmia management center, and we started doing EPS, ablations, 3D mapping, complex arrhythmias, device implantation of all clients, problems like lead extraction. And in the West, there are adult electrophysiologists, pediatric electrophysiologists. You take care of certain problems, you take care of ablations, or you take care of devices. Here, we have to take care of everything. From neonatal day 1, often in utero problem of the fetus, to 100 years of age, 100 plus years of age. So, we have to manage everything. So, EP ablations from 2001 to 2025, almost more than 4,000, and growing steadily growing. At this point of time, I was really getting burnt out. Thankfully, Dr. Hiren just joined me at that point, and I got some respite. I could take vacations, I could take a few days off. But when Hiren joined, that was a very crucial time, because what do you think happened here? Yes, absolutely, COVID came in. But then after these 2 years, even in these 2 years, we did a good amount of work. And after that, again, it's going up. So just let me give you an example. 5-year-old with palpitations, problems like this. And the QRS doesn't look normal. There are some Q waves in the inferior leads here. And when you do, patient is, you imagine 5-year-old going on beta blocker, verapamil, lanoxin, amiodarone. Would you give your child this? I mean, this is dangerous. And the patient was taken in the lab. He had a coronary sinus diverticulum. So the accessory pathway is inside the coronary sinus. So we have to target that, ablate. So during ablation, the pre-excitation is gone. Patient's QRS became normal at this point of time. He has delta wave up till here. After that, there's no delta wave. So pre-excitation is gone. This 5-year-old child who was on multiple drugs, multiple anti-arrhythmic drugs, drugs like amio, now never has to take medications again in his life. So patient is cured of his problem. And there are other extremes, 77-year-old gentleman with palpitations and occasionally having these kind of PVCs all the time, 1 or 2 different morphology, non-sustained VT noticed during this. So we go ahead and we had to ablate this. So it was ablated both from the right ventricular aspect. So the ablation catheter is going from IVC, RA, RV, through the tricuspid valve into the RV, and also retrogradely from the femoral artery, aorta, arch of aorta, ascending aorta, aortic valve into the LV, and that is where we ablate. This is the crux of the heart, posterior inferior region. We have to map the signals, locate it, ablate. After that, there are no PVCs, no NSVTs, patient is safe. But doing it in the conventional way is challenging at times, and 3D mapping is more useful. It's a way of mapping, especially for complicated arrhythmias, like patient comes with scar VT, sarcoidosis, coming in VT storms, there is LV dysfunction, or problems like atrial fibrillation or other complex arrhythmias in congenital heart disease. So here, you are able to map these scars better, locate the places, and these red spheres are where I'm ablating, so you can ablate better. This is a 30-year-old lady with palpitations, and this is the ECG which was recorded. It's a wide complex tachycardia. It's positive in V1, negative in 2,3 AVF. And the QRS here is a little positive, but here they are all QS, so a little unusual. And looking at the lead, V2 lead, you are seeing the R waves here. Is it coming up? Yes. Lots of R waves, regular fast R waves, and P waves, you have to look at the ECGs, less number of P waves. Sometimes the P waves are dropped. So more QRSs, less atrial activity, ventricle is the driver, it's a ventricular tachycardia. Once cardioversion was done, patient is in sinus rhythm. Sinus rhythm, but the QRSs are all looking odd here, isn't it? You are seeing R wave here in V1, V2, and then the R waves are gone. Patient doesn't have any other symptoms, no previous disease. What do you think is happening here? Lead 1 shows negative QRS. Lead AVL shows negative QRS. R waves are gone in the left-sided precaudal leads. The patient had dextrocardia. So dextrocardia with ventricular tachycardia. So situs inversus dextrocardia. Again, here you have to manipulate the catheters in one way, and your brain has to think in the situs inversus way. And sometimes it can become tricky. So we keep the fluoro image in such a way that we are looking at the live image, and then we flip, I ask the technician to flip it so it shows right-left inversion, so it looks like a normal heart. But when I want to manipulate, I have to manipulate the catheter in the opposite way. So this patient had that idiopathic LV tachycardia or fascicular tachycardia. This is 3D mapping being done. Localize the tachycardia in this region, the posterior fascicle, ablated. We do it with specialized systems. And this is what it looked like in real with the patient with situs inversus. But for our brain, which is geared to seeing things in certain way over 25, 30 years, we inverted the image, and here it is the normal image. So aorta, arch of aorta, through the aortic valve, into the LV basal posterior region. This is what it looked on the image, but this is what it was in the real life, ulta. So ablated, and after that the patient is doing fine. So we get all sorts of problems. This is not only for ventricular arrhythmias, it can be for other issues also. 40-year-old gentleman, recurrent palpitation, surgery at 16 months of age. There is a mid-sternal scar, but there are no papers, no documents. We don't know what the patient has undergone. Very rapid tachycardia. To get an idea, the patient was given metoprolol, AV node slowed down, and now you see more 2 P waves and 1 QRS. So atrial flutter with 2:1 AV conduction. We put in multiple catheters. The atrial flutter goes around the tricuspid annulus. So 3D mapping in post-surgical cases, etc., it's much better. We are able to identify things better, identify the scars because the patient has had previous surgery. This is the flutter going on, fast atrial activity. Ablation is being done and the flutter terminates. Patient is in sinus rhythm after that. And this is
I
curative.
would like to invite chair normal.
You will not have this problem again. So EP ablations, 3D mapping ablations, especially in complex arrhythmias. Pacemaker implantation, I told you initially only single chambers or VDD pacemakers used to be done. Once I came, started dual chamber pacemaker, putting in fixed active screwing leads. MRI compatible devices started coming in a decade or so back. And by default, everybody now gets MRI compatible devices. Certain people who are frail or young children, neonates, you had to put submuscular implant. Not subcutaneous, but below the muscle. And now we are putting leadless pacemakers. So over 25 years again, you know how I have this data? I have the report of every single EP and device procedure that I have done anywhere in the center or anywhere in the country since 2001, since the day one. So maintain your data well. At any point of time, if I want to know what I have done for this patient, I just need to go to my laptop, and 2004, I can get the report.
5 minutes remaining.
So pacemakers steadily increasing. Again, we had COVID here. And like I showed you, dual chamber pacemaker screwing leads. And high-end devices like CRTs or CRT defibrillators. Patients have survived more than 20 years, some of who have undergone 3 replacements for the battery depletion. So patient has a heart failure where 1-year mortality is 30% and 5-year mortality is 50%. Here patients have survived 20 years. Some have survived to heart transplant. And problems like this, patient had EF 15% rheumatic heart disease, and a CRTP was done. This is double valve replacement being done for this patient, and then a CRT was implanted and patient is doing fine. Patients with ventricular arrhythmias, coronary artery disease, LV dysfunction have undergone CRTD implantation, now get into VT storm, go ahead and ablate. Ablation on the right side, left side. The septum is often the place where anterior wall septal infarction, so we have to target it from both sides. Again, this is 3D mapping. This is the right ventricle, left ventricle. So we're mapping here, ablating on both sides. Single and dual chamber AICD. The earliest patient I had implanted in 2001 for CPVT is still doing well, is working. And youngest patient is a 16-year-old girl, survived VT storm. Now she's immigrated to Australia. Certain unique devices. We have left atrial appendage closures, explantations we have to perform sometimes, implantable loop recorders or leadless pacemaker. So this patient had undergone SVT ablation elsewhere, but landed up with a AV block. She has a narrow QRS, so you don't want to give a pacemaker which will end in patient getting a wide QRS. So we do conduction system pacing nowadays. Relatively normal looking QRS. Lead extractions are very high risk procedures. This is ICD with patient with malignant family history of sudden cardiac death. 4 uncles, one had died, one uncle on ICD, and then she developed an infection. So we had put in a different lead also, But this is a very gruesome procedure in fact. We have to go through fibrosis calcifications occasionally using special tools, laser or cutting cauteries, advance it over the lead, get into this region. Patients can land up with tamponades, so we have to have the surgeon always ready to take the patient in surgery if required. We go
2 minutes
gradually
remaining.
and have isolated the lead and then extracted the lead in totality. So the patient is without hardware, but then we still have to protect her. So I had to implant her lead device from the right side. 71-year-old patient, permanent atrial fibrillation, slow ventricular rate. Chronic kidney disease, likely to require a fistula on the left arm. Warfarin, right lower limb poliomyelitis, right upper limb contractures. So we have very limited options here. Patient requires a pacemaker. We cannot put a regular pacemaker. So what we've done here is implanted a lead-less pacemaker. No leads, but the sheaths are put in and the device is implanted. It's prongs which hold on to the myocardium, and that's it. Patient is going home with an alien capsule, alien implant in the heart. And patient has just had a 4-month follow-up. This is leadless pacemaker which is implanted. For patients who are atrial fibrillation, we do AF ablation, but they still may have bleeding on NOACs. So LA appendage closure or LA appendage occlusion is a procedure for these patients, and we've done a few of these. So journey since 2001, after establishing the cardiac arrhythmia management center, we have been steadily doing these complex arrhythmia, VT, AF ablation, regular pacemakers since ICD since 2001, CRT implants since 2002, patients surviving more than 20 years and going to transplants, conduction system pacing and LA appendage occlusion, leadless pacemakers now. So it's a steady journey, and I'm very happy to have Hiren with me. We have young blood to rejuvenate the system. Now there are almost 7 to 10 EPs in Gujarat. We have 2 here. We regularly do more than 250 cases, 3D mapping, complex arrhythmias, more than 50 per year, and all sorts of devices. Let me stop here and thank you all for the support you've given over the last 25 years of the journey.
Hello. Now Dr. Ian Kevade will be presenting the case.
The students and his faculties were interviewed.
So I would like to talk on prevention of sudden cardiac death. I mean, maybe from physician point of view, how can you help us out for saving patients' life? So I just try to give some guidance on that. I don't have any disclosure. So we know recently, I mean, not now recent, it is now 4 to 5 years history that we are documenting a lot of young deaths. Celebrities are dying, which we are looking into the newspaper, but a lot of layman people are also dying because of sudden cardiac death, which newspaper does not take care of. But if you see at the number over, a lot of young deaths are happening. So, see, it's a most challenging presentation of CV disease because we may not have much time there to save patients' life. So it is very important that we detect such cases before the event happens so that we can take action on time. Millions of deaths are happening. The problem is that the prognosis of out-of-hospital cardiac arrest remains very poor, and there is less than 10% survival. So if the cardiac arrest has happened outside the hospital, there is 90% chance that we are not going to, or we will not be able to save the patient's life. And problem is that it is sudden, rapid, and it gives very limited time or opportunity to intervene and save the patient's life. And therefore, the strategies should be focused on trying and identifying them very well ahead of the sudden cardiac death events. So we should recognize that these patients are at risk of getting sudden cardiac death and has to go for a specific treatment before they actually land up in sudden cardiac death. So point number one is those patients who are having ischemic heart disease. A case example, 67 male, old interval MI, PCI to LAD, NIHA class 2, and had a palpitations and pre-syncope. And this was the ECG. So when the patient had an OPD visit, the ECG was having sinus rhythm, and we can see there are Q waves into the anterior chest slits. So it's a Q right bundle branch. It is known as QRBBB. And this patient is definitely having interval scar. And if this patient tells us that he had a history of palpitation or he had a history of pre-syncope and syncope, we may not have documented arrhythmia till now, but we should give enough pressure to find out that there might be something happening to this patient. And what may be happening? It may be happening like that. So if you don't recognize it early, patient can come with this ECG later on. And ultimately, what is this? It's a monomorphic scar VT. And luckily, this patient reached to the hospital in a stable situation, cardioverted, got the sinus rhythm back. Obviously, we all start with amiodarone for this patient for termination and for prevention of, again, an arrhythmia. But if we want to save the life of this patient from further episode or future episode, amiodarone is not going to save the life. There are a lot of studies which tells that amiodarone does not improve the survival in monomorphic scar VT in ischemic cardiomyopathy. It might reduce the chance of getting repeat episodes. But if you want to save the life of this patient, definitely we should go for implantation of an implantable automatic defibrillator. So all these patients should have AICD in the body to save the life when the next episode happens. So ICD therapy is always recommended for those patients who have history of VTVF, especially after 48 hours of MI. Those patients who have a polymorphic VT in the 48 hours, within 48 hours of MI is usually a primary arrhythmia, primary VT because of ischemia. And once the ischemia goes off, they are less likely to get a monomorphic VT in future. So these patients are not at the indication of having ICD. But beyond 48 hours, having monomorphic VT, patient should have an ICD. Those patients who have, in fact, ejection fraction less than 35%, that don't have VT till now, as per the SEC-AHA guideline, this patient should have an AICD implantation for primary prevention against the sudden cardiac death because of the VT. And we go for a 3D mapping catheter ablation for these cases when they have a repeated VT after ICD implantation and needing a lot of ICD therapies in form of ICD shocks. We go for a 3D mapping, find out the scar, modify the scar, and get rid of that re-entrant circuit monomorphic scar VT. Point number 2 is again on ventricular tachycardia, but here they are idiopathic, like 25 male with structurally normal heart, normal angiography, had palpitation, a young lady, normal echo, normal angio with palpitation, and has presented to us with this arrhythmia. So this arrhythmia is a left bundle morphology with inferior axis, or it might be right bundle morphology with superior axis. So these are idiopathic arrhythmias in a structurally normal heart patient. They are monomorphic. They are coming from Purkinje system, either a posterior fascicular VT or it can come from the outflow tract VT. So that's why VT is not should be treated as equal for all the patients. So we have to go in depth into the VT and find out from where the VT is coming, whether it is idiopathic VT or whether it is a VT because of structural heart disease. So these are the two patients who had an outflow tract VT and a posterior fascicular VT in a structurally normal heart. Here, ICD is not recommended. So ICD is not the treatment of choice for prevention of sudden cardiac death. Here, the catheter ablation is the first line treatment for this patient. And once you do catheter ablation, 95 to 98% chance of getting permanent cure from the arrhythmia, and patient is free from the disease forever. So outflow tract VTs, fascicular VTs, papillary muscle VTs, and VTs coming from annulus like mitral annulus, there catheter ablation is the first treatment of choice, not the AICD implantation. Point number 3 is PVCs. So if the PVCs are idiopathic PVCs, which are idiopathic PVCs? Again,
Very good, Dr. Kiran Bhai. Now there is one question in presence of aortic stenosis, and when there is the patient is syncopal problem and has some simultaneously electrical imbalance. So how can we differentiate and what is to be done at that time?
See, I receive this question every time when I present hypertrophic cardiomyopathy, that is LVOT obstruction and cardiac death. So it is very important that LVOT obstruction is a mechanical problem, and that mechanical problem leads to heart failure symptoms. And arrhythmias are an electrical problem that happens because of fibrosis into the muscles, and that leads to cardiac death. So both are different. So when a patient is having LVOT obstruction that is significant, and if patient is significantly symptomatic in spite of taking drug for heart failure point of view, we should always go for a alcohol septal ablation, which Dr. Milanchak do frequently, and he is having highest number of alcohol ablation in India as a country. So those patients who have significant LVOT obstruction in spite of giving drug and having still heart failure symptom should go for therapy for that obstruction in form of alcohol ablation, or if they are not fit for alcohol ablation, for a surgical therapy. So that is going to reduce obstruction and that is going to reduce the heart failure symptoms, but that is not still going to prevent the sudden cardiac death from electrical problem. So ICD is always recommended for electrical problem for prevention of SCD.
The other point which Dr. Vijay Bhai was probably saying, aortic stenosis. So aortic valve stenosis and patient gets syncope, it's very ominous. Because with an obstructive lesion and patient get in syncope, high chances of sudden cardiac death. Here, nothing else will work. You have to relieve the obstruction, so patient will have to undergo either TAVI or aortic valve replacement. Dr. Gaurav,
I'll say we have seen many patients of such arrhythmias and sudden cardiac death in our recent times. But we have also seen some of the patients whom we required pacemaker insertion. Still, we need to extract the pacemaker just because of some allergic reaction. If that is happening, what can be the...
So in the vast majority, if we need to extract, it's due to infection. Allergy is very, very rare because these are inert metals from which it is made. Very rarely, now this is, I am talking about 1 in a million cases. If there is actual allergy to the metal, we can ask the company to make gold pacemakers and the patient will get a gold pacemaker. It has to be made and brought. So allergies are very rare, more common is infection. 1 in 100 is in good hands, in good center with good practices, generally the infection rate is less than 1%. If it happens, so because we get a lot of cases from elsewhere who are infected, we have to extract. Sometimes it's simple, sometimes very complicated. It's never a simple extraction when we take the patient on table because any time there may be disaster, so we have to be prepared in all ways for all patients. If we are able to get away with it easily, well and good. Otherwise, it can be, we have to use special tools to extract.
So what is the lifetime if machine is kept defibrillated? Now, how much time and what care he should take at that time?
The defibrillator, implanted defibrillator, the device battery lasts around, nowadays, between 8 to 12 years. So it's like any other pacemaker. For the first couple of weeks, we have to avoid infection. For first 6 to 8 weeks, avoid jerky movements of the arm to allow the leads to get fixed. And then we have 6 monthly checkup for a defibrillator and CRT. Once a year checkup for pacemaker where we come to know how the device is doing, how what are the arrhythmias if the patient has had. And we get the battery life also. Once it starts depleting, less than a few weeks remaining, we go ahead, take it out, new one goes in. So it's a pretty standardized way of doing it. Here in any point?
Yeah, I think with any device, whether it is pacemaker or whether it is but we have not gone for it because people told that, okay, you will not be able to use mobile phone, you will not be able to use any electrical switch in the home. You just have to avoid, you have to keep yourself 6 feet away from electric current. And that was the reason we were not going for a pacemaker. But truly speaking, after any device, a patient can do whatever we usually do routinely. Everything can be done by the patient. There is no restriction
So
usually.
the way I put it, generally I explain to the patient relatives, this device will give you freedom. Freedom to go alone outside, freedom to travel all over the world. If you didn't have this device, somebody would have to be with you always, and you could
5
still
minutes
have
remaining.
problems. Yes.
For the HOCM, if we do alcohol septal ablation, then it will produce the scar, right? So invariably we have to do put device in that patient, right? Or it is not so?
No, you are right, because anyway alcohol septal ablation is what? It is actually an iatrogenic myocardial infarction which we induce in a particular specific area which is hypertrophied and which we don't want. So we are going and occluding that artery and creating infarct so that that muscle gets infarcted, thickness goes down, and that's how it improves the way, I mean that outflow obstruction area, that area will get widened. But definitely it is going to induce a scar, and it can increase the risk of scarvity in future. So, but we don't have clear-cut number that it increases by this much. But definitely those patients who are already fitting for the, and that is the reason I told alcohol septal ablation or surgical septal resection is not the option of putting an ICD. ICD is the primary therapy for prevention of sudden cardiac death, and septal reduction therapies are mainly for heart failure point of view.
So what Dr. Hiren said, all these PTSMA or surgery will relieve the mechanical problem, but the pathology is there. Patient can still get ventricular arrhythmias, still needs to be on beta blockers, still may require defibrillator. So that is an independent evaluation.
And as you showed that more than 15% of scar needs that device. So if the scar volume is less than 15%, then we can avoid also, right? Or it is.
You have to individualize.
Yeah. It's not only scar actually. So that's why we calculate a lot of things. Na? Age, family history, NSVT, exercise-induced hypotension, or patient himself had a history of syncope which is unexplained, LSIs, LV ejection fraction, apical aneurysm, late gadolinium enhancement, then genetic mutations in some of the patients. So there are multiple factors, and we should take it as a whole rather than just a single factor.
So last question by Dr. Subhash Bhai.
Yeah, what is the coupling interval you said which can be dangerous? Is there just apparently long or short, or is there any specific value?
So 250 millisecond coupling interval is classically defined as short couple. Now the problem is that coupling interval short couple interval, PVC, creates problem because they fall on T wave, correct? But now the problem is that if we have given medicines which have prolonged the QT, or patient had a hypokalemia and prolonged QT, hypomagnesemia and prolonged QT, drug-induced prolonged QT, the same PVC which was not falling on T wave, though it was not short couple, now it falls on T wave because T wave is wide, and that can again become a dangerous. So it is not always an interval, it is more important interval plus whether it is falling on T wave or not. That is very important.
I think you have to catch Dr. Hiren Bhai once he steps down. We'll have to wind up this session.
Pharmacotherapy for obstructive cardiomyopathy, HOCM.
I think we'll take the question downstairs. Thank you, Dr. Gaurav. Thank you, Dr. Vijay. Thank you, everybody. I hope you enjoyed.
So for the next session, I would like to welcome as a chairperson Dr. Alpesh Prajapati, Dr. Haresh Acharya, Dr. Harshad Javeri, Dr. Mukund Patel, Dr. Parth Parikh, and Dr. Ramesh Advani. As a moderator, Dr. Marmik Brahmbhatt, Dr. Prakash Patel, Dr. Tejas Karamta, Dr. Vijay Gadia, Dr. Yashpal C. Makwana. As a panelist, our own Dr. Urmil Shah and Dr. Dhaval Naik, if he is there. Thank you.
So, good morning, everyone.
This is a clinical trial in cardiology 2025, part 2. All these trials have been basically taken from big conferences like ACC, TCT, and from big journals, international journals like NEJM, Circulation, or JIC. So they are very relevant, and this may change our day-to-day practice. I do not have any financial disclosure. We all know that risk stratification for coronary disease has been changing, and we know that LPA is a very important addition to all this thing. Inflammation also is thought to be the marker for the cardiovascular risk factor. And this was the big analysis which was done by the UK Biobank and MESA, which included inflammation marker interleukin and LPA. And they try to find out whether it has some correlation with the cardiovascular outcome is not there. And as you can see here, the higher interleukin level were associated with more BMI, blood pressure was high, and high CRP. And LPA independently also has found to be a risk factor for cardiovascular event. And when you combine both the things, the events were more worse. So this may be a new marker, interleukin, and maybe LPA as far as cardiovascular risk prevention is concerned. We normally come across when a patient comes to us with say chest pain or a breathlessness, we recommend that treadmill test. This is the standard way of doing it. Sometimes you may come across nowadays patient who has already undergone a CT angiography. Now the purpose of this study, this was a PROMISE, which was a very large study. Patients were included in 2009, 2014. They have been followed up for almost 10 years. 10,000 patients were included. The primary purpose was to find whether initial test as CT angiography is better or initial test as a stress testing is better. And this study clearly shown that both are almost equivalent. So you can, and slightly better towards the CTA. So calcium CT angiography may be a slightly better option if you want to have long-term prognosis in this group of patients. The primary reason is you may come across a small plaque which can be picked up, which is not picked up by the stress testing, because stress testing is more of when there is a severe disease, stress test is usually positive. So both are equal, and CT angiography done to see a long-term outcome also is not a bad idea. Similarly, another study where age between 50 to 64 were taken, CT angiography was done, and primarily to find out whether the long-term outcome as far as MI is concerned can be diagnosed by this. As you can see here, it's clearly shown that if CT angiography is showing some calcific or a non-calcific plaque, the chances of MI in this group is definitely high compared to non. So as far as risk stratification concerned and the primary prevention strategy also, we can use a CT angiography after this study. Many a times we do come across a patient who has undergone primary angioplasty and patients are being followed up. Some patients may not take the statin, some patients may take statin. This is a study which was done at the end of 3 years. OCT was done just to find out whether the non-significant plaque which was there at the time of intervention has increased or not. And as you can see, those who are having LDL in the range of less than 50 versus in the range of 87, there were more chance, and it was an independent predictor for a new atherosclerosis, meaning by a new development of plaques was much high if the LDL was not nicely controlled. Salt substitution in stroke study was a nice study which was done where a sodium salt was replaced by the potassium salt in a patient who is having stroke, and what has been found that recurrence of stroke and all-cause mortality was significantly down if the salt replacement has been done from sodium to the potassium salt, and there was no high chances of increase in hyperkalemia. So this is a good study. Another study which was there with the semaglutide, and that is a CagriSema, which is a combination of semaglutide and cangrelitide. The primary purpose of this study is to know the long-term outcome. The redefined study is already going on. The sub-analysis clearly shown that if you reduce the weight by this molecule, the blood pressure control is nicely achieved, okay? And you may have a better control of blood pressure, and that was the reason you can see about 5 to 7 millimeter of blood pressure can be. And this may be a useful because it can also reduce the long-term cardiovascular benefit also can be achieved. SOUL was a very important large study which was done. It was an oral semaglutide, 3 milligram, 7 milligram, and 14 milligram titrated in patient who is having diabetes and coronary disease, so and the kidney disease. The purpose was whether the kidney outcome and cardiovascular outcome goes down with this therapy or not. So 3-point MACE in the form of cardiovascular death, myocardial infarction, and stroke were taken into consideration. And a 5-point kidney outcome also was monitored in this group of patients. And as you can see, reduction in HbA1c, obesity was definitely there, which was expected of this molecule. But overall, if you see, the 3-point MACE was significantly low by using this molecule as far as both kidney and cardiovascular outcomes were concerned. So it is now in a patient who is having high creatinine, this molecule also has shown to improve both cardiovascular and renal endpoint. SELECT was the study which was done, already passed. It was presented before 2 or 3 years. This was a separate analysis which was done primarily to see whether heart failure readmission is reduced with this therapy. And these are a long-term follow-up patient. These are the obesity patient without diabetes. And as you can see, if this molecule has been given in the form of subcutaneous once-a-weekly therapy, semaglutide, the admission for because of cardiovascular problem has gone down. So along with the mortality reduction, the additional benefit in the form of reduction of hospital admission also has been achieved with this. Semaglutide and walking capacity increase in type 2 diabetes. We know that type 2 diabetic patients have a peripheral vascular disease, they have obesity. So if this molecule has been used, the purpose was to see whether they increase the walking distance. And as you can see, significantly this molecule, along with the other parameters of diabetes and obesity reduction, also has increased the mean walking distance. So this was also found to be positive. And the ABI also was found to be reduced with this molecule. So it was a good therapy to be given if the patient is having obesity and peripheral vascular disease. SURMOUNT was the trial where comparison of tirzepatide and semaglutide was done, primarily to see whether the weight reduction capacity is better with this molecule. And as you can see here, it was definitely high with the tirzepatide compared to the semaglutide. So compared to, as far as only weight reduction is concerned, the beneficial effects are much more with the tirzepatide compared to the other molecule. This was a study where tirzepatide was compared to the cardiovascular outcome. This was a very big study, surpassed CVOT study. The primary purpose was to see, we all know that other molecule which is already in market, like liraglutide, has been found to reduce the cardiovascular outcome. So what has been done is this molecule was compared with the liraglutide, which is a cardiovascular safe or molecule which is there. As you can see, both molecules have caused reduction in the HbA1c. Body weight index also has gone down. And when it was compared with the liraglutide, it has been found that the cardiovascular outcome, heart failure, and myocardial infarction was same. Meaning by the beneficial effects or cardiovascular outcome benefit which was there with liraglutide also is there with the this molecule. So this was a big study, 13,000 patients, and major there is no side effects. In type 2 diabetic patient, when tirzepatide was given, it is not inferior to liraglutide. So cardiovascular outcome benefits also has been established nowadays with this molecule. When you give a tirzepatide and stop tirzepatide, this is the study which was done. Those patients who has already achieved a good parameter in the form of blood pressure reduction or a diabetes, and this molecule has been stopped. So what has happened is, as expected, the waist circumference has gone up again, the obesity, the weight also has gone up in this patient. What about the cardiovascular benefit which has been achieved? As you can see here, the HbA1c which has gone down with the reduction of obesity has again gone up. Fasting sugar level also has gone up. The blood pressure reduction which was also achieved by weight reduction also is now going up. And diastolic blood pressure also is going up. So this was a study that if weight reduction and cardiovascular parameters nicely has been achieved, but if you stop this molecule, obesity is beginning and all other parameters are, which is found to be beneficial with the obesity reduction also was regained. This is a triple hormone therapy. This is a good molecule, which is a retatrutide, and which is a good obesity molecule with a triple hormone receptor. The study which was published was obesity and osteoarthritis. And what was found that if this molecule was given, of course, weight reduction was there, but definitely pain as far as knee problem is concerned has gone down significantly. This is a new oral small non-peptide GLP agonist which is going to come in the market, and this is specifically studied for a type 2 patient. All the patients were being followed up for about 40 weeks. HbA1c was in the range of 7 to 9, and as you can see at the end of 40 weeks, there is a significant reduction, or most of the patient could achieve the HbA1c nicely. So this is a non-peptide, and it is likely to cause more side effects, so this also may come in the market in the later on. As far as hypertension is concerned, aldosterone dysregulation is an important cause for resistant hypertension. MRA will block this. Baxdrostat is a new molecule which is highly selective and very potent aldosterone synthase inhibitor, and this was being studied in a patient who is uncontrolled or a resistant hypertension. As you can see, these patients were compared with the placebo, and 1 milligram versus 2 milligram has been compared. And as you can see, almost 9 to 10 millimeters significant reduction in blood pressure has been achieved. This was a primary outcome at the end of 10 weeks, at the end of 12 weeks, and achieving of reduction of the target blood pressure of less than 130, as well as the 24 hours and nighttime blood pressure reduction also has been significantly achieved by this molecule. The safety data has been established. There was no major chance. Of course, there are some chances of hypotension, dizziness, or hyponatremia or hyperkalemia, but that was not very statistically significant. And if you look at the serum aldosterone concentration in this group of the patient, it is found to be very good. So mechanism-wise also it is good, and blood pressure reduction also has been very nicely controlled. So this is the summary of the study. Almost 8 to 10 millimeter blood pressure reduction at the end of 30 weeks in all pre-specified subgroup, and it is very well tolerated. And now this molecule is going to be available in Ahmedabad, in India rather, in the near future. The similar molecule, which is also another aldosterone synthase inhibitor, has been used for those patients who are having 2 to 5 antihypertensive medicine, which was done. And as you can see here, all the parameters in the form of blood pressure reduction, 24-hour blood pressure reduction, diastolic blood pressure reduction has been significantly achieved with this molecule, and there was also no major side effects. But 50 to 100 milligram has not found to be having additional blood pressure reduction, so 50 milligram may be the standard dose for this molecule. Zilebesiran is an IV, it is a subcutaneous molecule which has a lasting effect for 6 months. It has been used as an antihypertensive therapy. This was the previous study which has shown that at the end of 6 months, the beneficial effects has been persisted. This was the study which was specifically designed to look into this thing detailed in the form of EGFR less than 45, EGFR more than 45. A primary outcome, as you can see, the office blood pressure has significantly gone down. It has been maintained over the end of 6 months. So it is going to be an important molecule. Safety profile also has been nicely achieved. And CVOT outcome study is going to be there. That is a Zenith study. We are also a part of, our center also is a part of this study, just to know the outcome, because outcome is very important in all these patients. BP Road is a study where aggressive blood pressure reduction has been compared with a routine in a patient who is having diabetes. It was almost 12,000 patients across China. And as you can see, there is a definite advantage of aggressive blood pressure reduction which has been found in this study. Elderly patient, also aggressive blood pressure reduction versus not that aggressive blood pressure reduction has been. And here also the beneficial effects are also been found. As you can see, the benefit are there with aggressive reduction. Of course, it is at the cost of some side effects, maybe in the form of syncope or maybe in the form of kidney dysfunction. This was a meta-analysis which was done including all the patients. And as you can see here, there is almost, or they were been followed for about 3 years, and significant risk reduction has been achieved, but at the same time, there was little bit more side effect as far as renal or hyperkalemia parameters were concerned. Bempedoic acid is a standard molecule which are using. This was a clear outcome data sub-analysis in the obesity patient, which was done separately. And as you can see, those patients who are having BMI more than 30, this molecule has been found to reduce the CRP and also has been found to reduce the cardiovascular outcome. So in the obesity patient, bempedoic acid can be given with the additional reduction of CRP in this group of patient. This was a very nice study which was done. That was for the primary prevention. The patient is not having MI or stroke. They may have a coronary artery disease found on CT angiography, or they may have a diabetes. And these patients have been followed up. The primary outcome as far as new cardiovascular death, myocardial infarction, and stroke was significantly reduced at the end of long term. So this is the primary prevention study using the PCSK9 inhibitor. And as you can see separately, myocardial infarction, death, everything has been also found to be significantly less by this. So this is the first molecule, which is a PCSK9 inhibitor, and if you reduce the LDL by less than 45, the chances of new development of stroke or a myocardial infarction can be reduced significantly in this group of patients. Secondly, this was the sub-analysis of the patient, which was a 4-year study. Those patients who are having ischemic stroke, they have high chance of development of recurrence of ischemic stroke, and PCSK9 inhibitor was used. And as you can see, if you aggressively reduce LDL in this group of patients, you can always reduce the chance of development of recurrent stroke. So PCSK9 inhibitor used for recurrent prevention of stroke. Now the LDL should be less similar to the cardiovascular guideline, should be like this. Oral PCSK9 inhibitor also is available. AHA 2025 has published the data that is an ensilatide, and this was primarily used to as addition to the statin, whether the additional beneficial effects as far as LDL is concerned. And as you can see here,
5 minutes remaining.
there is almost 52% reduction which has been achieved with this molecule. Another oral PCSK9 inhibitor also has been developed, and this is also showing almost similar result. As you can see, at the end of 12 weeks, almost 50% reduction of LDL can be achieved by this oral. So oral PCSK9 inhibitor may come into market. Of course, we don't have the outcome data at present. This is a very interesting data. This has been done. That is an angiopoietin-like protein 3 inhibitor. And what it basically does is it acts on a molecular level, a genetic level, and once it is given the lifetime, you have a reduction in the LPL level. So that is what the purpose of this study was that. Strong pulmonary embolism were compared with the heparin and a mechanical thrombectomy. And what has been found is if you do a mechanical endectomy, the RV-LV ratio has been significantly improved. At the same time, the recurrence of pulmonary embolism has been found also to be much less. So this was also a positive study where a mechanical device or removal of thrombus in a pulmonary embolism has found to be beneficial in this group of patients. Another important study which was done is extended DVT prevention in a provoked venous thrombolism. So normally we stop 3 months oral NOAC in all this patient where there is a provoked pulmonary embolism. And as you can see, if you extend it for 1 year with the low dose of apixaban, it has also found to be very beneficial. This was a nice study. We do come across a patient who is having prosthetic valve thrombosis, and normally the standard way of treating is we give an Elaprase, and what has been found is tinectaplase also is an important molecule which is available. So this was a comparison which was done with tinectaplase in a mechanical valve thrombosis. This was a study which was done from India, and the primary efficacy point was similar. That means instead of using tinectaplase can be used in the same manner like the standard way of treating, and complete thrombotic or even slightly better by using this molecule. Lastly, I will touch upon this mavacamtan. Mavacamtan, yesterday I talked about this molecule. This study, this was recently published in non-obstructive HOCM. It is not found to be beneficial. So that was the message I wanted to give. Mavacamtan is the molecule whenever there is an obstructive HCM and non-obstructive HCM, it is not useful. A similar molecule also has been done, same group of molecule, which is an efficamtan, which has been compared in this study with the metoprolol monotherapy. In the previous study with the mavacamtan is known as the add-on therapy. This is a comparison of beta blocker with efficamtan in a patient who is obstructive cardiomyopathy. And as you can see at the end of 24 weeks, there is significant advantage of using this molecule. At the same time, the obstructive reduction also, mean reduction in the alveotic gradient also has been achieved significantly, and NT-proBNP NOAA class also has been found to be much better. So this is also a molecule. Of course, it is not available. Mavacamtan is available, but this may come in the future. And this trial was positive, and this was comparison with the beta blocker. Zenith was a study where sotatercept, which is a very important new molecule as far as pulmonary hypertension therapy is concerned. We know that there are so many molecules which have come in the recent time. Now, this molecule is which is acting on a very different pathway. It is not acting on the standard endothelin or other pathways. And this was the very nice study which was published, which is a phase 3 study. And as you can see, time to the major cardiovascular outcome has gone significantly down with this. And the major important thing is, look at the p-value. It is almost 60% reduction in mortality and morbidity by using this molecule with the p-value of 0.0001. So it is a very effective and very important molecule which may come in the market. Of course, it is slightly costly. It is going to come in the market maybe after 2 or 3 months. As you can see here, the mortality has gone down. The need for the lung transplant has also gone down, and PH later hospitalization also has gone down. Of course, there was, and this trial was primarily prematurely stopped because there was significant advantage of using this molecule. Now, the same molecule has been used in Hyperion study, where early it was started. In the previous study, it was started quite late. This was early, within the 12 months of diagnosis, primary hypertension is started. And as you can see, sotatercept has got significant reduction as far as outcome is concerned, and no major side effect, except some of the patient has epistaxis and telangiectasis. Otherwise, it was a very safe molecule. So I will end here. There are so many other studies also were there, but because of time constraint, I could not take that. And if there are any questions, I'm happy to answer. Thank you very much. Hello.
I invite Dr. Dhaval Nayak for his talk. Okay, sorry. Yeah. I invite Dr. Milan Chak, sir, for his talk on CRM, cardiorenal metabolic syndrome. What should we know? Dr. Chak, sir, everybody knows.
Dr. Dawalbhai was busy somewhere, so he will take later on. So just switching off the topic. So I'm talking about CKM syndrome, cardio-kidney metabolic syndrome. I think you are aware about this. How confident are you to diagnose this, staging it, manage it? How many are totally confident about its pathophysiology? So few are there, so okay, this should be useful lecture. So I'll start with the clinical case. Mr. Abi is there. Dyspnea since 6 months and leg swelling since 1 month. He presented with 65, he's a 65-year-old man. He's diabetic, hypertensive since 15 years, non-smoker, no family history of ischemic heart disease. His height is 170, weight is 88, almost constant weight around that since 25 years. So BMI is around 30. Pulse is 80, BP 150, 80, bilateral edema pit of legs. Investigation shows total cholesterol 180, HDL 30, triglyceride 200, LDL 120, sodium potassium normal, creatinine raised 1.78, leading to GFR of 42, UACR 200, HbA1c 8.4, NT-proBNP 700, CT coronary artery calcium score 20, echo shows LVH, LVA 50, and suggestion of diastolic dysfunction. LA volume is high. More than 35, 34 is abnormal. So diagnosis is what in this patient? Obesity is there, of course. He is diabetic, he is hypertensive. He has CKD stage G3BA2, so that is by KDIGO heat map, it is very high risk in the red category. And he has heart failure with preserved ejection fraction. So this is his diagnosis. Now, what is this patient's CKM stage? We'll discuss what is CKM syndrome as such and what is its pathophysiology. Why to think about it? Diagnosis I made that it is diabetes, hypertension, obesity, and let us just treat it. But why should we think about that he has CKM syndrome and how to treat? So let us define. See, what is CKM syndrome? AHA actually has given good advisory in 2023, and they are going to publish guideline for managing CKM syndrome next year, or this year rather. So it's a novel health disorder which reflects pathophysiological interplay of excess or dysfunctional adiposity. It is not just adiposity, it's a dysfunctional adiposity. There is metabolic derangement, there is kidney dysfunction, there is cardiovascular disease, and that leads to multi-organ dysfunction and a high rate of adverse cardiovascular outcome. So CKM syndrome results in excess morbidity and mortality, which is beyond the sum of its parts. Like it is not just mortality of diabetes plus hypertension or obesity. It is some multiple of that. Metabolic risk factors cause end organ damage of heart, kidney, and vasculature. And mechanism of end-stage organ injury are hemodynamic, metabolic, inflammatory, and fibrotic, and they are almost permanent. If you know about premature mortality in CKM syndrome, see, severe obesity by itself, if somebody's BMI is 40, then survival is reduced by 8 to 10 years. If your diabetes, which is not well controlled, your survival is reduced by 13 to 14 years. And if you have CKD stage 4 compared to EGFR more than 60, life is reduced by 20 years. This is general statistics. But 10-year mortality rate of diabetes is 7.7%, CKD is 11%. But if you go both diabetes and CKD, then your patient is going, 1/3 of the patients are dead by 10 years. So it is really a serious problem, and it is a compounding effect. If you have no kidney disease, this is all-cause mortality in patients with diabetes. If you have no kidney issue, then 10-year mortality is 11%. But if you have albuminuria, then mortality is double. If you have impaired GFR, mortality is tripled. And if you have both albuminuria and reduced GFR, then mortality is almost 5 times. So again, this is a real serious problem, and we should try to prevent progression of this patient's CKD when patient has dysmetabolism and diabetes. So let us try to understand pathophysiology. See, visceral and ectopic adipocity. Adiposity of just subcutaneous tissue is different than visceral and ectopic adiposity. We have to remember that fat is not inert. It is an active organ. It releases adipokines. And there are, in healthy people, all of us have fat, is required also. So in adipose tissue, actually it secretes, it is an organ, which is an active organ, and it secretes adipokines. There are 3 types of adipokines, and domain 1 adipokines are actually useful, and in healthy people, majority of secretion is of type 1, or domain 1. They are cardioprotective, they are anti-inflammatory, and they are natriuretic. And domain 3, which is a bad kind of adipokine, its secretion is minimal in normal, healthy people. Domain 3 adipokines are pro-hypertrophic, pro-inflammatory, and anti-natriuretic. So they are minimal in this, and that's why people are healthy. What happens with ectopic or visceral adiposity? Ratio is reverse. Domain 1 adipokines, which are good adipokines, they are markedly reduced, and there is marked increase in adipokine 3. So there is pro-inflammatory, hypertrophic, and anti-natriuretic adipokines are very high in visceral adiposity patients. What does that lead to? It causes more inflammation, more endothelial dysfunctions, hypertrophy and fibrosis, cardiomyocyte dysfunction, sodium and water retention, that leads to plasma volume expansion, and that leads to systemic and pulmonary hypertension. So this is a deadly combination if you have got visceral adiposity. So in healthy people, and actually in healthy people, we know that it is cardioprotective and it causes natriuresis, so there is healthy circulation. But as soon as patient has ectopic adipose inflamed tissue, which is dysfunctional, ratio of secretion of domain 1 and domain 3 is reversed. It leads to hypertrophy in the heart, sodium retention by kidney, and fibrosis in both these vital organs, and that leads to heart failure with preserved ejection fraction. Our GLP receptor agonists actually act here on domain 3. What are these visceral adipose tissues where this can be? It can be in systemic, it can be between the muscles, it can be in the fatty liver, it can be in omentum, locally it can be perivascular fat along the all blood vessels, pericardial fat, epicardial fat, which can be, it can be in the myocardium also, between the myocardial cells, or it can be in renal sinuses also. So when it is a systemic, it causes metabolic dysfunction. When it is pericardial fat, it leads to obstructive coronary artery disease, atrial fibrillation, and heart failure. This is important diagram. See, we have got excessive dysfunctional adipose tissue that actually secretes this domain 3 adipokines that leads to inflammation, oxidative stress, insulin resistance, and vascular dysfunction. That leads to hypertension, dyslipidemia, metabolic syndrome, and diabetes. This ectopic tissue, ultimately this leads to fat deposition in the liver also, leads to ectopic fat deposition in liver leading to fatty liver and then metabolically associated steatotic liver disease. That is also dangerous. This can lead to heart, causing atherosclerosis, myocardial infarction, myocardial remodeling, fibrosis, and cardiac dysfunctions. Goes to kidney, leading to glomerulosclerosis, kidney fibrosis, glomerular gets fibrosed, and there is chronic kidney disease, which leads to neurohormonal activation, RAS activation, plasma volume expansion, which again leads to heart failure with preserved ejection fraction. So it's a vicious cycle. Each organ is affecting other organ. Heart, kidney, liver, and metabolism, and insulin, and pancreas, everything is interrelated. So acute and chronic dysfunction in the heart, kidney, and metabolic system may induce dysfunction in the other. Each dysfunctional organ perpetuates the dysfunctionality in the other organ through a variety of mechanisms. And type 2 diabetes is a risk factor disease related to cardiac system and kidney. So it's a vicious cycle, and we have to break this cycle somewhere. Not only that, there is a heart failure and there is mineralocorticoid receptor overactivation in this heart failure and CKD patients. So both kidney and heart are getting fibrosed, and actually it perpetuates each organ's damage. We know that mortality of heart failure with reduced ejection fraction, mildly reduced ejection
5
fraction,
minutes remaining.
or preserved ejection fraction, they are similar. And 5-year mortality is also same. So what is goal to prevent progression? That is why American Heart Association has given these stages. Stage 0 means no risk factors, stage 1 is dysfunctional adiposity, stage 2 has metabolic risk factors with CKD, stage 3 subclinical CVD, stage 4 is clinical CVD. So in stage 0, there are no risk factors, patient is normal, normal BMI, normal waist circumference, normal BP, sugar and lipid. In stage 1, there is excessive dysfunctional level adiposity leading to impaired glucose tolerance. BMI is more than 23, waist circumference is high. In stage 2, now there is either hypertension, metabolic syndrome, or frank diabetes, hypertriglyceridemia, and there is some kidney damage, moderate or high risk CKD stage G3 or G3, A1 or A2. In stage 3, there is subclinical cardiovascular disease in CKM, and there is either increased CT calcium score of subclinical heart failure, marker of which are increased BNP and troponin, diastolic dysfunction by echo, and patient has high risk CKD now, is in red category by KDG heat map. And in stage 4, there is established or clinical CVD with heart failure or atrial fibrillation or stroke or peripheral artery disease and established CKD. And all of these stages will have dysfunctional adiposity. There are some risk enhancers also, chronic inflammatory conditions, sleep disorder, polycystic ovarian syndrome, or even family history. Everything is important. So holistic approach should be there. We should control everything. What are the goals? Target goal is HbA1c less than 7, BP less than 120/80, LDL should be less than 50 for Indians. If it is extreme risk, less than 30, and weight loss should be at least 5 to 10%. We know that in good old days, bariatric surgery was there, metformin was there, fenofibrate was there. They were reversing this adipokin misbehavior. So there was reduction in domain 3, reduction in domain 1 adipokin secretion by all these molecules. But now we have got variety of safer and good molecules. MRS do same thing. Incretin receptor agonists like GLP-1 and even tirzepatide, they also do same thing. Angiotensin ARBs and RAS blockers and even ARNI, they also are helpful, and SGLT2 inhibitors, they are also helpful to reverse this abnormal ratio, and that can prevent heart failure with preserved ejection fraction. And nowadays, research is going on to directly have selective adipokine modulators, which will definitely do just reverse this ratio. They will reduce the adipokine 3 level. So what is the evidence of benefit? We have got a GLP-1 receptor flow trial is there, major kidney outcome with semaglutide, 1 milligram subcutaneously weekly, clearly showed a major kidney benefit, major CV event and death rate, everything was raised. In another trial with this semaglutide again, 2.4 milligram reduce in weight and reduction in CV event also. We have got SGLT2 inhibitors, Credence, DAPA, and EMPA, all three showed clear-cut benefit. And benefit was seen in heart failure with preserved ejection fraction also. We have got finerenone trial, composite CV outcome and composite renal outcome, significantly better with finerenone. And even in fine arts trial, we saw that finerenone is useful in heart failure with preserved ejection fraction also. And when you combine all these four molecules, SCLT2 inhibitor, GLP-1, and non-steroidal MRA, that is finerenone, MACE is reduced, hospitalization for heart failure, cardiovascular death, CKD, and all-cause mortality, everything is best when you combine all three molecules. So this is the four pillar of management of CKM syndrome: RASI, SCLT2, NSMRA, that is finerenone, and GLP-1 receptor agonist. We know this, that we have to add all these things, the last slide, before I end. So what is the treatment for our patient, 65 male? Treatment is lifestyle changes, healthy diet, physical activity. He was non-smoker. So for diabetes, CKD, and obesity, I'll give empagliflozin 10 mg, metformin 1 gram BD, gliclazide 80 BD. He was already on metformin and gliclazide in OD dose. Now we have made BD with empagliflozin is added. He should have renal protection and he's hypertensive also, so ramipril should be there. Finerenone should be added. His GFR is less than 60, so I should start with 10. And after 1 month, if potassium is still okay, less than 5, I can go up to 20. And semaglutide 1 milligram should be started weekly. And if he can tolerate after 1 month for weight reduction benefit, I may go to 2.4. Hypertension, if needed, if it's not reaching to 120 target, I can add amlodipine or diuretic. He had some edema also. And for lipid, it should be always intensive lipid therapy. Atorvastatin 80, when GFR is less, you cannot give more than 10 milligram of rosuvastatin, remember that. Then atorvastatin is kidney safe. Give maximum dose 80, ezetimibe 10, and if target of 50 is not met, I can add bempedoic acid, icosapendithyl, or later on PCSK9 inhibitor. Thank you.
Thank you, sir. Now I invite Dr. Dhaval Nayak, sir, for his talk on conduit in CABG, what physicians should know. Dr. Dhaval Nayak, sir, please.
Good morning. So, CABG, I think one of the most common cardiac surgeries has been happening in the world, and I feel, as being senior colleagues, you must know about conduit choice actually. What we do during the counseling, consultation, and surgery. So selection is very important. After that, harvesting techniques and outcomes and current evidence that we are going to discuss. So basically, we need to review all commonly used conduits in CABG. It is not only LIMA or RIMA or SVG, but we need to review everything. We need to understand indications and selection criteria, very important. I'll just discuss in upcoming slides. We must discuss patency rates and outcome. We also learn key tips for harvesting and handling without damaging these conduits, and we also need to recognize complications and how to avoid them, where we can get the best long-term outcomes of CABG. So the goal is to complete and durable revascular. This is very important actually, complete revascularization. Conduit choice is very critical in determination of outcomes. We always just thoroughly discuss about arterial and venous conduits in all patients. We need to balance between the patency and availability, and we must consider certain patient factors also like COPD, obesity, old age, osteoporosis, etc. So everyone must be aware of this common conduits, that is internal memory artery on the left and right. Radial artery is also left and right, but we commonly use left. Saphenous vein grafts, very universal. And we have less commonly used arterial conduits like gastroepiploic artery, which normally we don't practice nowadays. Now LIMA, I think yesterday Dhiren Bhai discussed LIMA. It's a very gold standard. It is one of the God's gift actually. Very typically made for LAD, but sometimes we use in major OMs also when LAD lesion is not critical. It is having one of the best long-term patency. It is having a intrinsic nitric oxide in this media, which very seldomly causes spasm of this internal memory artery. It is very resistant to atherosclerosis and minimal size mismatch. So Lima and Rima also is the same character. We always try to get a harvest with the best possible results without damaging that. Similarly, it is a right internal memory artery. We use different configuration also. Radial artery, it is again artery. The difference between the Lima and radial artery is a bit of a presence of a more media, which can cause sometimes radial spasm, which is very rare nowadays. It is very sensitive to flow. Like, for example, if you put a radial artery on a less stenotic artery, then very high chances that radial artery can get blocked. So we have to justify the use of radial artery. Saphenous vein graft is like emergency, most commonly available conduit. We have two long saphenous veins in the leg and thigh, very easy to harvest. Long-term patency rates is okay if you have a proper selection of artery, and it is a bit susceptible to atherosclerosis and intimal hyperplasia. Few of the vein grafts actually even they close before we discharge the patient from the hospital. So the use of saphenous vein graft has to be very judiciously decided. So there are a lot of factors actually which we consider before the choose conduit. So first of age and life expectancy, younger age, older age, diabetes, obesity, renal dysfunction, bone quality and sternal perfusion. That is very important, particularly when you think for the bilateral memory artery, because so many times it can cause to sternal breakdown, and which is one of the nasty complication. And most important is target vessel quality and size. Degree of stenosis in the native artery is very important. Quality of the distal runoff, like, if there is a blockage is too long actually, runoff is not good, then the conduit may not work well for the long term. Competitive flow consideration, as I discussed before, and location, either it is a LAD territory or circumflex or RCA territory. We have different harvesting techniques. I am not going in details about these techniques because it might bore you actually, but Lima, like, we harvest as a pedicle or skeletonized, depending on the size, how we want to get it done. Veins, we can harvest open or minimal invasive or endoscopic assisted, but whichever the technique, we always try to avoid injury to that particularly conduit, because sometimes, if you don't realize from outside, but inside, once the intima just breaks down, that can lead to immediate or late issues with the graft. So if we talk about patency and outcome, arterial grafts are certainly better than venous grafts, so it is always preferable. Lima LAD patency is highest among all. I'll show you the figure. Importance of severity of stenosis in the target vessel is very important. So it is not like that if one artery is 50-60% blockage, it's not significant, then also you just do it. It's not like that every time. And use of multiple arterial graft is always preferable. Complications can happen with this conduit harvesting, particularly sternal wound complication, as I said, when you use bilateral, even with the single memory, patient diabetes, female patient particularly, old age, so 1 or 2% chances it could happen. Graft spasm, which I don't see nowadays because we have a very special harvesting technique and we use papaverine. But previously when I was studying actually, that time we used to see, and that is seriously notorious in ICU. It just gives you big ST elevations, the patient crash sometimes, and sometimes we have to take that patient again in theater to revise that graft. Harvest site infection, as with all surgeries, and early graft occlusion and technical errors, which is very rare with us, but it can happen. So these are some special clinical scenarios. We are a little bit more choosy about the selection of conduit, like diabetes and obesity. We always control diabetes up to the mark before taking the patient for surgery, because it is one of the main reasons actually for the sternal wound infections. Elderly patients, they are geriatric group, very fragile, and you have to handle them very carefully. Left main and triple vessel disease and redo CABG, in that, sometimes we don't get the choice of conduit because in previous CBG, it's already been used actually. So we have to more rely on vein grafts. So current trends, there is increasing multiple arterial grafting, skeletonization of the internal memory artery, but you need really expertise and actually do that because very high chance that you damage mammary artery when you remove the veins around, like, endoscopic vein harvesting whenever it is possible and feasible, and we have to focus on the long-term secondary prevention of the disease. So guideline says Lima to LAD is strongly recommended. This is a class 1 indication. Multiple artery grafting, as I said, is reasonable in selected patients. Avoid bilateral IMA in high sternal wound risk, and radial artery is preferred over SVG when severe stenosis is present. Now, the third one, avoiding bilateral IMA, just we take a lot of precautions otherwise to avoid, but still, at least few patients in a year we get with this kind of complication. So this is a graph patency. If you see the Lima patency, at the end of 1 year is almost 98%, and 15 years it is 88%. That's ultimate results. Rima, more or less same, slightly less, but it all depends actually how you use Rima. Radial artery patency is reasonably good up to the 10 years, but after that it just reduces. And saphenous vein graft patency 1 year is 88%. That's one of the reasons actually we use less vein grafts. And most of the vein grafts actually, almost 60 to 70% vein grafts, they just close by the end of 10 to 15 years. So, suggested approach whenever we plan for CABG, LAD territory, Lima is always preferable. Additional critical vessels in young patients, we always consider multi-arterial. Most of the time it is Rima or radial artery. Diffuse disease, which is very common, we are getting now more and more complicated patients like diffuse disease, CKLV, and that time SVG is appropriate because the priority goal actually is to bring out that patient. High risk for the sternal complications whenever we feel like, particularly female patients, old age patient, obesity, that time we avoid bilateral IMA. And if there is a moderate stenosis, for example, in circumflex or OM, there is a 60 to 70% stenosis, then normally we avoid putting radial artery because competitive flow, they close that radial artery. So these all we consider everything before we plan for surgery. You have time? Want to see video of one of? Yeah. Can someone? I think this video has not come in this laptop, I believe. I'm sorry, actually, this video is not playing in the system.
5 minutes remaining.
Thank you. So this is a case of, now just want to, so this is a case of triple vessel disease when we have harvested both mammary artery. This is on the left, Lima, you can see on the diagonal, and LAD. And then, oh yeah, so my commentary is there. To the middle of the left internal mammary artery, and then done at diagonal with Lima, and the second graft was done is Lima to LAD. The third graft was done with the help of a Rima, that is high diagonal, and that Rima was taken down laterally to the OM, and the final graft was done on the PLB. So Lima, Rima Y, and 5 grafts, that is diagonal, LAD, high diagonal, OM, and PLB. We have also done the 6th graft, which was put on PDA, and that graft was attached to aorta. So this was a young patient, 37-year-old patient, had a very strong family history, had bad triple vessel disease. So this is called total arterial CABG. Now you can't put veins actually at the age of 37. It is slightly unjustifiable. So we also shifting from conventional CABG to more innovative approaches like total arterial, as I saw. Robotically assisted, also we started. We just done few cases. Even we are the first one to did totally robotic Lima LAD CABG, minimal invasive CABG. Now this one just want to emphasize. The previous case actually, is been offered by so many centers like, we do minimal invasive, but it is impossible to perform these 6 grafts with this technology, Lima, Rima, and radial. in this setup, and the long-term results of minimal invasive for particularly multiple arterial grafting is not available. So we normally discourage whenever they ask for the minimal invasive surgery in this kind of cases, but otherwise we very routinely we do minimal invasive. Hybrid CABG, that is CABG and PCI. And yesterday I has discussed, we do a lot of MI complicated cases. Remember one thing, but choice of any modality, whatever you explain, whatever you consider, or whatever you do actually in the operation room, we always consider two things. One is safety, and second is long-term results. And that's the reason actually after 10, 15 years, our patients, whenever do we check angiography, the most of the patients, they are good, healthy, and the grafts are flowing. And
2 minutes remaining.
yeah, so robotic CABG, I'm not this, Amit, I think already saw your video. So certain myths actually is in society among doctors. Saphenous vein grafts are as good as arterial grafts. No. Only the lima matters in CABG, never actually. Okay, we have to justify, we have to plan actually whether use lima, rima, lima radial, lima vein, according to the all factors what we described before. Radial arteries should be avoided due to risk of hand infection, no. Older patients should not receive arterial grafts, no actually, we have to again justify, but particularly for the bilateral memory artery, we have to see the sternum. If it is too osteoporotic, then we avoid, otherwise we can consider. Diabetic patients should not receive bilateral memory arteries, that is also a wrong thing actually. We have to control the diabetes properly, and then so many times we use skeletonize, so we can preserve as much as more vasculature in the thoracic cage. Vein failures actually does not matter if lima LAD is patent. Not every time actually. Lima LAD is very standard, but sometimes the patient may present with you with angina if other grafts, they get blocked. So, and radial artery is unreliable due to spasm, which is nowadays we don't see actually. The last case of radial spasm I've seen is 11 years before. After that, I have never seen radial artery spasm. Endoscopic vein harvesting we do very routinely actually, but it is really good. Endoscopy actually, you know, it is a no-touch technique. So we don't touch veins actually. So it is always better than open. Anyway, I think we are running out of time. So conduit choice is individualized. Arterial grafts provide superior durability. Lima LAD remains gold standard. Careful harvesting and handling are crucial. And long-term outcomes depends on both conduit and patient factors. Thank you.
Thank you, Dr. Dawalbhai. Now it's a great pleasure to invite my batchmate, Dr. Hemang Bakshi, for his talk. His talk is on SGLT2 multifaceted agent for cardiometabolic renal disease. Hemang, please.
Good morning. Good morning, everybody. Milan bhai just discussed in detail this cardio metabolic renal disease, and I will be talking about the role of SGLT2 inhibitors, which is a multifaceted agent for these patients. Now, you all are aware that there is of late, there is a new paradigm shift for optimal type 2 diabetes management, and one should consider risk factors beyond glycemic control, including obesity, cardiovascular risk, heart failure, and renal disease. And overall, it is a patient-centered approach where there is a shift from glucocentric view to an organ disease approach. And this diabetes, cardiovascular disease, chronic kidney disease represent three major health challenges associated with substantial morbidity and mortality. And recently, as Milan bhai discussed, this complex web of interrelated health conditions has been collectively defined as cardiovascular kidney metabolic syndrome by the American Heart Association. So CKM is basically pathophysiological interrelatedness of metabolic risk factors such as obesity and diabetes, CKD, and cardiovascular disease. So it starts with excess or dysfunctional adipose tissue leading to hypertension, dyslipidemia, metabolic syndrome, and diabetes. And there is myocardial remodeling and cardiac fibrosis because of that, resulting in cardiovascular disease, and also glomerulosclerosis and tubulointerstitial fibrosis leading to CKD. So there is interconnection between diabetes, heart failure, CKD. It's a vicious cycle. And there are, almost 50% global prevalence of CKD with diabetes, and the mortality triples with the association of CKD and diabetes. Heart failure is also a common complication of diabetes and CKD, and almost 1/5 of the patient has heart failure with type 2 diabetes. Stages of CKM has been discussed by Milan Bhai. Stage 0 is no risk factor. Stage 1 is excess dysfunctional adipose tissue, and patient has impaired glucose tolerance, overweight or obesity, and abdominal obesity. Stage T is basically metabolic risk factor and CKD, and patient is having hypertension, type 2 diabetes, metabolic syndrome, moderate to high risk of CKD, and hypertriglyceridemia. Stage 3 is subclinical CVD, where the manifestations are subclinical ASCVD and subclinical heart failure, while stage 4 is clinical CVD in CKD, and patient will be having heart failure, CAD, peripheral arterial disease, stroke, and atrial fibrillation. Now, coming to the role of SGLT2 inhibitors in this CKM syndrome. And you know that Apple has always been at the center of the evolution in mankind. And in 1835, the French chemist isolated fluorescein from bark of the apple tree. And now this fluorescein is the precursor chemical component of the SGLT2 inhibitors that we have been using now, which is, one of the 4 pillars as discussed by Milan Bhai in type 2 diabetes management with CKM. And you can see the goal is cardiovascular and kidney risk reduction. So if your patient with diabetes is having ASCVD or having indicators of high CVD risk, patient is having heart failure, or patient is having CKD, SGLT2 inhibitors are now first choice agent, oral anti-diabetic agent as per the ADA and other guidelines. So this should be given to all these patients as a first line agent. Now, it is now a choice of oral agent when diabetic patients are having obesity, cardiovascular risk, established ASCVD, CKD, metabolic dysfunctional associated with steatotic liver disease, previously called as non-alcoholic fatty liver disease, glycemic and weight management goals not met on current therapy. So it is a one class, and many experts can use: cardiologists, endocrinologists, nephrologists, and physicians. And these are the evidences: cardiorenal and metabolic comorbidities with SGLT2 inhibitors having recommended for ASCVD prevention and management. If the patient is having diabetes, for prevention as well as for treatment of MI and CAD, SGLT2 inhibitors are indicated. Now, this is the mechanism. As far as the heart failure is concerned, you can see for prevention type 2 diabetes with high CV risk or established CVD, SGLT2 inhibitors are indicated. Also CKD with or without type 2 diabetes, SGLT2 inhibitors are indicated for prevention. And for treatment of heart failure, across the spectrum of heart failure, whether it is HFrEF, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction, SGLT2 inhibitors are class 1 indication. So it is the only drug which is a class 1 indication all across the heart failure spectrum. And this is the mechanism of SGLT2 inhibitors in cardiac dysfunction. It has got glycosilic effect and natriuretic effect. And because of this, there are series of actions which leads to decrease in atherosclerosis. There is decreased cardiac hypertrophy, cardiac fibrosis, decreased cardiac remodeling, which improves cardiac performance and ultimately myocardial decongestion results. As far as the CKD prevention and management is concerned, SGLT2 inhibitors has been indicated. The CKD is defined as persistent UACR more than 30 milligram per gram or persistent EGFR of less than 60. If the patient is having diabetes or patient is non-diabetic, SGLT2 inhibitors, as you can see, it's a class 1 indication in these patients. As far as the mechanism of SGLT2 inhibitors in renoprotection is concerned, basically there is reduced volume overload and there is reduced intraglomerular pressure and decreased glomerular hyperfiltration, and also there are series of actions at proximal convoluted tubule, loop of Henle, and distal convoluted tubule, resulting in renoprotection effect. There are patients who are having heart failure in CKD, and here you can see that if the patient is having heart failure and CKD combination, irrespective of ejection fraction, SGLT2 inhibitors are class 1 indication. But in this patient, you should be careful as far as the hyperkalemia is concerned, which is defined as serum potassium of more than 5 milliequilibrium per liter. You have to recheck elevated potassium before making therapeutic changes. Consider potassium binder, and patient should be prescribed low potassium diet. What happens if there is acute decline in EGFR? Tolerate acute EGFR decrease of less than 30% after initiation of therapy. Do not discontinue therapy prematurely. If more than 30% decline in EGFR, and so ensure euvolemia, adjust diuretic dose, discontinue non-essential nephrotoxic agent, and then evaluate alternative etiologies. You have to monitor the disease progression in CKD and heart failure with biomarkers, anti-proBNP and UACR. So SGLT2 inhibitors basically is an ideal agent as far as this cardiorenal metabolic therapy is concerned, because it's a once pill, once a day, no dose titration, substantially improves survival and prevents hospitalization, meaningfully improves quality of life and functional status. Benefits appear rapidly within days to few weeks of initiation, exceptionally well tolerated and safe, does not lower blood pressure or does it very minimally, no adverse renal effects, and instead preserves kidney function and prevents dialysis. We will quickly revise some of the scientific evidence or trials. SGLT2 inhibitors, it is glucose-independent reno and cardioprotective effects. So irrespective of a patient having diabetes or non-diabetic, the trials have shown with dapagliflozin as well as empagliflozin that SGLT2 inhibitors are useful and effective. So there is a paradigm shift of SGLT2 inhibitors from just a drug for the patient with diabetes to the drug that lowers CV events and lowers the risk of renal events. These are the evidence of SGLT2 inhibitors in type 2 diabetes in high ACVD risk and MACE outcomes. As you can see, all the 3 major trials are showing benefit. As far as the heart failure outcomes in these major trials are concerned, it is, unequivocally shows that this drug is beneficial. DAPA-CKD was the trial which was done for dapagliflozin for kidney function improvement in CKD. It was randomized, double-blind, placebo-controlled, multi-central trial, 386 sites in 21 countries, more than 4,000 patients. Patients included had GFR of 25 to 75, 67.5% were diabetic, and ACR was 200 to 5,000. And the study showed that among patients with chronic kidney disease, the risk of any composite kidney or cardiovascular outcomes or death was significantly lower with DAPA than with placebo. Similarly, empagliflozin showed the similar results in EMPA kidney outcome, which was even larger trial with more than 6,000 patients. And you can see that among a wide range of patients with CKD, who were at risk of progression, EMPA therapy led to a lower risk of progression of CKD or death from cardiovascular causes than placebo. And this is the results of DAPA-HF trial, has been discussed many a times in patients with low ejection fractions, and the study has shown that in patients with heart failure and reduced EF, with or without type 2 diabetes, DAPA reduces the risk of worsening heart failure or death from cardiovascular causes compared to the placebo. Emperor Reduce was another trial which is again tested empagliflozin in patients with heart failure, and this trial again showed that among patients receiving recommended therapy for heart failure, EMPA group had lower risk of CV death or hospitalization for heart failure than those in placebo group, regardless of presence or absence of diabetes. Deliver was the trial which tested DAPA in patients with HFpEF, and the study showed that the primary outcome of worsening heart failure or CV death at a median follow-up 2.3 years was statistically significantly less in DAPA group versus placebo, with the hazard ratio of 0.82 and significant p-value. Emperor Preserved tested EMPA in patients with HFpEF, and again, this study concluded that EMPA reduced the combination risk of CV death or heart failure hospitalization in patients with heart failure with preserved EF, regardless of presence or absence of diabetes. Now, some important points to be noted. Patients need to be educated on the signs and symptoms of DKA, and certain situations increases the risk of DKA when you are using SGLT2 inhibitors. So you should avoid these drugs in acute illness, dehydration, insulin deficiency, or surgery. Genital infections can be minimized with good hygiene and controlling blood glucose to reduce glycosuria. And as demonstrated by CV and renal outcome trials, SGLT2 inhibitors do more than lower glucose and have potential to reduce CV and renal risk across different patient population. And these drugs are used in, as we discussed, in diabetic patients, and is useful as far as the patients having concomitant ASCVD, heart failure, CKD, obesity. Thank you very much.
Thank you, Dr. Hemang, for highlighting SGLT2 inhibitors. Any one or two questions?
My question is, in non-diabetic obese patient, can we give, or what are the criteria to giving SGLT2 inhibitor in sole obese patient doesn't having any diabetes?
So basically, obese patient not having diabetes, SGLT2 inhibitors, I mean, it is not recommended as of now.
Dr. Ankur Rawal, my question is to Dr. Hemang Bakshi and Milan Chak sir both. Regarding the SGLT2 inhibitors, like there is a tsunami of the empagliflozin versus the time-tested the dapagliflozin. So we as physicians wanted to know from both of you that so far as the cardio protection is concerned, which one is the better? And number two, where the renal protection is concerned, which one is better, and both in the primary as well as in the secondary prevention?
So basically, both these drugs are good, and I mean, I showed the data, but the EMPA, I mean, as far as the secondary prevention in cardiovascular disease is concerned, probably EMPA scores over dapagliflozin because of the mortality benefits that has been shown in the trial. So I prefer for secondary prevention in diabetes, those who are already having CAD, empagliflozin over dapagliflozin. Otherwise, both are, I mean, same. You can use either of these. For kidney, I think both of them are similar. You can use either of EMPA or DAPA.
Thank you.
My question is to Dr. Milan sir. Hello. Milan sir, in your case, metformin was used, sir, and when creatinine was 1.7, I think, and eGFR was less. So it is justifiable to use metformin in this case. And second thing was because patient was obese and gliclazide was used. So sulfonylurea group of drugs sometimes gives weight gain. So if patient is ready to go for insulin, then it is better to switch over to insulin than the gliclazides. And last, sir, amlodipine was added in last. So, because no doubt, patient was in heart failure with preserved ejection fraction, but dihydro group of calcium channel blockers can be used safely in this condition because sometimes it aggravates heart failure.
That's a good question. See, basically, his EGFR was 42, so metformin can be given up to EGFR of 30. After 30, you cannot give. So that is given. This patient had received already empagliflozin also, and he had received semaglutide also. So both are going to work for diabetes. But if sugar is still remaining high, metformin can be continued because GFR is not less than 30. Once it reaches to 30, then you have to stop metformin. He was already on gliclazide, which we continued, and still is with gliclazide and metformin, his EGFR, HbA1c was 8.4. So something has to be added where empagliflozin and semaglutide are added, and let us see what happens to him. As far as hypertension is concerned, he has no CAD. His calcium score was almost 20, and he had no history of any angina, no family history, non-smoker. So CAD was probably not there. So ramipril was given for hypertension as well as renal protection, 10 milligram. And he is receiving now finerenone also, so potassium has to be balanced. So in that case, rather than increasing ramipril, which can go up to even 20, that is the maximum dose for hypertension control. If hypertension is not controlled, then second safe molecule from kidney point of view, in absence of heart failure with reduced ejection fraction, EF was 55. So you can give amlodipine, or you can give isolazine also, which is hydrolazine plus nitrate also. That can be given because I don't want to increase ramipril to more, so that otherwise potassium will go up and then I have to stop finerenone or add potassium binding agent, which is costly and having more side effect also. So amlodipine can be given for a patient with heart failure with preserved ejection fraction. It does not aggravate heart failure. For reduced ejection fraction, we don't give.
Okay, sir. Thank you.
We are now concluding the section. Further question can be asked to the speakers during lunchtime. Thank you.
5 minutes remaining.
So yes, for the next session, we have Dr. Hemang Bakshi there on the dais as a panelist. Dr. Vipul Kapoor can join him. I request as chairpersons and moderators, Dr. Ankur Rawal, Dr. Bhavesh Patel, Dr. Parth Parikh, Dr. Hiren Pandya, Dr. Ashok Shah, Dr. Neil Mehta, Dr. Manoj Patel, Dr. Chaitanya Buch, Dr. Darshan Jotangia, Dr. Harpal Singh Davi, Dr. Nilesh Bhatt, and Dr. Ronak Patel. Please be on dais and let's have the next session. Over to you, Dr. Hemang Bakshi.
So there is a slight change in the schedule. First, I will invite Dr. Neil Mehta for his talk on generative AI in clinical practice.
Good morning, everyone. Apologize for the change in schedule, but you are all physicians and you know how life goes. I got called in because a close friend's dad in India has some medical issue, and I'm going to go from here straight there to do a home visit. So that's life, right? So if I'm a little distracted, that might be because of that. We'll talk a little bit about AI, and the thing to keep in mind is the examples I give you are based in US. But you all know that what happens in US often comes here. And so this will give you a preview of the life of a physician in the US and how AI is starting to impact, actually right now, how we practice. So some of the things we'll try and talk about is some of the administrative tasks. This is a huge issue in the US. It leads to a lot of burnout. We'll talk about I'll give you some screenshots of how we are using AI in the exam room to record the conversation and convert it into notes. We'll talk a little bit about how AI is used to answer patient messages in our electronic medical records, and then how AI is used in clinical reasoning. So administrative tasks, this is open evidence. This is blocked here in India, but there are many tools, and you can do the same thing with Gemini or ChatGPT. Make sure you do not put actual patient information. That is critical. But you can make up something that a 60-year-old man. Don't put the patient's name or medical record number or address or something in there. So here is a patient. We are just talking about SGLT2s and GLP-1s. So here is someone who is a good candidate for one of the GLP-1s, and he has NASH or MEL, morbid obesity, BMI, knee OA, and he has CAD and is pre-diabetic, right? So he's pre-diabetic, he doesn't have diabetes. In the US, this person would not be normally easily approved for a GLP-1, which means $1,000 a month out of pocket, which most people cannot afford. So I have to write a letter to the insurance company to approve this. And I put this in here and say, can you help me write a letter? And it'll generate this letter instantly with all the references to all the trials that support it for his liver, for his heart, for prediabetes, for his obesity, etc. I can download this, I add in the patient's name, and my secretary can send it to the insurance company. Another big issue is patient education. Literacy is the same issue here and there. We may have patients. I did a PSA, it comes back as 4.5. Now I have to explain to the patient what this means and what the next steps are. And yes, I can explain it in the office. By the time they leave, they have forgotten 80% of what I said. So you want to give them a little handout so they can study this. I put this in here and say, can you give me a nice patient handout to explain what the next steps would be? In this case, you would repeat the PSA, and then if it's still high, maybe send him to urology. So it will generate that letter, and if you want it in a different language, their Spanish, it'll convert it to Spanish, and it's very, very good at doing those things. So these are very quick early wins. You can do this and saves you a lot of time typing, looking up information. Always, always, always read it yourself before you actually give it to the patient. It can make some very funny mistakes. All right, so ambient AI. The way this works is I go into my office, I put this phone on the desk, and I ask the patient, is it okay if I use this? Patients have already been told there are signs in the waiting room, they are aware of this. It starts recording the conversation, and I'll show you some screenshots. When I finish my clinic and go back to my office, all my notes are done. I don't have to rewrite anything. I do have to read it, correct it, and make sure. Even in US, you bill by codes, right? So you can say, I saw type 2 diabetes without long-standing insulin, uncomplicated. It will have generated that code. You just have to hit accept or modify it. So this has literally become the third person in the room. We are used to having computers in the room. Now we have AI in the room. And what does this look like? Couple things. If and when this starts coming here, make sure that you look at a certain factors, the cost. If you have an electronic record, make sure it integrates. Otherwise, you're still copying and pasting notes. My notes are already in the electronic record when I go back to my office. From my phone, I don't have to copy and paste. Make sure it supports coding. If coding is an issue for billing, it will come here if it's not here already. And then see who else is using it. If it has been used by good organizations, look and see how it works before you invest in it. Is it a fly-by-night operator? Is this a company that's going to be there for a while? Because if you invest time and effort in using this, suddenly it's gone, you'll have to learn everything again. So this is an actual screenshot. It knows my schedule. You can see every 20 minutes I have a patient. I blocked out the names of the patients. And the first one is ready. So I click on that, it loads the patient, and I've again blocked out the name. And then it has generated the list of diagnosis. This is my average patient I see in 20 minutes. I'm sure a lot of you have patients that look like this. After I finished talking to the patient, this is the level of note that is generated here. And there are some things like it picked up on the fact that there was plantar fasciitis. Everything I said is already documented. Half the times when I actually write my note, I would have forgotten some of these things. So I'm like, wow, it even remembered that I told this patient to do certain things. On top of that, it'll take everything I said and convert it to a patient handout. So it says, we talked about your shortness of breath and the fact that you have a murmur. This is what I thought it's a very faint murmur. I'm not very concerned. But because your increased shortness of breath, I've decided to get an echo. So you can see it has changed the same conversation to the level of literacy of an average patient, and every detail is captured. I don't have to worry about that. Again, all these things have been covered. The things that are in my note are reflected in the patient. Big issues. In the US, and I'm sure in India, there is the problem of physician burnout. 30 to 40% of physicians in the US experience burnout, and it's because we love to see patients. It's all this stuff that happens afterwards, writing a note, billing, coding, writing prior authorization. It's a lot of busy work. Secondly, we are all typing notes in the office while we are talking to patients. Now, I just put my phone there, I turn around, I talk to the patient. The patients love it. There is more trust. They disclose more. We feel closer. Most people feel the care is better. The problem is what happens to that data sitting in the cloud? Who owns it? How long? Is it auditable? Stuff like that. And there is some inaccuracies, so you have to read it. And the tendency is you don't want to read it because it'll save time. If you don't read that long note and it has problems, you are liable, the patient can see it, and then that propagates the errors down the road. The big issue for me as an educator is we have students and residents. I don't know about you, when you actually write the note is when you think, and you are saying, okay, should I get a TSH or this? You are going through that thought process. This short circuits the whole thing. It actually starts suggesting things to do, and we really worry that students and residents will lose their ability to reason and think clinically because they talk, this generates a note, they give it, and they're done. And that critical thinking process is gone. So for a busy, experienced clinician, maybe it's okay. It saves you time. For a person in training, right now in our medical school, we don't allow our students and residents to use this. After I finish my clinic and I go back, and actually I was doing this even here, we get messages, right? You get the lab results. You get patient messages saying, you saw me, but my back pain is still there. What do you want me to do? Or can you tell me who is a good consultant, and can you give me a phone number of your radiology department where you ordered an MRI? Automatically, the system will generate a draft for me. It says, and it's very kind, very nice, written better than I can. And all I have to do is look at it and change a couple words, hit send, and the patient gets a message. Increasingly, it's getting better and better and better. And things that I may have missed, it's able to pick up because it also can see the patient's chart. So it saves a lot of time. Again, it's a slippery slope. What is your role when AI starts doing more and more of this? Also, it can make mistakes. Make sure there is human in the loop and you are involved in reading and making decisions. Last part of this is clinical reasoning, and this is fascinating. So this was actually a friend of mine in California, a 60-year-old. He has type 2 diabetes and says, should I get stem cell treatment for this? Now, this is not an FDA-approved treatment in the US. I have no clue. I had no idea because I've never used this. And he also says he doesn't want to use bone marrow. Can he get some allogenic stem cells? And I'm like, you know what? I don't know, but I'll try and find out. So what do? I showed these tools on a couple days ago, Elicit, Undermined, and you can even use Gemini Deep Research or ChatGPT Deep Research. I stick this in, it starts coming back with papers. Here's the question. Here are all the studies done using stem cells for type 2. I can say, focus on type 2, not type 1. Focus on studies that have more than 2 years of follow-up. I don't want someone who gets better for 3 days and then gets worse again. It brought me all this, and Undermine does the same. It gives you a fantastic summary, very well referenced, and now, if I want, I can dig in myself and get more answers. The interesting thing is that there is actually some decent data that this does work, but it has not gone through extensive studies, and so I kind of was able to give him my perspective on this. Similarly, here is someone, this is actually, I want you to think about this. This was something because it's a patient with metastatic prostate cancer and diabetes and hypertension. He was given a medicine called abiraterone. How many have heard of this medicine? I had not either. I mean, I'd heard of it, I'd never given it, I didn't know what it did. And he said, when they gave me this, they gave me prednisone, but I'm smart, I have diabetes, I'm not going to take prednisone. And so I did not, so I just took abiraterone alone. And now I'm noticing my blood pressure is very, very high. What should I do? And he walks into my office, or I walk in and he asks me this question. I have no freaking idea. I'm like, can you give me a second? And then I'm going to look this up. I was very honest. I said, I don't know
2 minutes
this.
remaining.
I'll try and find out for you. So I put this to Gemini, and this is the thinking process it did. So it summarized what I said, prostate cancer, diabetes, hypertension. Gemini first says, okay, let me see how abiraterone is used. Then it says corticosteroids are used because abiraterone can cause increased mineralocorticoid levels. And if you use prednisone, it suppresses the ACTH, the corticosteroid levels are down, glucocorticoid levels, and that prevents hypertension. And the mineralocorticoid levels will go down. And I'm like, it just blew my mind because I never remember the adrenal pathways. I have to go back to the textbook. So this whole thing, I was able to understand the whole pathophysiology of this, go back, read it up in up-to-date, and I was able to go and tell him, you have to take prednisone, but you could try a mineralocorticoid antagonist, but not spironolactone because that actually blocks the effect of abiraterone. All of this within 10 minutes. So this is the level of clinical reasoning that it's able to do. It'll suggest the medicine, options, side effects, and pros and cons. So here's the whole summary of what it came up with. And finally, where we are going now is agentic AI. I can set it up to say, every time there is I'm interested in these types of conferences. Anytime an announcement comes that this conference is looking for abstracts, send me a note. It'll remind me that abstracts are due for AAMC meeting, and I don't have to keep track of it. It's same way, it is a multi-step process. You make a clinician appointment, it will walk through the whole thing and inform the patient when the appointment is. Lot of concerns, like I started to say, biggest issue is problems with how dependent we become, and is it going to hurt our thinking process? Problems of errors, biases, hallucinations, but this is here to stay. It's going to change your life if it hasn't already. It has changed our lives in the clinic. So keep your eyes open, fingers crossed, and all the best on this. I have to rush off to see someone, so thank you all.
Thank you, Dr. Neil Mehta. I am happy to tell you on behalf of excellent disclosure, just 1 second. He is in a hurry and therefore we have taken him first. I will just let you know on behalf of all my friends that we at India have voice RX, we have AI, we have integration with EMR. Even these specs are also giving the same ICD and procedure codes. So overall, we are almost with internet, we are, what is discussed yesterday night is available yesterday night in India, and therefore things are very good. And we all are on the same one earth. અને એક જ અર્થમાં આપણે પ્રેક્ટિસ કરીએ છીએ, only one small difference, and I'm not commenting or making just a comment, કે અહીંયા એક ફાયદો અમને એ છે કે we are the king in our OPD, and so far the systems are not so much set that therefore we are not the slaves in the system, but combination of both is required. We appreciate. Thank you.
Being able to work with AI as a partner and being able to make that happen is key. Don't let the system run you. You should have autonomy in how it's used. Thank you.
Thank you. Thank you very much. Bye-bye.
The next talk is by Dr. Parth Parikh. Yesterday we were lucky to listen to him. It was really excellent, and he is having the very good heritage and inborn genius. Over to you, Dr. Parth.
Thank you very much. Good morning, everyone. Today my talk is going to be on mitral regurgitation. It's an upcoming therapy. It's been there in United States for quite a few years. It's coming up in India slowly as well. So it's transcatheter edge-to-edge repair, which is decoded when, why, whom, and how. These are my disclosures. Objectives of the talk today is to go over the epidemiology, classification of mitral regurgitation, pathophysiology, basic assessment, and then I want to try and spend some more time going over some cases that can show that it is a feasible, easy procedure to do, and then go over some other transcatheter therapies. From an epidemiology standpoint, mitral regurgitation is really underestimated. The prevalence and outcomes in unoperated patients is quite high. So this was a study that was done in Cleveland, looking at how many of the patients with functional mitral regurgitation are undergoing just medical therapy, which is 50%. 26% got surgery for functional mitral regurgitation, 17% got surgery for degenerative mitral regurgitation, but then there's a big chunk of population which is untreated or treated just with medicines. From an Indian perspective, what is the prevalence? So 9 million, so 90 lakh people have significant functional mitral regurgitation from heart failure. 4 million, so 40 lakh people have degenerative mitral regurgitation. 3 million have significant functional mitral regurgitation following a myocardial infarction. Brings up the total to 15 million patients with mitral regurgitation in India itself. Out of that, if we try and go by the demographics, the indications, and even the putting cost into perspective, there are at least 5,000 patients who should be getting this therapy of transcatheter edge-to-edge repair within India itself. In terms of numbers, we are currently, in 2025, around 150 patients got this therapy. If we take a step back, we had a great talk on TAVI yesterday as well. We saw the numbers that in 2025, there were 4,000 TAVI procedures done. In 2017, so just going 8 years back, that number was less than 200. So I do feel that we're at a point which is where we're going to get there in probably the next 8 years, that we'll be seeing much more of this therapy within India itself. From a pathophysiology standpoint, most of us are aware that there's regurgitation of the left ventricular stroke volume that goes back into the left atrium and causes left atrial dilatation. Overall, over a period of time, leads to atrial arrhythmias, thrombus, pulmonary hypertension, and all the downstream effects that we see from that. This is probably one of the most important slides that I have, which is classification of mitral regurgitation. So once you diagnose a patient having mitral regurgitation, it's very important to know what the cause of the mitral regurgitation is. Different causes have different management therapies. So primary mitral regurgitation, or DMR, or degenerative MR, is like this video over here. You'll see that this leaflet, it's a leaflet issue. So it's
Primary, the leaflet is either prolapsed, flail, or something going wrong with the leaflet. When it's functional, it's a pump issue. So either the left ventricle is dilated or the left atrium is dilated, which causes malcoaptation of the leaflet. So the leaflets are not coming together. The leaflets itself are functioning properly. The reason it's important to know this, because again, primary MR or degenerative MR has a different therapy. Functional MR has a different therapy as well. From a clinical presentation standpoint, most of these patients are going to present in the same way: shortness of breath, fatigue, orthopnea, PND episodes. They'll have atrial fibrillation, pulmonary hypertension, and on examination, you'll definitely appreciate a murmur. From an assessment standpoint, echocardiography still remains the mainstay for the diagnosis and etiology of the mitral regurgitation. There are various parameters that we look at in an echo. TEE, the transesophageal echocardiogram, is of paramount importance to make sure that we understand the etiology, and that will also help determine the feasibility for management of the valve issue. There are other modalities which can also be used, which is like a cardiac MRI or a hemodynamic cath. So going over primary mitral regurgitation, so as I mentioned, this is a valve issue. Valve issue where on this 3D image you can see this is anterior, this is posterior. The posterior leaflet, there's a prolapse and a small flail segment, so it's a leaflet issue. So any patients who have symptoms due to mitral regurgitation from a degenerative leaflet, if they have symptoms, the first therapy for them is mitral valve surgery, where they should be aiming to have a mitral valve repair for a durable result. So that is a class 1 indication. In patients who are high or prohibitive surgical risk, so if a cardiac surgeon says that the risk of this patient coming off the table successfully is very low, then these are patients who should be referred for transcatheter edge-to-edge therapies. Again, very important to know that if it's degenerative MR, gold standard is still surgery, open heart surgery for these patients. So medical therapy for secondary MR, that is functional MR, that is an issue with the pump. So if there's an issue with the pump, if the EF is low, then again, gold standard, class 1 indication is still medications, medical therapy. They have to be on ACE, ARBs, ARNIs. Think about CRT in these patients if their QRS is prolonged, if they have a left bundle. So again, medications are primary and mainstay for these patients. As I mentioned, GDMT is class 1. In these patients, if their EF is low after appropriate GDMT, they have persistent symptoms, and you have an anatomy that is favorable, then you can think about doing this transcatheter edge-to-edge repair. More recently, the 2025 guidelines for the ESC were updated, where TEER is now, the transcatheter edge-to-edge therapy is now a class 1 indication in Europe and other parts. What we have seen, the trend with guidelines, is that the American guidelines usually, unfortunately, follow the European guidelines. So probably in the next couple of years, we'll see that change in the ACC guidelines as well. Now, how did edge-to-edge repair come along? So it came along from initially surgery, that a surgeon in 1991, Dr. Alfieri, saw that there's a congenital heart defect where there is a fish mouth opening of the valve, which may be able to reduce the MR. Not a big timeline if you think about other things where surgery has been very ahead of the percutaneous or transcatheter therapies. Within 10 years, an interventionalist thought of doing the same thing with a device where we create a fish mouth opening. So if we see 91 was the first surgical intervention, and within 10 years, the first human implant of a MitraClip procedure was done. In terms of data, so there has been enough data over the past decade showing that this therapy is quite beneficial in select group of patients. Again, I'm not going to spend much time going over data in detail, but this was a landmark trial that was published in 2018 showing not only benefit in decreased heart failure hospitalizations, but also an improved mortality benefit that has persisted over years. So 5-year data was recently published as well, 2 years ago now, that showed persistent benefit of this therapy. So when we come to devices, what kind of different devices are available? There are currently 3 commercially available devices for this TEER procedure. All of them have the same principle. This is a device made by a company, Abbott, where there are retention elements. You see these things here that catch onto the leaflet. then you close the device and bring the leaflets near. Edwards has a similar device with a little bit different orientation of the retention elements. Made in India, make in India, again, we have an Indian system, MyClip, which is very similar to the MitraClip system. Again, you can see the top is the MitraClip here, and this is the Indian system, which again has the same principle and same thought process of using this device. Putting into perspective the American data about how frequently these procedures are now being used. So again, most recent data is from 2024 that I was able to find, which is 16,000 procedures for MTR, for the mitral transcatheter edge-to-edge repair that have been done in India. Again, we mentioned that that number is quite low. So I have a better video going over this procedure. So this is the device system that is set up on the cath lab table. Access is very simple. It's going through the femoral vein. We put a catheter through the femoral vein, go up into the IVC, into the right atrium, we puncture a hole, go transseptal, put the catheter and the guide system across into the left atrium. This is the MitraClip device that comes out. This is all done under TEE guidance. So TEE is of paramount importance in this procedure. We can move around the device based on the TEE guidance. So the cardiac imager is going to be telling us how and where the device needs to go. You put the device across into the LV, you put the grippers down, and this is the kind of opening that you would see. If you're not happy with the result, like over here, you see residual MR, you can open up the device, get a better grasp, close it again, and then deploy the device. So again, it is a pretty straightforward procedure.
Remaining.
Most of these patients are able to go home the next day, or at least within 24 hours. So quick case example, 75-year-old female, severe functional mitral regurgitation, class 3 symptoms on appropriate GDMT, valsartan. ARNI was not started because of the high cost for the patient, dapagliflozin, metoprolol, and spironolactone. This is the amount of MR that you see on appropriate GDMT. This is live TEE images. This is a case that I did 3 weeks ago just before coming here. So this is the MitraClip device going into the left ventricle. With TEE guidance, we're pulling the device up, and you'll see shortly that this gripper goes down. Goes down. Now we close the device, get better assessment. We're not happy with the numbers, so we let go, invert the device, come back into the left atrium. Again, using TEE guidance, we reposition the device, and then once again, attempt to go back into the left ventricle. Make sure that we see the leaflets. The leaflets are bouncing on the grippers, on the hand, and then the grippers will come down. We close. And this is, again, almost real time, so it's not a very long procedure either. And then we can immediately see the difference in the mitral regurgitation here. Again, this is how we started. And in less than 30 minutes, this is the result that we're able to get. This is of a different patient, just to show the steps that we go transseptal, we put the device in, we can release. This is, as I mentioned, again, a different patient. The patient I just showed got a really good result just with one clip, but you can put multiple clips as well if you have residual mitral regurgitation. Another example I'll go over quickly, which is for degenerative mitral regurgitation. So over here, again, degenerative is different. This is a 78-year-old female who has a high STS risk score, not a surgical candidate. You see prolapse of the posterior leaflet. So this is anterior, which is where the aorta is. This is the posterior leaflet. And again, we can see there's significant leak from the prolapse. We do all of this under 3D multiplane reconstruction imaging. And again, here, this is showing the MitraClip device going down. We position it across where the pathology is. So this is, again, different, that you want to target where the leak is. This is the grippers going down. So you're grasping the leaflet, and then you close the device. So this is what we started with before. So this is a prolapse and flail that you see in the posterior leaflet. This is after putting the clip on. And there is immediate reduction in the MR. And again, these patients go home within 24 hours of the procedure.
2 minutes remaining.
Another quick case, this is similar to the first case that I showed, 82-year-old male with severe functional MR. Again, it's very important to make sure that they're on the appropriate GDMT before we do anything. So they have to have symptoms on appropriate GDMT. In this case, it was an ARNI, SGLT2, beta blocker, and an MRA. And again, same thing, we use 3D imaging as a guidance to make sure that we know exactly where we're going. We're seeing this in real time, and as we see it in real time, we can see a response in real time as well. And again, on the top is before we started, and on the bottom is after. Again, you may see a little bit of residual MR, which is very normal, and you want to have at least some degree of MR left in functional because you don't want to completely take it away. In terms of future directions, again, it is a very exciting field right now, structural cardiology. There's a lot of stuff going on. These are just some of the trials that are ongoing in United States to look at different therapy options for mitral valves. And again, we have clips, we have valves. There are different valve systems that are coming in. There's annuloplasty devices that are coming in. All of this can be done without open heart surgery. So if there are some takeaways from the talk, then it's very important to differentiate between primary and secondary mitral regurgitation. Primary or degenerative MR, if they're lower intermediate surgical risk, class 1 indication, still open heart surgery for a mitral valve repair. If they're high risk, then TEER is a class 2A indication for these patients. Functional MR in European guidelines, 2025, it has already become a class 1 indication after GDMT optimization. And again, heart team approach is extremely important.
Thank you, Dr. Parth. It is a Dhurandhar presentation. The next is Dr. Anish. Anish is a man of series so far as the excellent presentation is concerned. I just asked him, which is the best one of yours, Anish, the presentation. He politely said, next. So we are eager to hear you, listen you rather. Over to you, Dr. Anish.
Yeah, thank you, Ankur Bhai, and once again, a good morning to everyone. I'm very sure the topic which I'm going to discuss in next 15 minutes will surely create a very strong impact on the way you look at Indian dyslipidemia, the way you look at how to approach and treat this particular dyslipidemia. So we all know that we Indians have got early, progressive, and diffuse coronary artery disease as compared to the Western counterparts. We get our first heart attack at a much younger age, at least 10 years before the Western world gets it. We have got more severe coronary artery disease when you send a patient for angiography. Per vessel number of blocks is more in Indians. We have got more diffuse and extensive coronary artery disease, where getting multi-vessel disease is very, very common. Unfortunately, whatever best kind of revascular efforts we do, either we do angioplasty with best possible stents or we do CABG, in Indians, the need of repeat revascularization is much more as compared to Western world. And obviously, because of this, the quality of life is impaired and mortality is also very high. And we know that there are many reasons, and we have to think certain specific reasons which we have. So let me give you first this case, and then we'll go for timer. He's a gentleman, 38 years. I mean, he is younger than most of the people sitting here. No diabetes, no hypertension, 92 kg weight. That's the serious most challenge and issue of youngsters of today. BMI 34, family history positive. His father had acute heart attack at the age of 50 years, for which he underwent intervention and was okay. Now, this boy or this young man who has come to your chamber has got certain parameters done. His total cholesterol is 195. His triglyceride is high, 270. HDL is low, 35. LDL cholesterol is 105, seemingly okay. See, this is how you see your most of the people, where if you look only on LDL, your eyes would perceive as reasonably okay. VLDL is high, non-HDL cholesterol is very high. So that's important point. Your LDL is 105, but your non-HDL is 160, and that happens in people who are obese, insulin resistance, particularly Indians. HbA1c is luckily okay at the moment. ApoA 1.4, ApoB 1.3, so 130 milligram per deciliter ApoB, which is high. Lipoprotein A, which is a specific risk markers for Indians, is very high, 76. Ideally has to be as low as possible, less than 20 is okay. 20 to 50 is an intermediate zone where your risk of coronary disease goes up, and once it is more than 50, you are already stamped as high risk candidate in in spite of anything and everything you have. So what will you do to this person? Number one, lifestyle changes. He's very young. I'll call him after 3 months and we'll reassess the lipid parameters. Number two, lifestyle changes plus fibrates because his triglyceride is high. He's an Indian patient. Number three, lifestyle changes with statin and fibrates because he needs aggressive treatment. Number four, lifestyle changes because in this conference we have been discussing high intensity statin and ezetimibe. So let me pick up the conference favorite option. So these are 4 options. Study them and your time starts. Okay, so people have become now quite statin-centric. That's good, that's good. Let's see how to achieve. So dyslipidemia in Indians, we know that it's high triglyceride, low levels of HDL cholesterol, and particularly this HDL cholesterol, even if people who have got little high HDL cholesterol, not sure that it is protective. See, that's the problem of Indians. It can be dysfunctional HDL or non-protective HDL, high proportion of small, dense LDL cholesterol. So even if your LDL cholesterol looks normal, 100 milligram, but then it will contain and carry more atherogenic ApoB particles. So this is called as atherogenic lipoprotein phenotype B in association with metabolic syndrome, insulin resistance, visceral obesity, and high level of lipoprotein A. It leads to a very disastrous coronary disease. So dyslipidemia in Indians is a bigger part of a bigger picture that is broader metabolic syndrome. So if we have to take some conclusion after 30 hours of continuous learning, it's all we Indians are going to have serious issues in next 20, 25 years unless we change ourselves very seriously. Prevalence of coronary disease in India is 4 times more than Western counterpart, and almost nobody has got adequate level of HDL cholesterol. That's the true story. Elevated lipoprotein A is a very, very common risk factor in Indians. It is per molecule, lipoprotein A is 6 times more atherogenic than LDL cholesterol, and it's very important for premature CAD. Unfortunately, there is no treatment. There is no lifestyle which affects it. There is no treatment at the moment. It is genetically decided, and it remains there forever. So we all know that this is a serious issue. Now, how a normal LDL, seemingly normal LDL, is disastrous for Indian is we need to understand this slide. So let me get a pointer. So this is LDL cholesterol of 100 milligram per deciliter. Same amount of LDL cholesterol. This is also 100 milligram, but here it is small dense particle. Now what is very important is every LDL particle will carry one ApoB particle, and it is the ApoB particle that is dangerous. That leads to atherosclerosis, not LDL itself. So when you have got 100 milligram LDL with large LDL particles, your ApoB particles are, say, for example, 20. Now same gram or milligram of LDL cholesterol, but if the particle of LDL is small, you have got 40 ApoB particles. So it is the number of ApoB particles you carry that's the cause of atherosclerosis, and that's why normal LDL cholesterol in Indians does not necessarily mean low risk, because most of us have got such small dense particle. Now we all know that triglyceride is a risk factor. Higher the triglyceride, higher the risk. And if you look to this data across India and world, once the triglyceride goes more than 150, the risk goes very, very high. And unfortunately, more than 50% of Indians, particularly youngsters also, have got more than 150. Tell me who have got less than 150? Very few people. A very important point that triglyceride remains a risk factor even if you give statin. So when you give statin, it reduces triglycerides. Say, for example, this is the people who have placebo, and their triglyceride level is always high. And when they are given statin, triglyceride comes down. But even after treatment with statin, whatever triglyceride level remains, higher the triglyceride, higher the risk. We all know that, and we have known it, that HDL cholesterol, lower the HDL cholesterol, higher the risk, and higher the HDL cholesterol, lower the risk. But now we have come to a point that still, as a science, as a fraternity, we do not understand the HDL cholesterol as well. There are so many things beyond milligram of HDL cholesterol. It may be the size of particle, density of particles, protein content, and most important point about HDL is what we want from HDL is CEC, cholesterol efflux capacity. Cholesterol efflux capacity means ability of HDL to reduce your LDL cholesterol and stabilize the plaque. Now, there is something wrong here in the Indians. Even if an Indian, your HDL may be high, but then perhaps cholesterol efflux capacity of that HDL is not as good, and that's why we Indians have issues. Now, lipoprotein A, highly atherogenic, highly inflammatory, and leads to development of premature stage vulnerable plaques, plaques which are ready to rupture and cause SES. That is what lipoprotein A. It's highly prevalent. 30% Indians have got LPA less than 30, more than 30. So it's very, very important. And when it crosses more than 50 milligram, it becomes a serious risk. Now, at the moment, we consider lipoprotein A as a risk multiplier. So when your lipoprotein A is normal, whatever risk you calculate traditionally is right. Say, for example, this patient whose LDL is 105, triglyceride is 270, if you calculate his risk will come, say, for example, X. But if you feature in the lipoprotein A of 75, his risk becomes 2.5 to 3x. So your same risk when your lipoprotein A is high gets multiplied by 2 to 3 times. And that's again a serious problem of Indians. And that's why if you look to the Lipid Association of India guidelines, where our Dr. Chugh is one of the member, once you got lipoprotein A more than 50, irrespective of anything, you are at high risk of cardiovascular disease and death. Your LDL may be 50, 60, 70, your triglyceride may be 120, 130, 140. You maybe not be smoking, you may be doing regular exercise. Once it's more than 50, your risk is high risk as per LAI. So that's something so important. What I discuss and what we have been discussing, I'm very happy that we as now physicians are becoming conscious that understanding LDL cholesterol as a risk factor for coronary artery disease is important. But still what is more important than LDL cholesterol is non-HDL cholesterol. So look at our young man, 105 LDL, 160 non-HDL. So they are discordant. Your non-HDL cholesterol is quite proportionately high as compared to LDL, and ApoB is 130. So that's where ApoB is important. And again, let me repeat, your LDL cholesterol is important, non-HDL cholesterol important, but what it suggests, how much cholesterol is carried by all atherogenic particles, it's milligram. What is more important is how many atherogenic particles, ApoB, you have. If your LDL is 150, but your ApoB particle number is less, does not happen generally, but less, you are okay. But even if your LDL is less, but ApoB particles are more, and which is there with all of us, and that's why ApoB is so important. So how to treat Indian dyslipidemia? Heart-healthy diet, exercise, if done consistently, goes a long way, but mind well, lifestyle changes produce positive changes in every risk factor to small extent. Don't expect exercise and diet to reduce your LDL from 105 to 50. It doesn't happen. Your lifestyle, exercise is going to help you tremendously, going to get you good quality of life, but then it will touch every risk factors to small extent. So when you do consistent, high-intensity, regular exercise, your triglyceride reduces, your HDL comes up a little bit, but particle size change is good, and your LDL goes little down. So keep doing lifestyle. Unfortunately, at the moment, there is no medicine on this earth which reduces triglyceride and at the same time reduces cardiovascular disease significantly, except for, again, statin. So there have been a lot of trials of all the fibrates done extremely well in non-diabetic and diabetic, and very clear, fibrates do reduce triglyceride numerically, does not change the cardiovascular disease future. And that's why please stop using fibrates in your practice unless triglyceride is more than 400. Unfortunately, every physician I see a prescription of Atorva F, Rosukor F. Bullshit. Stop using fibrates till your fibrate does not cross more than 400. And at that stage, use it for pancreas, not for heart. At the moment, fibrate should be out from cardiovascular practice, mind well. It's the statin which reduces your triglyceride, and if need be, again, saroglitazar, there is no data, so you can use, but there is no data. And if need be, as was talked by Dr. Milan Chugh yesterday, use eicosapentethyl. So a person who has got high triglyceride, eicosapentethyl, will reduce triglyceride marginally. Mind well, it is not going to make your 300 triglyceride to 100. It's going to reduce TG by 15 to 20%, but even with that small reduction, with whatever mechanism, it reduces cardiovascular disease. So a patient who has got high triglyceride, in addition to lifestyle, you've got two options, high intensity statin and eicosapentethyl. There is at the moment no medicine on this earth which increases HDL specifically and reduces CVD. So at the moment, all those medicines are out, and it's a research topic. Again, there is no medicine at the moment on this earth which reduces lipoprotein A significantly and improves CV health. They are in the pipeline. Maybe by next 2, 3, 4 years we'll get those molecules, but at the moment, inclisiran and PCSK9 do reduce lipoprotein A by small extent, 20 to 30%, but please do not use them for LPA reduction. It's very clearly said to have any significant effect on cardiovascular disease, you have to reduce lipoprotein A by 80 to 90%. A touch reduction of 20, 30% doesn't help. So that's still away. So what remains with you are only those 4 drugs, which you generally like not to use and use other things. It's all statin, high intensity, ezetimibe, bempedoic acid, and PCSK9 based therapy. So when you reduce your LDL cholesterol and so non-HDL cholesterol and so ApoB, you get tremendous cardiovascular benefit. And with every 40 milligram LDL cholesterol reduction, you reduce cardiovascular event by 20%. And that's true for everyone, man, women, child, adult, anybody with any disease. And that's very, very important. If your LDL is 100, you reduce it by 20%, 40 milligrams, so 100 goes to 60, you are going to get benefit. 60 goes to 40, you get benefit. 40 goes to 20, you get benefit. So what is more important is how much low, how much early, and how long you can maintain. We have got therapies which has got predictive definition, and even if with oral treatment, say high-intensity statin, ezetimibe, and bempedoic acid, you can reduce your LDL by 65 to 70%. That's not bad. That's very good. So what LAI, Lipid Association of India, has suggested that anybody whose lipoprotein is more than 50 is high risk. And now look at here. Our patient is high to very high risk. What are the goals for our patient? LDL has to be less than 50, non-HDL has to be less than 80, ApoB has to be less than 65. So start using LAI guidelines. Please stop referring and using American and European guidelines. Our guidelines are extremely strong, meant for our people, written by strong experts like Dr. Chuck sitting here. So what our patient values have, our patient has got LDL of 105, which you believe is normal. It's not normal. You have to take him to 50. Our patient has non-HDL of 160, you have to take it to 80, and ApoB, which is 130, has to be taken 65. You need maybe 3 or 4 drugs, statin, ezetimibe, bempedoic acid, and maybe PCSK9. So coming to conclusion, Indian dyslipidemia, small, dense, atherogenic LDL cholesterol with high TG and high lipoprotein A is the crux, leading to malignant cardiovascular disease. Heart-healthy lifestyle will improve your ASCVD risk. Don't bother about lipid profile. It may not affect lipid profile to a significant extent, but it's going to change your life. Proper intensity LDL and non-HDL reducing therapy with the help of statin, ezetimibe, bempedoic, and PCSK9 is at the moment only rescue you have. Please stop using fibrates. We need specific medicines which can reduce TG, improve HDL, and at the same time, reduce your cardiovascular disease risk. Till then, your weapons are clear. Thank you very much for your kind attention.
Thank you, Dr. Anish. It was really wonderful, and many pulse of the wisdom. All the physicians will take Anishni Shikhaman, clinic Sudhi, Anishni Shikhaman, patient Sudhi. Next speaker is Dr. Vipul Kapoor, and he is just like Lal Bahadur Shastri ji, the simple living and the high thinking. When he was just about to come from the abroad, he passed through the green channel because he was in a hurry, and the airport official asked him, Dr. Vipul, do you have anything to declare? He politely said, nothing except my genius. So over to you, Dr. Vipul.
Thank you, sir. Thank you for the kind introduction. Good morning, everybody. The topic is, I don't know whether it is apt for the moment or not, but I saw a few people little dozing, little yawning. So I thought, let me just put in this topic here. It's very interesting, and it's something which I believe quite a few people forget in their daily, day-to-day practices. But I believe it is very, very relevant to our clinical practice. The forgotten risk factors. I believe the crux of my focus in these topics has always been to rekindle some of the topics or some of the points that we tend to, forget or we tend to overlook quite often. But these are very, very important and pertinent points here. And sleep, stress, and the new frontier of cardiovascular care will be the focus. So I believe it is very good, but let me start with a question. So it's a very pertinent one. How would you rate your sleep yesterday night? How many of you believe that you had a good sleep? So timers, please. Good, bad, or you are not sure? You just slept and you don't know whether it was adequate, whether it was good or not. So let us have an honest answer. Okay. So most of you feel, but equal people feel bad. There would be multiple reasons for it. Maybe you slept late night, you had a bad night that way, duration. But are you also aware, the next question follows, are you also aware that whatever people who said that they had a good sleep may not actually have had a good sleep? So are you aware that there is a scientific definition for good sleep and that you are aware of it? Yes or no? Timer, please. Okay, so most of you know it. Let us see whether you actually know it. Because there is a scientific definition of sleep, and most of the people, if you see, including healthcare professionals, believe that it is just the duration. If you just talk to a layperson, and if you ask him how many hours do you sleep, or he would ask you how many hours do you sleep, I would suppose say 4 hours, and he would be surprised, and you will be taken aback. Like, how can you be actually sure that you had a good 4 hours sleep, and how do you call it as good hours sleep? Because it is not just about duration, right? The sleep has to be having a circadian alignment. It has to be restorative, daytime functioning, circadian alignment has to be good. The architecture of the sleep is also very important. It is not just about those 7 to 9 hours. Because if I can have all those features in 4 hours of sleep, and a person who is having a 7 to 9 hours of sleep may still not be having that kind of a good sleep. So that is very, very important. And that is why what does healthy sleep mean is something like this. So it is about the duration, not only about duration that we all agree, it is about timing and regularity. So at the same time, sleep-wake cycle is very important. So you roughly sleep at the same time and you get up at the same time in the morning. So with very few wake-up times in between, say roughly about 10-15 minutes of the total duration, less than or equal to 1 hour variability. So you may get up at 6 usually, but you may get up at 7 sometimes. You may sleep at 10, but sometimes you may sleep at 11. So less than 1 hour of variability is important. The sleep quality is very important, that you lie down in bed and you are asleep within 30 minutes. Max 15, 20 minutes, 30 minutes is it. Less than 45 minutes of wake up after sleep, waking up refreshed. So restorative nature of sleep is very, very important. You may get up tired and you may feel exhausted. That is not a good quality sleep. So even if you had slept for 7 hours, 9 hours, but if you are exhausted in the morning when you get up, my friend, that is not a good sleep. Right? So sleep architecture, as I said, you need to have very adequate N3 phase of non-REM sleep. That is the deep sleep or the slow wave sleep. And you need to have REM sleep, good REM sleep, because these are the ones which are very, very restorative in quality. Sleep environment is important, dark, quiet, cool, no screens in bed. Screen time, 1 hour before getting up and 1 hour after getting up and 1 hour before sleep, no screen time. So that is very important. Daytime functioning, you have to get up alert, energized, no daytime sleepiness. So that is important. So if you are in this auditorium, in spite of all fascinating speakers giving their talks, and if you're still dozing and if you're still yawning, my friends, I'm sorry, you might not have had a good hours of sleep. So key take-home message is good sleep is duration, regular timing, quality, and restorative daytime function. So these are the points that you need to address, and you should ask every patient when you are in their OPD, when you are possibly dealing with a cardiovascular young patient who has a cardiac event, ask him about his sleep quality. That is very, very important, and I believe quite a few of us still overlook that fact. So that is important. So our clinical focus, we are experts at managing the usual suspects. We have been using these points for the past 2.5 days. Hypertension, dyslipidemia, diabetes, smoking, most of the traditional risk factors. We manage them expertly, but we often overlook two ubiquitous risk factors that are already operating silently and but powerfully. One of them is sleep, and the other is stress, which I'm going to address in this talk. So if you look at the short sleep duration, and there are so many studies, multitude of studies which have clearly shown that it actually increases your coronary and even stroke risk. So 48% of coronary heart disease risk, 15% of stroke risk. I cannot emphasize it more. If you look at the cardiovascular risk by the sleep duration, just by the sleep duration, look at here. So right, if you are somewhere here below the adequate hours of sleep, you are actually exposing yourself to almost 50% of cardiovascular increased risk compared to people who sleep well. So this is a very important parameter. And yet, you will find that a significant portion of the risk remains totally unaddressed. So inadequate sleep, chronic stress are actually breaking the shield of your cardiac protection. So these aren't, my friends, just lifestyle factors. They are independent cardiovascular risk factors with very well-established pathophysiological mechanisms. So there is a mechanism to it. There is a science to it. It is not just that it is an arbitrary statement. So what it does is, sleep deprivation unleashes a multi-system physiological assault on your body. It would lead your sympathetic overdrive. It would just go into sympathetic total chaos. It will lead to decreased heart rate variability, and it will lead to increased blood pressure and heart rates across the 24-hour cycles. It will lead to metabolic dysregulation. You have had an obesity masterclass. You have had metabolic dysregulation classes. So they are all something like insulin sensitivity. And all of this increases your cortisol, which just wrecks your system totally and mimicking a pre-diabetic state. Inflammatory activation. So significant elevation of inflammatory markers, CRP, IL-6, TNF, alpha, all of these are ultimately accelerating your atherosclerotic plaque formation. Endothelial dysfunction, very, very important, nitric oxide. So that all of these things, impaired flow-mediated dilation and bioavailability of nitric oxide, this is a very critical step in atherosclerosis. At molecular, cellular level, it has already been proven beyond doubt that this is a physiological assault and you need to address it. And a very important factor which might already been addressed so many times is obstructive sleep apnea. In fact, it is a direct multi-pronged attack on the heart. In fact, it affects 25 to 30% of our cardiac patients, repetitive hypoxemia, intrathoracic pressure swings, arousals and sleep fragmentation. So all of this results in almost 4-fold increased risk of atrial fibrillation. So quite a few patients who actually come to you with lone AF may actually have hidden obstructive sleep apnea that you need to address, you need to identify, and you need to treat it aggressively. And that is very, very important. And in fact, the SAVE trial demonstrated that CPAP, which most of our patients are reluctant to use, actually reduces cardiovascular events even in the high-risk OSA patients. So very important point to be addressed. Now let me move on to the next risk factor. Let us again begin with a question. How frequently do you feel stressed out? I agree most of us are stressed out. I was rushing to the hospital. I was rushing to this theater. I was stressed out, but I could control my stress. How many of you do? So let us find out with these few questions. Very frequently, uncommonly, or never. Are there some rare people who would never be stressed out? Well, maybe, I guess so. There will be a few ones. Let us see. Okay, so most of them are uncommonly stressed. Well, that itself is an uncommon answer as being a doctors here and physicians, but still let us accept it at face value, and then we'll see how do you address it. So there are psychosocial stress accounts for 30% of global myocardial infarction risk. Can you imagine this number? Population attributable risk for myocardial infarction, psychosocial stress. In fact, it is as good as smoking. Can you imagine this? It is as worse as abdominal obesity. And still, we are addressing only the traditional risk factors, and we just simply forget to ask our patients how stressed they are. Usually our young individuals, which Anish Bhai wrote, 38-year-old, 40-year-olds, 45-year-olds, they are all under tremendous amounts of stress, and we simply cannot address it. We simply do not even bother to ask whether you are actually stressed, because that you may not find any other risk factor. In fact, everything will be absolutely normal, but just that single stress factor itself, whether it is at work, whether it is psychosocial, whether it is personal level, whatever it is, that itself may be a causative risk factor for his coronary event or a stroke event, whatever it may be. So chronic stress, how does it do? Again, there is a pathophysiology. So what it does is it ignites arterial inflammation via brain-heart axis. So it is that HPA axis, your hypothalamo-pituitary adrenal axis, which is triggered by this chronic stress, and it actually, heightens your amygdala metabolic activity. Now, this amygdala is a very, very important, marker, is a very, very important part of the brain which actually controls your stress. What it does is that this will lead to emotional instability, lot of effects on the adrenal axis, and lot of your prefrontal cortex is the one which is balancing it. So that is suppressed, this is hyperactive, and that it leads to lot of systemic effects like bone marrow activation. You have leukocyte production, inflammatory cytokines, and you have got arterial inflammation, and ultimately you have got increased risk of. I'm just focusing on cardiovascular. It would lead to multitude of other bodily effects, but yes, cardiovascular outcomes and effects are very, very significant. So it directly triggers, not only that, it would directly trigger your ischemia, arrhythmias, and myocardial stunning. So if you look at stress-induced myocardial ischemia, we have already seen that coronary vasoconstriction, sympathetic overdrive, increased platelet aggregability. In fact, it is found in 30 to 50% of CAD patients, and in fact in mental stress testing, but cortisol often even silently. Arrhythmogenesis, autonomic imbalance lowers ventricular fibrillation threshold, and it can trigger even AF episodes, which is very, very common, and sometimes we fail to diagnose it. Takotsubo cardiomyopathy, I believe it would already have been discussed, and it's a very, very well recognized impact of high stress event, and you can actually have direct myocardial stunning and no other cause except an increased stressful episode for that particular patient. It might even be physical, it might be an emotional stress, it can be even pregnancy sometimes. So we must screen, in short, we must screen for sleep and stress as rigorously as we screen for lipids, and I cannot emphasize it more. If these factors carry risks which are comparable to smoking and dyslipidemia, then why don't we, simple question, why don't we screen them with the same diligence? So we should have cognitive behavioral therapy. We should even give them, chances. How do you do it? Immediate effect is just slow breathing a day. We forget to do it ourselves. 5 minutes a day, 2 minutes a day. If you can do 2 minutes of heavy, slow breathing, 6 minutes, 6 breaths per minute, longer exhales, shorter inhales, just a physiological sigh, even that if you do, that will immediately lower your heart rate, increase heart rate variability, increase your heart rate variability, decrease your blood pressure, decrease your heart rate, and would immediately de-stress you. These are simple methods, and so many methods are already there. Exercise is there, walking in the sunlight is there, if you have nature exposure, so many episodes, so many things that are there at our disposal, but we forget to use it. And we need to emphasize to our patients that they can also do the same. So systematic screening moves these risks from the abstract to the actionable and validated tools. These are the tools that I'm mentioning, and they are all scientifically proven. They can be integrated directly into the clinical workflow. So take time out from your routine clinical questions, ask your patient these points, and most of them you will find would tell you that they are sleeping inadequately, they are not having a good sleep, and they are really stressed out. So these are the screening tools that I was talking to you about. So for sleep disorders, there is something called as the Pittsburgh Sleep Quality Index. It is available on the net. You can download it. Use it for comprehensive sleep quality assessment. Just a questionnaire, put the points down, and you can give it to the patient himself, and he can tell you that he is not sleeping well. Stop bang questionnaire is another one. This is for obstructive sleep apnea people. So it just takes 30 seconds of your and the patient's precious
2 minutes
time.
remaining.
It identifies high-risk patients for whom you would actually address for polysomnography. Perceived stress scale. For the stress, look at this thing. For a brief validated measure of stress. So this is again a stress scale which is available. You can use it. And you can also do direct questioning about your chronic stressors, what is his or her job strain, social support, that is very important. Oxytocin is a very important marker. If you are having a social connect, if you are not very, very lonely, in fact, loneliness is a mortality risk marker equivalent to smoking. Dyslipidemia, 30% increased risk of MIs if you are lonely. So social connect releases oxytocin, and this is a buffer for your cortisol. So that is very important, and you should have a very good social connect, and this is part of our social networking. Not just this, so many social networking angles are there. All of you should use it, for myself as well and for everybody here. That is very important. And these are evidence-based interventions which can actually mitigate the risk and improve outcomes. For OSA, we all know CPAP therapy, put it across to your patients. For insomnia, you can have cognitive behavioral therapy for insomnia, CBT, which is very important. And for chronic stress, you can have a structured stress reduction program. And this would be mindfulness-based stress reduction, like your exercise, like even writing. 5 minutes of expressive writing has been shown that every day if you can do that is a very good stress reliever. Remember, this is a very important, and so many other tools are already there. If you can put into practice mindfulness-based stress reduction, that would actually give you a very good cardiac rehabilitation. So what would you do to de-stress is the answer. Whether would you do nothing, sleep, take help? I think the answer I already mentioned. So this is the science of de-stressing, the biology, sustained cortisol, all of these that I've already discussed. And I believe integrating sleep and stress moves us from actually treatment to prevention. So I'm taking you from treating to prevention. From hypertension, dyslipidemia, diabetes, smoking, sleep health, and stress resilience, I think we will have a better society. Thank you.
Hello. Yeah. Now, according to me, this JIC 2026 will help in networking and will help in de-stressing ourselves. Thank you very much.
Yeah, it was really excellent. And Dr. Vipul, you had the many carry-home message, not for our patients, but for ourselves also, and for our near and dear one also. I just remember one slok from epic Mahabharata. Dharmam janami nachame pravruti. Adharmam janami nachame nivruti. So it's having many pulse of wisdom, and probably it is appealing to everyone. Yes, we have one question from the audience.
My question is for the lipid person. I really enjoyed your talk. In 15 minutes, you really batted 2020. So my question is, why should we measure LPA? Why should we keep measuring all of them? Because at the moment, we don't have treatment. A lot of money is being wasted by physicians, endocrinologists, general practitioners, cardiologists. Because we don't know how to manage LPA. We don't know how to manage the others. So why not just stick to the routine LDL and triglycerides? When you get the drugs, we are more than happy to measure them for you.
Yeah, I mean, a wonderful question, practically relevant, though I made a mention, but let me repeat. So same lipid parameters in the presence of LPA, if it is less than 20, will have X risk. If your LPA is 60, the risk will go to 2 to 3 times higher. So at least at the moment, by getting LPA data, we are doing 3 things. Number one, there is a strong data that if your LPA is high, better and stricter lifestyle modification you do, LPA becomes silent. If you control LDL to a very drastic level, say for example, less than 50 or 30, then at that level of LDL and non-HDL, LPA becomes silent. So these are 2 strong points. So that gives an additional push to us and inspiration to the patient that since you've got something which is non-modifiable, let's modify something which is modifiable. So what I talk to my patient is, say you have got 4 enemies. You have got obesity, you have got LDL, you have got smoking, and you have got LPA. So at least let us kill these 3 enemies so that 4th enemy will be little silent. So that's how I take LPA to the people. Thank you.
Yeah, Anish, Anish, one question from me
one-
on the stage, Anish.
One thing I want to say about
Yes,
the
please.
LPA, at least those who have a family history of premature CAD, they have to must to do, and in their siblings must to do.
Yes.
Must to do.
Totally,
And once done in lifetime, no need to repeat.
totally agree. Yeah.
So what I say to people is get it at least twice or thrice for getting laboratory error out. Because unfortunately in India, we measure not in millimole, but in milligram. And that's a pathetic system. And unfortunately, many laboratories, and unfortunately again, 30 to 50% patients comes with a booklet of 100 reports. That does extremely wrong. So just please get it 2 or 3 times in 2 or 3 different labs. Those who do millimole, it's better, but I take your point. But again, LPA is something to show a patient that your risk is high and let's at least work on lifestyle.
Yeah, Anish, my quick questions. I hope your answers would be quicker than mine. First question is, when should our Indian patient start screening for the lipids?
So all those who do not have family history, 18 years latest, those who have got family history, 10 to 12 years. What I did in my kids is when my son had first prick, I sent lipid profile. So it was maybe 1.5 years when he had some infection. Why not to send lipid profile when the child gets first prick? There is nothing wrong. It's just 400 rupees. I don't say start treating, but even familial hyperlipidemia will be picked up, though rare case. Lipoprotein high will be picked up. By 2 years, 2 and 3 years, it becomes fixed. And you at least understand that this is something which you have to deal with. So sooner the better.
Earliest age to start the statin, and if especially in the female patients, they are planning for the marriage or the conception in the coming time. So what should
So
be
good
your
point. So those who are again familial hyperlipidemia, premature history of family disease, whatever age you have to start lipid lowering treatment. Say for example, a child who has got familial hyperlipidemia, homozygous, LDL is 240, 280. How you can wait to treat that? Because by the time you think to start treatment at 30, he would be dying because of coronary artery disease and atherosclerosis. So no age is a bar. No age is a bar. I have attended and listened to pediatric lipidology. Even 2 years, 3 years, 1.5 years, you have to start treatment because that's the only thing you can do. Or you can let the child have disastrous effect. Yes, pregnancy is an issue because no drug is tested in pregnancy. So what you have to do is, if a female who is at childbearing age, you have to explain that if it is a genuine serious familial hyperlipidemia, 260, 280 LDL, then they are taking little risk of remaining unprotected from treatment, and that unprotected phase can be anything between 1 to 5 years. Because a couple who is desirous to have a child, and the moment they starts unprotected sexual relationship, before 10 to 15 days, you have to get all the treatment out. So sometimes it may take 2 to 3 years. In today's world, where couple are getting late married, 25, 30, 28, they are desirous for child at the age of 30, 33, 34, that period becomes too long. So you have to talk to the people, but yes, you have to stop all the treatment because at the moment there is no child safety data.
Dr. Chandarana, certain dry fruits, almonds, apricots, pistachio, and chia seeds are also useful in reducing the lipid levels in addition to our drugs.
Perfect.
What's your opinion?
Perfect.
And how much you should consume?
It's well established. So two things, it should be consumed by everyone. You have to consider that it's a calorie. It's a good calorie, but calorie. So if your body has a provision for more calorie, take it more. If your body has a provision for less calories, somebody who's weighing 90 kg and obese, he can take 2 badam, 2 pista, 1 almond. Somebody who is Vipul Kapoor can take 100 grams of badam, pista and akhrout.
Sir, when we are to simplify lipid profile, we are talking that should be done. That is, if I go single lipoprotein A once in a life, and second I monitor by ApoB in a cardiac patient, what other things will do? These two simple tests will inform the severity.
Yeah, very good. So as far as lipid profile is concerned, ApoB takes care of all the bad particles, including lipoprotein A. It takes care of everything. And that's why, see, if you attended yesterday's lecture of Dr. Neil Mehta, where he said it is called as discordance. So there are people who got low LDL but very high ApoB. So if you take care of ApoB, I think, and lipoprotein A, everything comes under that. But unfortunately, there are two things. We as physicians are more conversant with LDL cholesterol, non-HDL cholesterol. So we have to keep those things in the market because that's how this science that ApoB and lipoprotein A are sufficient for most of the people, that science will take many, many years to percolate down. And secondly, all the trials have been done based on LDL. I mean, see, if you look to all the trials, they have checked LDL, non-HDL. So very few trials have incorporated ApoB as a primary target. So that's where we have to keep using those things. But I do agree to your point philosophically.
So another question on LP little a. Like to Sir's point on a lighter note, LP little a is like the Gabbar Singh that you use to fear people, right? But on LP little a, example, let's say a person like me checks an LP little a, it's elevated. My parents don't have any significant coronary artery disease, and their LP little a, if I check it, if it's also elevated, then how do you take that value into account?
So good point. Again, so I'll take it as a face value, even if there is no family history, but if lipoprotein A is high, obviously I'll check for other lipid profile, ApoB, etc. But once I'm very sure lipoprotein A more than 75 milligram, consistently proven, you are termed as high risk, no question. And we have to have your LDL less than 50. We have to have a great lifestyle, and we have to have everything there because it hurts. Maybe see, sometimes, see, it's very important. I mean, you know better
2
than
minutes
me.
remaining.
All these are statistics. So in statistics, which 20% people get MI and which 80% do not, that maybe is decided by so many other things and maybe destiny, but we have to correct it, no question.
I think since the discussion was quite warm on LP little a, I just wanted to say a few things. I had an opportunity and privilege to do my dissertation on LP little a way back in 1990 when I was studying in France. Something which I remember because it had been 35 years. This molecule was discovered by Swedish scientist Kerbergs in 70s. And then there was some interest in LP little a, and it was found that this is a major risk factor. And then what we tried to find out that this is not absolutely permanent values. There are modifiable component and non-modifiable component. So non-modifiable is about 70-75%, and modifiable is 20 to 25%. And this, one of the modifiable factor is correction of diabetes. There can be some impact on LP little a. This is one. And number two, about 30-35 years, there was no interest. It went again into, darkness, and once again the interest has started back because now there are some methods to treat LP little a, high LP little a. One of the ways is to treat through plasmapheresis, although it's a very, very expensive method. But if we can give blood transfusion to thalassemia major patients for years together, we can treat patients with very high risk of having or past history of myocardial infarction and having very severe LPA, treat with plasmapheresis and so.
Thank you very much. We have had big discussion on LP little a. We have so much enthusiastic audience and questions, obviously because we are all real practitioners, but we cannot continue till Chanda Mama comes, so we have to stop near Chanda Rana only. And we have realized that Vipul Bhai, like any other Kapoor, Raj Kapoor, Vipul Bhai has told us that there is a Vipul scope for taking care of our sleep, and we must not sleep over the sleep problems of the patients. So thank you very much for patient hearing.
Let's have the moderators, chairpersons, and panelists for the next session. I think this session has ended. Thank you, everyone. It's well done. I think these two gentlemen should be permanently on that dais so that we all of us get elated, because the way you speak for all of us is so encouraging. Thank you.
So
I think it's now diabetes.
One comment. What you mentioned, Dr. Chugh, and we all as executive committee members of the Lipid Association of India, we would say the app is very good. Everyone needs to download the app and use, and you will directly get total details and information and what is required for that patient and risk classification. If 1,000 doctors do 100 patients, we will be having a very big number. And the app is very good. So I request you to download and use the app. Thank you.
Thank you. And I invite the chairperson for the next session, Dr. J.J. Mukherjee, Dr. Mukul Oza, Dr. Manish Agrawal, Dr. Manoj Vithlani, Dr. Tiven Marwa. Moderators, Dr. Hardik Shah, Dr. Ketan Joshi, Dr. Nitin Parikh, Dr. Raghu Satyanarayan, Dr. Sanjay Chaudhary, and panelists are Dr. Bansi Sabu and all speakers.
Good morning. Again, heads off to JIC Organizing Committee for excellent, they deserve big round of applause. Excellent conference. Now for a change, we are going to slight deviating the topic, scenario, and the mood. It's cardiometabolic, basically. So I invite our first speaker, who doesn't know, doesn't require introduction, Dr. Sanjeev Phatak, leading diabetologist of our city, great academician, and we learn many things from him. Sanjeev will give us idea on the comprehensive management of type 2 diabetes. Sanjeev, please.
Thank you, Dr. Mukul Bhai. Thank you, all the chairpersons, colleagues, and dear friend. Good morning, everyone. And thank you, Meringo Sims, for giving me this opportunity, the JIC. Well, we covered this topic day before yesterday. So since I had the privilege of troubling you, I'm not going to bore you with the same slides. So what I'm going to do is switch the gears very fast, and we'll just cover some of the points so that we have more time for discussion as well as the other speakers, allowing them more time to discuss. We know type 2 diabetes is a multi-system disorder, and it requires comprehensive assessment, comprehensive evaluation, and comprehensive management. This we discussed 2 days back. Some of the slides are same. And what we have done is, for comprehensive management and for comprehensive assessment, there are ADA guidelines, recently released in December 2025, the guidance for 2026. They are the ADA practice recommendations. Of course, they are very comprehensive, but little bit confusing also, because if you take into account these guidelines, it becomes very difficult to remember and recall that what patient requires, which investigation, what evaluation, at what point of time, how frequently, and how periodically, and what management strategies we need to change and individualize so that the therapy becomes very effective, not only in controlling his glucose, but for controlling his overall health status, for improving his quality of life, improving the longevity, and as well as reducing the cardiorenal metabolic complications that are associated with that. We know diabetes is a cardiometabolic disease where, let me ask you here, that between ABC, I'm going to discuss the ABC very briefly, the A1C control, blood pressure control, cholesterol control. Which is the most important thing? A, who is in favor of A? That is glucose control. B, that is blood pressure control. And C is the lipid control. I think, yes, Anish has very clearly mentioned that it is the LDL, LDL, and LDL, which is very important. Of course, the non-HDL also, to reduce the cardiovascular, cardiometabolic risk of a diabetes patient. I'll be honest enough to tell you that it is even more important than glucose control. So please don't stop referring the patient to me just because glucose control is not as important as lipid. But lipid control in diabetes patient is very, very important, needless to say that. All the guidelines have clearly shown us that lipid control plays a very important role, not only in reducing the cardiovascular risk, but also the retinopathy risk, to some extent the kidney risk also, and some other vascular disease risk also. So based upon that, we have divided this alphabetically into 10 categories, A, B, C, which we all know. D, E also we discussed yesterday, day before yesterday rather. So I'm not going to touch upon that. So what I will be touching upon today is the follow-up part and the general health part, because these are ignored in our routine day-to-day practice, and these are not discussed in most of the guidelines. We have our own website. Dr. Ajay was asking whether there is an app or not. At present, we do have an app for this, but it is not yet made public. We are trying to do that with little modifications. This is how it looks like, and we have a bird registry, that is the Blue Index registry, so that patient can be comprehensively evaluated. We also reward the patient on achievement of their individual goals, the A goal, the B goal, the C goal, like that. And what we have found is that by doing this, the overall health of the patient, we have seen remarkable improvement. The A1C score goes up, the blood pressure score goes up, that means the blood pressure control becomes better, the lipid control becomes better, the dietary adherence becomes better, the exercise counseling also helps them do more regular exercise. What I'm going to touch upon is the follow-up. The follow-up, if you can improve the follow-up of the diabetes patients, it can have remarkable impact on all other risk factors. A, B, C, the medication adherence, the reduction in the complications, all these are influenced by regular follow-up. And regular follow-up does not require physical follow-up every time. In this virtual world, now we can even have the digital follow-up so that the patient can be monitored as far as the complication prevention or the overall health status, medication adherence, and everything is concerned. With follow-up, you also get a chance to understand the patient's psyche, his socio-economic status, as well as how much the patient will react to whatever treatment which we are giving, whether he is ready for the GLP-1 or not, whether he actually deserves much more detailed evaluation or not. So all this is given importance. And then comes the general health, which is often paid less importance in our day-to-day routine. We always pay more importance to A, that is A1C, blood pressure, and cholesterol. But for a diabetes patient, anemia is also equally important, and anemia due to multiple reasons can be there in diabetes patients we discussed day before. The bone and muscle health are becoming very important these days in the anti-obesity treatment era, not because of the anti-obesity treatment itself, but because of various reasons. And we need to identify this. We need to see their muscle mass, if possible, by the body composition analysis machine. If not, then at least their hand grip and the chair test, which are very easy to do, but very, very rarely practiced in our day-to-day practice. I feel they are very important these days whenever you are targeting the weight loss. The muscle grip and the chair test should be done routinely, at least once in 6 months. Thereafter, the importance of cancer screening comes in our diabetes patient, especially if the patient is having weight loss, if patient is having anemia. These two are the condition, or the GI symptoms. These are the conditions which should open your eyes that we are not missing anything. Not every patient needs evaluation, but at least the patients who are having these three things: anemia, bowel-related problems, recent bowel habit changes, and weight loss, unexplained weight loss. Sometimes we feel that weight loss may be due to metformin or the GLP-1 or SGLT2. But if it is beyond the explanation of all these drugs, we must get into picture some of the cancer-related screening tests which may be appropriate for that particular patient. The diabetes distress, again, which is again a very, very commonly overlooked entity. Dr. Vipul Kapoor will agree with me that sleep deprivation, stress also plays very important role, not only in worsening the glycemic control, but also in some of the complications that are related to diabetes. So distress also plays a very important role. Other endocrine problems, hypothyroidism, hyperthyroidism, cortisol excess also should be given attendance. And finally, but very importantly, the fatty liver disease has become a very, very common entity in type 2 diabetes. So this should also be given due importance. All this will improve not only their cardiometabolic health, but also will improve or rather reduce the risk of the infections that the diabetes patients get. The dental infections are very common, which we often ignore. The genitourinary infections, especially in the SGLT2 era, must be given attendance to. And also the respiratory infections, which are preventable, largely preventable by vaccinations, should also be addressed whenever you are treating any person with type 2 diabetes. And finally, J is the jeopardy. That means the treatment which we are giving, we must counsel the patient for the side effects. We rarely do that. We rarely document that the SGLT2 inhibitors are given. You have explained the genital hygiene to the patient, the importance of the urinary or the genital infections which can worsen the overall health status of the patient, but that is often ignored in the practice. Through this, we have seen that the patients who follow this index, they have remarkable improvement in this score. At present, we do not have any evidence whether it will reduce the complication, but we are trying to generate by repeated studies. What is the complication rate? At present, we do not have any data on that, but the trend is that we are seeing significant, remarkable improvement in their cardiorespiratory, renal, as well as the metabolic disease-related complications. So I'll just cut short the presentation. I'll sum up that with this comprehensive evaluation, whatever way you follow, whatever measures you follow, the comprehensive evaluation and management are absolutely mandatory in every type 2 diabetes patient. You can use some type of index like this. These are not risk markers. These are actually the motivational scores so that patient can be engaged, encouraged, and patient can self-participate in his own health improvement. It will simplify the diabetes care, will take the diabetes care to the patient rather than at the clinic level. With this short note, I will thank you once again for your kind audience.
Hello. Many thanks, Sanjeev, for highlighting the blue index, and which is diabetes not only the centered for the cardiometabolic and kidney, but it's considering the whole body. And the blue index is really, he is the pioneer for the making this blue index and patient-centered care. Big applause to the Dr. Sanjeev. Our next speaker is Dr. Rikin, is a young diabetologist from the SIMS. May I invite Dr. Rikin?
Thank you, Dr. Manoj Vitlani, sir. Diabetes in a young, very common scenario nowadays, so it is important to discuss. I don't have any financial interest. As we all are young, but by definition, young age is 14 to 26 years, that we are currently in the age of childhood, adolescence, and young adult life, a time of growth, learning, and development. Let's start with question. 19-year-old male, 72 kg weight, BMI 25, HbA1c 8.8, grade 60 by antibody, negative. No symptoms, diabetes detected with routine checkup. Which type of diabetes do you label? Normal BMI, young age, 8.8 HbA1c, grade 65, negative. Start the time. Type C Modi. Wonderful. Let's discuss because it needs further investigation. It may be type 2 DM of young, it may be Modi, it may be LADA, or it may be difficult diagnosis. Sometimes there is an overlap of features. So why early diabetes matters? Because currently young diabetes means, as we discussed, it is a type 1 diabetes. It's a number of type 1 diabetes increasing from 1,91,000 to around 3 lakh people by the next few years. But in young age, type 2 diabetes incidence is rapidly increasing because younger diagnosis means prolonged exposure to high blood sugar, long risk of complications of heart disease, kidney disease, and other ASCVD complications, and greater impact in socio-economic and financial challenges. So there is always a difficulty in diagnosis when a patient presents with similar scenario. It may be type 1, it may be type 2, it may be monogenic because it can be present in childhood, maybe family history positive, may present with ketosis, maybe positive antibodies or negative, maybe overweight or frankly obese. As because 6% of youth with type 2 diabetes present with ketosis. It's not only type 1 diabetes. In today, even 10% of individuals who have type 2 diabetes have present antibodies also. And roughly 1/3 of the young with type 1 diabetes are also overweight or obese. So there is a continuous overlapping of differential diagnosis of diabetes in young age. So this is one of the most important slide of my presentation. How will you differentiate different type of diabetes? So type 1 diabetes generally presentation is sudden, while other types of diagnosis, it is generally gradual. Age of detection, in 4 to 7 years of age, there is a first spike, generally type 1 diabetes is detected. Second spike comes at 10 to 14 years. Type 2 DM of young generally presents in 10 to 19 years, Modi less than 20 years, and LADA generally more than 30 years, but they may present around 20s. BMI, type 1 DM and Modi are generally lean, while type 2 DM of young and LADA are generally normal weight or overweight. Autoantibodies are present in type 1 DM and LADA both, but it is negative in type 2 DM of young and Modi. C-peptide, it is very low in type 1 DM and LADA. In other, it is normal or high. Family history is most strong in Modi because there is a 3 generations may be affected, and it is a generally one-sided generation. If mother has diabetes, mother of mother and mother of mother has diabetes, it is generally linear generations are positive. Second, type 2 diabetes is also a strong family history. Other types of diabetes, it is lesser common. Treatment is very much different in all type of diabetes. That's why diagnosis is must. Type 1 DM, as we know, lifelong insulin therapy. Type 2 DM, lifestyle, metformin, and now currently GLP-1 and SGLT2 inhibitors. Modi often responds with small doses of sulfonylurea along with lifestyle and other diet therapies. LADA, they are considered as adult type 1 diabetes. Initially, they may respond with oral agents, but later on they will also require insulin for longer term. So there is a multiple risk factors. We generally more discuss next time will be type 2 DM of young, because generally there is obesity is there, more than 85% BMI, maternal history of gestational diabetes is present, family history of type 2 diabetes in 1 or 2 parents is present. Black, Asian or American Indian are more prone to developing type 2 diabetes of young and associated with insulin resistance. As we see, younger diabetes mean younger duration of younger age of diabetes, younger duration of diabetes. Around 13 years, if you see, there is after 13 years of diabetes, there is increased risk of nephropathy by 55%, neuropathy by 32%, retinopathy by 50%, cardiovascular risk by 50 to 70%, and at least one complication risk is around 60%, and 2 complication risk is around 28% for lifetime. So young diabetes obviously matters. So that's why we require multidisciplinary team. As we alone doctor cannot treat this young diabetes, we require dietitians because nutrition part is very important. Diabetes educator to learn them about the insulin dosage, insulin storage, common errors in insulin delivery. Physicians or nurses required for counseling and regular follow-up. Behavioral psychologist is also required because younger age they do not listen generally easily, and social worker for mass awareness. Treatment approach is generally more than 10 years of diabetes. Primary care screening can treat, but better to refer to patients to multi-speciality. Multidisciplinary clinic have all the team of doctor, dietitians, nutritionists, exercise therapist, along with counselor. There is a lifetime management because nutrition is required and medicines are generally required for the lifetime. And pharmacological support is most important as newer and newer agents now are being approved for the younger age of diabetes. We will discuss in next slides. This is a pyramid approach. Along with balanced nutrition, healthy eating patterns, there is the requirement of decreased consumption of calorie-dense, currently available fast foods, increased requirement of sports activities, particularly in school and colleges. Muscle strengthening exercise is also required. And most important thing is a decrease in screen time. Currently, in our childhood, even much younger age, now there is an average 1 to 2 years of screen time. And eliminate sugar-containing beverages, currently available cold drinks. Second important part, apart from diabetes management, is comorbidity management. As they are prone to higher duration of diabetes, their comorbidities should also be managed, as Dr. Anish Chandran and previous cardiologists managed. Hypertension, nephropathy, neuropathy, lipids, retinopathy, dyslipidemia, NFLD, OSA, PCOS, mental health. So all these components are also be taken care. This is the one of the second most important slide. These all are available molecules which are US FDA approved for type 2 DM or type 1 DM of young. So generally, as we discuss, these are currently all next to next GLP-1 are being approved for younger age. So liraglutide, it is approved for type 2 DM and obesity both, more than 10 years of age, daily injectable, 1% A1C reduction and around 3% weight reduction. Exenatide, twice a daily injectable, currently we are not using much. Phentermine, topiramide, approved for obesity, more than 12 years, around 6 to 7% weight reduction. Dulaglutide, it is approved for more than 10 years in young diabetes. HbA1c reduction is 1.4%, weight reduction is around 3%, and it's a weekly injectable. Semaglutide, it's a weekly injectable available for type 2 and obesity, both patients, more than 12 years. At 68 weeks, with 16% reduction. Is a step teens trial is there. Then empagliflozin, it is approved for more than 10 years of age. It generally, there is reduction of HbA1c around 1% and weight reduction around 1 kg. So you can use all these molecules in type 2 DM of young or adolescents. So summary, youth onset of type 2 diabetes is a unique form of diabetes with rising incidence, rapid progression, high complication rates, and disproportionately affecting minority youth. Clinicians managing youth onset type 2 diabetes should have special consideration for these unique aspects and treat this disease aggressively to reduce complications rates. The ongoing challenges for management in this patient population relate to the few pharmacological therapies. As we discussed in last slides, these are only available pharmacotherapies for type 2 D of young, and lack of therapy shown to reduce the disease progression in this medically unserved patient population. Youth is our future of nation and it needs special attention too. This is our global platform. Obesity School is an academic platform for learning for physicians. We are also available on Android and Apple, both platforms. We are also available on social media, YouTube and WhatsApp community also. Thanks.
Many thanks, Dr. Rikin. Very nice and the informative lecture on by a young diabetologist on young, how you evaluate on young diabetes. Thanks, Rikin.
Okay. So welcome to Dr. Jitendra Patel for his talk on management of diabetes patients in non-critical situations. Dr. Jitendra is very much from Ahmedabad, very well known, very well connected, good friend of all of us. So Jitendra, over to you.
Thank you, Dr. Devenbhai. Good morning, everyone. My topic is inpatient management of diabetes in non-critical setting. The most common comorbidity we encounter in hospitalized patient is diabetes, and what we observe that frequently mismanagement of any problem in the hospital patient is a diabetes, and that is a main independent predictors for the infections, long hospital stays, cardiovascular complications, and mortality. So our goal of inpatient hospital management is a safe, stable glucose control, not perfect HbA1c. So that we have to keep in mind. And I would like to touch that part in my next presentations. And so objective is reviews about the inpatient hyperglycemia definitions. We'll discuss the target glycemic range, also explore the insulin therapy protocols, understand the perioperative and non-critical inpatient management, and emphasize the discharge planning and error preventions. Uh, intri- the intricate challenge of inpatient hyperglycemia, you can see in this slide, around 30% of non-critical ill hospitalized patients have hyperglycemia, more than 140, and which increase the complication, increase the length of the stay, and increase the mortality. So hospital hyperglycemia is associated with these all problems. Hospital hyperglycemia is triad of challenge. So we know that hypoglycemia, hyperglycemia, and glycemic variability, and these will affect the adverse outcome and mortality. So careful management of inpatients' diabetes has direct and immediate benefit. Association between the blood glucose and length of stay and mortality in this slide is very clearly showing that any rise of 50 milligram of blood sugar will increase the level of hospital stay for 1 day. So how important is the control of blood sugar in inpatient is, you can understand. So increase or elevated level of blood glucose is always associated with a longer length of stay and increased mortality. This definition of ADA 2025, hyperglycemia means any hospitalized patient having the blood sugar more than 140 or HbA1c before admission more than 6.5 is labeled as hyperglycemia. So how we can optimize the glycemic control in non-ICU settings? So anti-hyperglycemic therapy, most of the times in hospitalized patient, insulin is the recommended, and preferably IV insulin in critical ill patient and sub-Q insulin in non-critically ill patients. And OAD is not generally recommended. What are the pathophysiology? We all are aware about it, that stress response in hospitalized patient because of the cortisol, catecholamines, cytokines, reduced insulin sensitivity, secretions, certain drugs induce, particularly vasopressor, steroids, also worsen the glycemia, so that we have to keep in mind. These are the classification, typical type 1, type 2, newly diagnosed. The most important is stress-induced hyperglycemia in hospitalized patient, we have to keep in mind. What are the targets for the glycemic control in hospitalized patient? In non-critical patients, the target recommended is 100 to 180, but in critical patient, it has been revised to 140 to 180. And it will be individualized based on comorbidity, age, and the nutritional status. Avoid tight control less than 110 due to mortality risk. So glycemic goal in hospitalized patient, more than 180 milligram of patient, you start threshold for initiating or intensifying the insulin therapy. And this table is very clearly showing by ADA 2025 that in ICU setting, you have to keep the blood sugar between 140 to 180. And in non-ICU setting, you have to keep 100 to 180. In selected patient, it recommended 210 to 140, particularly undergoing cardiac surgery. But in terminally ill patients with a short life expectancy, or having advanced kidney failures, or patient is high risk for hypoglycemia, or having labile glycemic excursion, in that less than 250 is acceptable. In hospitalized patient, according to RSSDI 2022, the most critically ill patient, the guidelines is 140 to 180. In most non-critical ill patient, recommended is 140 to 180. And in selected patient, it recommended to 110 to 140. So insulin therapy, we all are aware about it. The basal bolus is a gold standard approach. In preferred sliding scale, it almost discourage IV insulin infusion in critical and convert to sub-Q insulin when the patient is stabilized. Basal bolus regime, I don't have to teach much about it. We know that basal long-acting insulin available in the market, glargine, detimers, reglutec, bolus rapid-acting meals, lispro, aspart, and regular, and correctional additional insulin when there is elevated of the blood sugar values. We know that insulin infusion protocol start IV insulin infusion if it is more than 180, and the target, as I have mentioned in previous slide, between 140 to 180, and adjust every 2 hourly, and transition to sub-Q insulin once it is patient start eating. And this, when patient is treated with a diet or oral agent before admission, particularly non-critical patient, we have to hold the oral anti-diabetic at admission, and this suggests if the blood sugar between 140 to 200, the 0.4 unit per kilogram body weight has been recommended for the basal, and 0.5 for the between 200 to 400, and in elderly or in renal failure patient, it is on the lower side, 0.3 unit per kilogram of body weight has been recommended. And the total dose has to be divided in 50% as a basal insulin once a daily, same time each day, and 50% as bolus split into 3 doses. Perioperative management is also another big challenge for inpatient hospitalized management. So omit oral agent on a day of surgery, use IV insulin with dextrose during long surgery, restart the usual regime post-op when the patient is stable. Transition from IV insulin to sub-Q insulin is also very much important. So you have to consider when the patient is stable, with when to start the subcutaneous insulin, start 2 hours at least before stopping the insulin, and then you have to calculate the total daily dose requirement. You can calculate either by last 6-hour requirement multiplied by 4, or you can calculate last 24-hour insulin requirements. And you have to calculate 80% of the total daily dose requirement to 50%, 50% as a bolus and 50% as a basal insulin. The simplest and most effective formula for calculating the start dose of basal insulin for all medical officer and in-house resident, fasting minus 50 and divided by 10. As for example, 160 is fasting, minus 50, 110 by 10. So 11 units is normally a starting dose for the basal insulin. This is also comparison of patients who are on liquid diet and those who are taking oral diet. As for a patient weight is 60 kg, the requirement is 24 units, so you have to give once a day. For a patient is taking orally, then divide into the 50-50, the 15 unit bolus and 15 unit you have to divide into 5-5-5. These are the supplement dose calculations. We all are aware about it in the algorithms. We are frequently used to it. So, and the nutrition and nil per oral patients, in that case, always continue basal insulin, decrease the dose by 20 to 30%, hold the bolus doses, use the correction insulin every 6 hours if required, never stop basal insulin in type 1 diabetes, use IV dextrose if needed, and frequent glucose monitoring is required. Steroid-induced hyperglycemia, it is very common in COPD, oncology, autoimmune cases. Afternoon and evening spike are so concerned. So in that case, you have to check that and correct the insulin dose has to be given. Use intermediate-acting insulin is preferable NPH to steroid peaks,
5 minutes
and
remaining.
adjust based on tapering doses. Special population for inpatient are elderly group of patients. So in that case, you have to be very less stringent target. CKD patient, again, you have to be on the very reduced insulin dose side to prevent hypoglycemia. Pregnancy required tight control, 90 to 140. And tube feed patients, in that case, schedule basal and correction dose is required. DK and HS overview is also challenging parts. I think my colleague will touch on that portion. Safety indicators of transition from IV to sub-Q insulin. When you will switch your patient from IV insulin infusion to sub-Q, so you have to look for the stable blood glucose at least for last 6 hours, resolution of coexisting acidosis, hemodynamic stability, stable nutritional plan, and then you can start IV drip rate with very low variability. And unsafe indicator when you cannot switch over from IV insulin infusion sub-Q, when the patient drip rate is with a very high variability of glucose level, drip rates maybe 2 IM requirement is more than 2 units per hour. And even last 6 hours of IV drip administrations, also shorter time periods may not be provided to switch to the sub-Q insulin. Oral anti-diabetic agent in hospitals. So metformin hold if hypoxia, patient having renal dysfunction or using the contrast study. SGLT inhibitors stop if there is a risk of decay and dehydration. Sulfonylurea is to be avoided because of risk of hypoglycemia. DPP-4 can be used selectively. GLP-1 RA is usually stopped. Monitoring and hypoglycemia management is also required. Frequent small checking. Any nil those patients on NBM every 6 hours on steroid. You have to check the post-lunch and post-dinner. Treat if it is less than 70. If patient is conscious, give them oral glucose 15 grams. And if comatose, you have to give 20 ml, 50% IV bolus. And mostly now with the dextrose 10% because of the safer way in less rebound hypoglycemia and better titration for the target glucose controls. Recheck after every 15 minutes and identify the cause and review the insulin dose and the nutritions. And this is the ADA 2025 classifications of hypoglycemia. Level 1 hypoglycemia when there is range between 54 to 69. Glucose concentration less than 54 is level 2. And level 3 when patient having altered mental or physical functioning that require assistance from another person for recovery. Nursing team role is very much required for inpatients management, regular glucose check, prompt hypoglycemia treatment, communications with the physicians, and documentation is very, very. Discharge planning is also very important. Reassess the regimes very carefully, educate the patients on insulin SMBG, ensure the follow-up and prescriptions, and clear return instruction is required. Quality and safety is always required, particularly U500 and U300 insulin available, so you have to teach your patients not to do the mistake. Standardize your order sets and audit hypoglycemia episodes too. Hospital diabetes team, it's a teamwork, physicians, endocrinologists, diabetes educator, dietitian, and nurse requirements. And these are the research advances in inpatient management that AI tools comes into the management, that will be very helpful. Closed loop insulin system, glucotab device supported the algorithms, basal insulin, open APS loop Android apps for type 1, and iLet dosing decision software. Key takeaway message for my talk is individualize the glycemic target, prefer insulin-based regimes, avoid hypoglycemia, and plan the transitions and educations early. Thank you very much.
Thank you, Jiten bhai, for a nice, very detailed, intensive talk on a non-intensive problem. With this, we move on to the next talk. Dr. Vivek Patel, who is an endocrinologist, he is going to speak on critical care patients having diabetes or diabetes in critical care setting. Vivek.
Thank you, sir, for this kind word of introduction. After an excellent talk on diabetes management in hospital setting in a non-critical patients, I would be talking on a critical care patients. So the critical care setting in diabetic patient could be of two. One is a diabetes related that includes diabetic ketoacidosis, hyperglycemic hyperosmolar state, and the severe hypoglycemia. And also it could be a non-diabetes related conditions in which patient is required to admit into ICU in a critical condition, but patient is not, the condition is not related to diabetes, and I would be mainly touching on the non-diabetes related conditions. So what are the recent changes in the ICU hyperglycemia management? The first thing is target refined, or we can say it's redefined. So previously it was, as sir has mentioned, the previous targets were between 100 to 140 for critically ill patient, but now it has been shifted to 140 to 180 in a critically ill patient because more aggressive and more liberal targets have been associated with increased risk of mortality and morbidity. Stability over the absolute numbers, so we need to focus on glycemic variability rather than the absolute numbers, and many of patients who are coming with the newer pharmacological agents like SGLT2 inhibitor and GLP-1 analog, we need to be keep an eye on that kind of patients, and which requires extra vigilance in these patients. So what is the challenge of ICU dysglycemia? So hyperglycemia that is defined as blood glucose more than 140 milligram per deciliter is almost universal finding in majority of ICU setting patients, and dysglycemia comprise of both hyperglycemia, hypoglycemia, as well as the glycemic variability. And this dysglycemia is a major contributor for morbidity and mortality, with hyperglycemia increasing the risk of infection, multi-organ failure, increased risk of prolonged ventilation as well as the prolonged hospitalization. With hypoglycemia increases the risk of cardiac events like arrhythmias, and high glycemic variability is associated with more oxidative stress than the sustained hyperglycemia, and therefore all admitted patients in the ICU must be screened for hyperglycemia regardless of their diagnosis. This is the classification of ICU hyperglycemia. It can be categorized into three categories: known diabetic patients who are admitted for non-diabetic condition, the undiagnosed diabetes in patients who is admitted with a hyperglycemia of more than 140 milligram per deciliter, but first time diagnosed to have diabetes with HbA1c of more than 6.5, and the stress hyperglycemia in which patient is having blood glucose more than 40, but the HbA1c level is less than 6.5. It is a marker of acute illness severity and associated with higher mortality in non-diabetic cohorts. So this is a well-known established study which has shown that hyperglycemia is an independent marker of in-hospital mortality in patients with undiagnosed diabetes. And here you can see at a similar level of hyperglycemia, the patients who are having stress hyperglycemia are having higher mortality, especially in ICU care setting, because the more severe hyperglycemia in a non-diabetic individual, it indicates the more severity of an underlying illness. This is a landmark trial, that is NICE Sugar, included almost 6,000 patients, which have shown that more intensive glycemic control of 80 to 110 milligram per deciliter is more harmful, with increases risk of 90 days mortality with severe hypoglycemia, around 15 times more hypoglycemia happening with the intensive control, and therefore the moderate control of glycemic target of 140 to 180 milligram per deciliter were established. And subsequent many meta-analyses have shown there is no additional benefit of intensive control in terms of sepsis or renal failure. However, there are few recent trials, they have tried to established new criteria depending on the availability of newer monitoring systems which are available with us. So first was the individualized target hypothesis, in which the controlling trial, the concept of that patient baseline HbA1c glycemia should be targeted with the ICU management. However, in this patient, they have no additional clinical benefit but increased risk of hypoglycemia. And what they have concluded is that the patient's chronic baseline is not the optimal target for the acute physiological stress. Another trial, they have tried to reduce hypoglycemia by relaxing the range. That is the Lucid trial. They have targeted very high range, around 180 to 250 milligram per deciliter. However, it increases the risk of mortality in favor of reducing risk of hypoglycemia. Again, the 2026 guideline has reaffirmed that the 140 to 180 should be the ideal target and the most balanced, with minimum risk of hypoglycemia and the best mortality and morbidity outcomes. So how should be treated in a critically ill patient? The hyperglycemia should be treated. So the continuous IV insulin should be the gold standard therapy for this kind of patient. Because of its rapid onset, shorter half-life, easy titrability, and it is most reliable treatment for critically care patient for hyperglycemia. But how we should titrate the IV insulin set? So first is a linear algorithm. The linear algorithm which we see commonly, that for a fixed level of hyperglycemia, you give the fixed dose of insulin infusion rate. However, these fixed rate are though simple, but it increases the risk of hyperglycemia and the hypoglycemia. It is just like using a sliding scale in non-critical ill patient. And therefore, a dynamic algorithm is more appropriate, more balanced, which minimizes the risk of hypoglycemia. This dynamic algorithm takes into account patient's rate of change in the glycemia and patient's current rate. The newer systems like computerized system and AI systems are in the process of coming into the picture. Initial infusion rate should be patient current blood glucose level divided by 100, and the monitoring frequency should be at least 1 hourly in the initial phase. So this is the preparation: 50 units of regular insulin dissolved into 50 units of 50 ml of NS. There is no additional advantage of using analog insulin when we are giving IV insulin. However, during the transition phase, it is always better to have analog insulin with us. Intravenous insulin infusion should be done with the insulin pump. The priming is very important to saturate the insulin binding site in the tubing. The initial rate should be current blood glucose divided by 100, monitoring every hourly. Also, we have to focus on potassium level because of the risk of hypokalemia. And if patient is not taking orally anything, then again, we need to give some dextrose also. And this is the algorithm which is given by the RSSDI, and which is very
5 minutes
simple
remaining.
algorithm to guide the IV insulin therapy. It takes into account the current blood glucose, the previous blood glucose, the rate of change, and the current rate of insulin infusion. And by using this algorithm, you can very easily achieve that target sugar of 140 to 180. The transition from IV to the subcutaneous insulin is a very critical period. We need to assess the stability of the patient. We need to calculate total daily dose from preceding 6 to 12 hours and thereby switch to the basal bolus insulin. Very important is the overlap. Whenever we give the basal insulin, it takes around 1 hour, 2 hour time before it takes into effect, and therefore the overlap of around 1 to 2 hours should be there so that patient should not go into the rebound hyperglycemia. 2 molecules, newer pharmacotherapy, SGLT2 inhibitor, risk of euglycemic diabetic ketoacidosis is there. The mild hyperglycemia would be there. Blood glucose level would be less than 200, but patient might be having metabolic acidosis. And the current recommendation are hold SGLT2 inhibitor for at least 2 to 3 days prior to any elective surgery. For patients who are admitted for any emergency condition, stop SGLT2 inhibitor immediately. The only exception are the heart failure patients who are stable, eating well. In those conditions, we can continue to use for heart failure management. Another is the GLP-1 analog. It increases the, it delays the gastric emptying, and because of that, there is increased risk of aspiration, pneumonitis. And for injectable therapy, it should be hold before the surgery, and for weekly injection, it should be stopped at least 1 week prior to the surgery. For special population, glucocorticoid-induced hyperglycemia, it is associated with fasting Hypoglycemia with daytime hyperglycemia, particularly post-lunch hyperglycemia is there, and we should be matched with intermediate acting insulin like NPH. For enteral and parenteral nutrition, patient is receiving continuous glucose load, and therefore the continuous IV insulin should be the preferred choice in this kind of patient. For cardiac and neurosurgical patient, for cardiac patient, again, those patients who are undergoing cardiac surgery, the target should be slightly lower to prevent the wound infection. And for neurosurgical or neurological patients who are in ICU setting, the avoidance of both hyperglycemia and hypoglycemia are of paramount importance. Now, few words regarding the use of CGM in critical care setting. So it came into the picture when the COVID pandemic was going on. There were a few trials which have shown that it reduces the healthcare professional exposure to the patient. The frequency is improved because of the continuous glucose monitoring. It gives the real-time values and trend of the glucose values. The hypoglycemia detection is very early, and the staff burden is less. However, it comes with some of the limitation because of the physiological lag. There is around 15 minutes lag to the capillary blood glucose and the interstitial blood glucose, which is measured by the continuous glucose monitoring system. The perfusion issue, many of the patients are having inadequate perfusion in the subcutaneous tissue, and therefore the values might not be very much clear, and medicine interference are also there. So currently guidelines are suggesting the hybrid approach of using CGMS in the hospital care setting. The do's are, it should be used for monitoring the trends, it should be validated with the point of care device, and it should be protected from the compression lows, and it should not be used for measuring the insulin dosage. It should not be relied on in patients who are hypotensive or hypothermic, and this continuous glucose monitoring device are currently not feasible with the MRI or CT scan or even electrocaution. Therefore, it should be used very cautiously in these conditions. So the take-home messages are hyperglycemia occurs frequently in hospital settings, both in patients with or without diabetes. Proactive treatment is required. Target should be 140 to 180 milligram per deciliter, and IV insulin protocol should be the best method to achieve that target. The smooth transition from IV to subcutaneous insulin should be of paramount importance. The modern pharmacotherapy risk should be kept in mind. CGM is useful but have some limitation, and therefore hybrid approach is preferred in selected patients. Thank you.
Thank you. Excellent presentation, Dr. Vivek. Please be on dais because your help will be required during the panel discussion. And now next we have a speaker straight from Kolkata. He is not only prolific in knowledge, aggressive in his thoughts, but also a very, very lucid speaker. He makes you think or rethink how we practice. So fasten your seatbelts and be ready to listen to Dr. J.J. Mukherjee.
Thank you, Dr. Sanjeev Pathak, and I think I'm honored and privileged to be amongst you. All the luminaries from SIMS Hospital, I'm only the odd man out. I was passing by, I was in Swasthakon, and Sanjeev caught me. Hey, JJ, tu aa raha Swasthakon mein? Maine aa raha hu. Tu SIMS mein bhi aa ja. So that's why here I am. You have had a lot of sessions on obesity already, right? And for the next 5 years, you like it or not, whichever hall you go, there will be a session on obesity, because tons and tons of medicines are coming. We didn't discuss about, I did not give too many lectures on obesity. Why? Because we did not have any medicines to treat with. And now, bang, in this year, we have 2. And in the coming 4 to 5 years, there'll be plenty such molecules coming. This is a sponsored symposium, Lilly-sponsored symposium, so we will be sticking only to tirzepatide, but during the question-answer time, free for all. Jo man mein pucho. So what I'm going to discuss now is SURPASS-2, paving the way for HbA1c and weight. And before I start, just by a show of hands, how many of you in this room are using tirzepatide? Ahmedabad, doing very well. Good. So Lilly people, maybe, okay. So paving the way, HbA1c and weight while being superior to GLP-1. Those of you who have been to all these Lilly sessions know why I'm discussing SURPASS-2. Anybody can guess why I'm discussing SURPASS-2? There are 5 SURPASS trials. Why? Because it is a head-on comparison with semaglutide, the only other anti-obesity medication which is licensed, GLP-1 medication licensed. As I said, Lilly-sponsored symposium. I have received honoraria from a number of companies, so I will try to be as unbiased as I can. Before I go into incretin, you should know that as of now, there are only 6 molecules licensed anywhere in the world for managing obesity: naltrexone, bupropion, phentermine, topiramate, orlistat. And there are 3 injectables: liraglutide, semaglutide, and tirzepatide. So all 3 are incretin-based. So that's why my first slide is on incretin. Out of these 6 molecules, only 3 of us are available to us in India. We have orlistat, semaglutide, and tirzepatide. That's all we have. And that's why in Swasthakon yesterday, I was asked to speak on orlistat. Reason is very simple. Because many of our patients, even if you want to give semaglutide or tirzepatide, you just can't give because of the cost. But those of them who can afford, like people in Ahmedabad who are quite, rich, I saw so many hands going up for tirzepatide. Well done. So for them, this talk begins. So what is incretin effect? Very, very old concept. Everybody in this room knows. I don't want to bore you. If you take glucose orally, the amount of insulin secreted is much higher than if you take insulin intravenously. You get the same amount of glucose excursion. Why? Because of the incretin hormones. The first incretin hormone to be discovered was GIP. Initially, it was called gastric inhibitory polypeptide. Later on, it was found that its role is not more in gastric inhibition, but more in glucose control. So it became glucose-dependent insulinotropic polypeptide. And the other one, which most of us in this room know, is GLP-1. We talked about GLP-1, GLP-1, GLP-1 all this while. And lo and behold, tirzepatide comes, and now we're all waking up to what is GIP, how does GIP control blood sugar? And if you ask me questions in the panel, I will find it difficult to answer, but we'll try. So this is the incretin effect. If you see on the right-hand side, the hormone secretion when you're giving glucose orally, insulin secretion is higher, and that is mediated by the next 2 graphs. The first one is GIP, and the second one is GLP-1. So both GIP and GLP-1 are the incretin hormones, and if you see in this slide, GIP, when you eat glucose, when glucose goes, it causes insulin secretion, but that is only 1/3. Majority of the insulin that will be secreted when you have your lunch today, postprandially, will not be the glucose, will be your incretin hormones, the L and the K cells, the GIP and the GLP-1. And amongst the two, GIP has got a much bigger contribution to postprandial insulin secretion than GLP-1. If you can see the percentages there, 44, 33, and 22. So twice the effect of incretin-mediated insulin release is by GIP rather than by GLP-1. So it begs the question, why did we keep running after GLP-1, GLP-1, GLP-1 agonists for the last 20 years? All the molecules we have used, liraglutide, semaglutide, they're all GLP-1 agonists, single receptor agonists. Why did we not think about GIP-1? The reason being, there is decreased incretin effect in people with type 2 diabetes. Everybody in this room knows that. Not in everybody. Nothing in medicine is 100. There are people who have incretin effect. So once this decreased incretin effect happened, the first molecule to be discovered, incretin molecule was discovered, was GIP in 1970. GLP-1 was discovered in the 90s. Initially, people did try GIP in mouse model, in rabbit model. And what they found was giving intravenous GIP to people to animals made diabetic, there was no increase in insulin secretion. So the concept was GIP resistance, just like leptin resistance. So people thought giving incretin was not going to work, and people were giving away. But then some people worked on GLP-1, and lo and behold, GLP-1 did good work. It showed insulin secretion, and for the next 20 years, we kept talking about GLP-1 agonism. But people didn't give up. They kept working on GIP agonism, and I don't know, serendipity, whatever you call it, they hit on a couple of molecules which stimulated both the GIP and the GLP-1 receptor, and to their surprise, instead of sugar going up, instead of lipids going up, that's what you would expect with GIP. GIP is a lipogenic hormone. They found the opposite. Sugar's going down, weight going down. Theories are still being developed as to why that happens. So that's why we now have a single molecule, which is a twin incretin now. It's acting both on the GLP-1 receptor and the GIP receptor. And as I told you, if you attend more and more conferences like you're attending this one, in 2-3 years' time, you'll be hearing about twin incretins, 4 receptors, and already people are working on 5 receptors for management of obesity. So I hope you've read this slide by now. GLP-1 and GIP, what it does, it's a stock slide. I mean, every meeting you go, you must have seen this slide 100 times. What does GLP-1 does? Acts on the central nervous system, reduces food intake, increases satiety. My clock didn't start. मेरे पास पूरा दिन है, sir. You forgot to start the clock. सुनना है क्या? मेरे को बोर हो जाओगे. and increases nausea. If you come to pancreas, causes increased insulin secretion, and this is where the difference lies. If you see on the right-hand side, GIP is effect on glucagon and effect of GLP-1 on glucagon. GLP-1 reduces glucagon, whereas GIP increases glucagon. Delays stomach emptying. We all know the GLP-1 effect. The difference with GIP is its action on the adipose tissue. That's the difference between GLP-1 and GIP. It increases insulin sensitivity on the adipocytes, increases lipid buffering capacity, increases lipid blood flow, and it reduces the pro-inflammatory immune cell infiltration. So that brings us to the molecule tirzepatide, which I'll take the trade name only once. As I said, sponsored symposium, Mounjaro. It's based on a native GIP sequence. So its effect on the GIP receptor as opposed to GLP-1 receptor is 5:1. It's 5 times more GIP active than GLP-1 active. That's what the second line says. Half-life is 5 days. That's why we use it once a week. This last line is not probably entirely true. No dose adjustment for tirzepatide and recommended renal or hepatic impairment. That is probably not true. In people with end-stage kidney disease or end-stage liver disease, child C, I would not be using tirzepatide. Tirzepatide basically does exactly what GLP-1 does with the addition of GIP. So I think this is an exam slide. If you're asked in the exam, you have to give this answer. Central nervous system decreases appetite, decreases food intake, decreases liver fat content. We can have this discussion later on. Increases insulin secretion, decreases glucagon secretion, decreases gastric emptying, increases insulin sensitivity mostly in the lipids. So this brings to the trials. Any new drug which comes into the market has to have a lot of regulatory trials. So tirzepatide has got 2 major trials. One of them are called SURPASS. SURPASS are trials done in people with type 2 diabetes, various combinations. If you start reading from the top, what are the various combinations they've tried? Most molecules have done that. Take a SGLT2, take a DPP4, take semaglutide. They all have done these trials. And all have some catchy names. All the semaglutide were step 1 trials. Here they're called SURPASS trials. The other trials they have is, this molecule is used not only for management of diabetes, but also for obesity. Those trials are called SURMOUNT trials. There are 5 SURMOUNT trials, which I'm not going to discuss today, because it's a diabetes session, so I'm focusing use of tirzepatide in people with diabetes. So SURPASS 1, every new molecule has to study against a placebo in people with type 2 diabetes, and that was SURPASS 1. SURPASS 2, why we are going to discuss today, because it is comparing with the biggest competitor which tirzepatide has in the market now, which is semaglutide. SURPASS 3 is with insulin degludec. See in the background, they're on metformin plus minus SGLT2 inhibitor. SURPASS 4 is versus insulin glargine, and SURPASS 5 is again in combination with insulin. You all know the ADA guidelines. You must have heard it being repeated time and again that before you insulinize a patient, you should think of adding a GLP-1, GIP agonist before you think of insulin. I think what the guidelines forget to mention is provided your patient can afford it. I think that's should be mentioned in capital letters. So we are talking about people who can afford. So coming to SURPASS 2 trial. It is a head-to-head trial versus semaglutide. Again, by a show of hand, how many of you have heard the SURPASS 2 trial before? Not many. So those who have heard, please humor me, because I will be going through the basics in that case, because many have not heard about it. So SURPASS 2 is tirzepatide 5, 10, and 15 milligrams versus injectable semaglutide 1 milligram, not 2.4, because it's a diabetes trial. As an add-on to metformin. So people were on metformin, and then they were randomized to 2 arms. One arm was tirzepatide, the other arm was semaglutide. On the left-hand side, you see the baseline. Always see the baseline in any diabetes trial, because higher the HbA1c, bigger is the HbA1c drop. So baseline HbA1c is important, it's 8.3. Duration of diabetes is 8.6, little bit odd. These are people only on metformin. Generally, you do not have people on a single drug for almost 8.6 years. But that's how it was in this trial. Baseline BMI was 34, a little bit high from our Indian standards. And quite a large number of patients were enrolled. Whenever you use semaglutide or tirzepatide, you have to go very, very slow, because those of us in this room who are using it know that they cause bad GI side effects. If you don't go up, titrate the drug slowly, you will lose the patient. So there were 4 arms, 5 milligrams, 10 milligrams, and 15 milligrams of tirzepatide, and semaglutide 1 milligram. went up gradually, as you can see, 2.5, 5, 7.5, 10, 12.5, and 15 for tirzepatide. So you can imagine, to reach 15 milligrams, you've already got 5 months gone. So such a long, you need a long trial. And for semaglutide, it was 0.25, 0.5, and 1 milligram. So these were the titrations done. It's a 40-week trial. Primary endpoint, it's a diabetes trial, so weight loss was not the primary endpoint. It's not an obesity trial, it's a diabetes trial. So HbA1c reduction was the primary endpoint, weight loss was a secondary endpoint. This is the picture slide. If you want to compare 1 milligram semaglutide with tirzepatide, just 5 milligrams of tirzepatide is better than 1 milligram of semaglutide in people with type 2 diabetes, with an HbA1c of 8.3, with an 8.6 years duration of diabetes, given metformin, if you add semaglutide 1, or if you add tirzepatide 5, both given weekly injections, tirzepatide 5 statistically significantly reduces HbA1c minus 2.1 as opposed to minus 1.9. You will say 0.2% kya farak padta, Dr. Mukherjee. It applies statistics because it's only 40 weeks. If you put that over 40 months, it will make an effect. So that's where statistics comes. If you can up titrate to 10 milligrams, you can get a better HbA1c reduction. We never thought of these kind of HbA1c reductions till about 5-10 years ago. We used to talk about HbA1c reduction of 0.5, 0.6, SGLT2 0.7, DPP4 0.6 to 0.8%, maybe metformin 1.1%. But now look, we are talking about HbA1c reduction of minus 2.2, minus 2.4, minus 2.5. If you are using tirzepatide for diabetes management, the difference between 10 and 15 is not much. By 10 milligrams, you've already got a reasonably good glycemic control. As to what happens to the weight will come later, but with regards to glycemic control, 10 milligrams is probably sufficient enough. This is the graph which tells you how quickly you can get the glycemic control. Look at number 4 weeks. By 4 weeks only, you have dropped the HbA1c down by 1 to 1.5%. Magic. Pehle nahi hota tha ye sab. Now with GLP-1 and the twin incretins, you can get, this is as good as insulin. I mean, insulin is of course better, as you just now heard our speakers say. It happens within minutes to hours. This is happening within weeks. You're getting an HbA1c reduction of as much as 1 to 1.2% just by 4 weeks. And look at the values you're reaching. 6.19, 5.9, these are not bacha diabetics. Huh? These are people with 8.6 years duration of diabetes. They've lost quite a bit of their beta cell function. They started with an HbA1c of 8.3. It's not like कि कल बच्चों को diabetes हुआ HbA1c 6.6 है. The 8.5 years diabetes, 8.3 HbA1c, and look what you have done to the HbA1c. 6.2, 5.9, diabetes gaya 5.8, in remission on drugs. The next thing which you will tell your patient asks, Doctor Sahab, kitna weight ghatega? So what you should be very, very careful when you're using these drugs. You should tell them that about 1 or 2 in 10 chance, you may not lose weight. You may not get good glycemic control. So look, HbA1c less than 7% is happening in 86% of people if they take 5 milligrams. And if they can tolerate and afford, and go up to 15 milligrams, up to 92%. Not everybody. Eh? So don't go and start telling your patients कि one drug दे दिया diabetes बिल्कुल control हो जाएगा 5.2 हो जाएगा. Some people do not respond. This is HbA1c of less than 7%. Look at the last one. HbA1c of less than 5.7. Look at the rightmost column. Semaglutide does not do bad. 20%, 1 in 5, will go down to 5.7. Again, stretching the fact. People with type 2 diabetes, BMI 34, 8.5 years of diabetes, 8.3% HbA1c, only on metformin. You added 1 milligram of subcut semaglutide only for 40 weeks. And 1 in 5 gets HbA1c of less than 5.7. But look at what tirzepatide does. If you can go up to 15 milligrams, half of them. So all these complications we are discussing, liver, kidney, heart, they won't get gayab, but they will reduce in frequency. So that was the glycemic part. What about the weight loss part? As I told you, weight loss was a secondary outcome in the SURPASS trials. All of you should know that weight loss in people with obesity and diabetes versus people with obesity, no diabetes, same BMI. But if you have diabetes, the amount of weight loss is generally half. If a person with obesity without diabetes loses 10 kilograms, a person with the same amount of BMI, same age, with diabetes will lose to the tune of about 5 to 6 kilograms. So keep that in mind. Keeping that in mind, look at the SURPASS-2 data. Look at the weight loss. On the top, it's in kilograms, and below it is in percentage, because baseline weight was 93.7 kilos. BMI was 34. Look, with 5 milligrams, you're getting a 8.5% reduction. Semaglutide doesn't do bad with 1 milligram. They're getting a 6.7% weight loss. So if you're using 5 milligrams for glycemic control, it's better. But if you want a little bit bang for your money and got a better weight loss, then look at 10 milligrams. You get 11% weight loss, and with 15 milligrams, you get almost 13% weight loss. Obese people with diabetes, 8.5 years, only on metformin, 8.4% HbA1c, 94 kilograms weight. You manage to give them 15 milligrams of tirzepatide for 40 weeks. You make them lose 12.4 kilograms weight. So nowadays we talk about composites. So what are the composites? The composites are designed by the company. Whatever suits them well, they make that composite. So what is the composite here? More participants in the composite endpoint, which was HbA1c less than 6.5, weight loss more than 10%, and of course no clinically significant or severe hypoglycemia, which is quite rare. Tirzepatide 5 milligrams gives you all three outcomes put together in 1 in 3. If you can go up to 10 milligrams, half. This is quite nice actually. Half the people with type 2 diabetes, weight almost 95 kilos, 8 years duration, 8.4% HbA1c, you give 10 milligrams of tirzepatide for 40 weeks, half of them will get an HbA1c of less than 6.5 and lose 10% of their body weight. And if they can go up to 15 milligrams, which not many people can, then that is about 60%. Semaglutide doesn't do bad, but it's way inferior at about 1 in 5. So then brings the last 2 minutes, Chairperson sir, brings us to the complications. हर कुछ जिंदगी में इतना अच्छा नहीं होता ना, सब कुछ अच्छा है, अच्छी बीवी मिल गई, अरे नहीं बाबा, थोड़ा उल्टी साइड में खोल के देखो, there will be some side effects. And everybody in this room who has used a GLP-1 receptor agonist knows the side effects are GI side effects. You have to titrate the drug slowly, go once every month, increase the dose, don't rush out. Nausea, if you see. Let's take 10 milligrams of tirzepatide. Let's read 10 milligrams of tirzepatide and semaglutide 1 milligram. These two columns, let's read. So nausea, 1 in 5 in both the groups. So every 100 people you start, 20 will complain of nausea. So you have to forewarn your patient. Diarrhea. This is something which doesn't go off. 1 in 7. Vomiting, 1 in 12. The others are dyspepsia, decreased appetite, constipation, and abdominal pain. The purpose of showing you this slide is, it's a head-to-head comparison. There's all this talk कि tirzepatide से थोड़ा ज़्यादा nausea होता है, sema से थोड़ा ज़्यादा diarrhea होता है. Maybe that's your personal opinion, but in this trial, 40 weeks, randomized trial, if you look at the percentages, it's exactly the same. So to say one molecule has got more GI side effects, one molecule has got more diarrhea, you will hear that. When you go to different meetings, you will go to RSSDI, you will go to ESI, you will have other speakers standing here who will tell you that maybe tirzepatide causes more diarrhea, semaglutide causes more vomiting, more nausea. Maybe that it's all individual experience, but if you see a randomized controlled trial, they're almost the same. Hypoglycemia, almost negligible, because we told you it's glucose dependent. So sugar starts going down, the drug doesn't cause hypoglycemia. So my summary slide. Tirzepatide is the first and only approved single molecule GIP GLP-1 receptor agonist. Any more are in development? Yes. How far are they? They're quite far behind actually. A couple were tried before. I won't name the names, and they just went out of the race. Something very peculiar about this combination that tirzepatide has. 5:1 GIP versus GLP-1 stimulation, which does all these wonders. Superior HbA1c reduction, I hope I've convinced you, all of you, with all 3 doses studied, 5, 10, 15 milligrams, versus 1 milligram injectable semaglutide in people with type 2 diabetes, and the maximum reduction was minus 2.5%, more than 2/3, reaching an HbA1c of less than 5.7%. And if they can continue, God knows what will happen to our cardiologists, and oh my God, full of cardiologists, the room was full of cardiologists. Superior weight reduction with all 3 doses studied up to 12.4 kilograms, and safety profile is similar to semaglutide, 1 milligram. With that, I'll stop. Thank you for a patient hearing. Any questions we'll have?
Thank you very much, Dr. JJ. In your usual style, you have covered the subject so well. There will be many questions to all the speakers, but unfortunately, since we are running late, we'll be postponing this session to the next one. And meanwhile, it's over to the organizers for the next session. Thank you all the speakers for sticking to their time and for the precise presentations. I request all the, yes, sir.
Yeah, sorry. I would request all the panelists to stay in-house, either in the auditorium, and if some of you can stay here on the podium too. I would request all of you to stay back for 1.5 hours, maybe even less than 1 hour, to finish the next session. And we'll have open session for a lot of question answers which we were not able to address. So hang in there. Last session is nice, very varied, from weight loss to research to hypertension guidelines. So hang in there. Dr. Bhavin Dalal, please. And the next panelist chairman can come on the dais, please.
Hello. Before Dr. Bhavin starts, let me put a point. JIC 27, dates already defined, 8, 9, and 10th January 27. So please block your calendars. We'll be there back, and you will be there back with us. Thank you.
Good afternoon, everyone. So my talk is about the critics of the famous randomized controlled trial. I think you guys are hearing a lot of randomized controlled trials, like you just heard from Dr. JJ regarding the 4 different arms, and every study have their own critics or the advantages and disadvantages. I will show you a few examples how you can interpret the study for your clinical practice. So this is my disclosure. I have an audience response questions if you have those things. 55-year-old guy who has a hypertension and diabetes came to the hospital with a cough, body ache, and fever, 101 degree. Heart rate was high, respiratory rate was high, the blood pressure was okay, 110/70. Was admitted in the ICU for hypoxemic respiratory failure, requires 3 liters of oxygen, nasal cannula, and the saturation was 95 to 96% on 3 liter. This is a chest X-ray. So apart from the antibiotics, IV fluids, which of the following improves mortality? Is it 200 milligram hydrocortisone IV, 125 milligram solumetrol IV 3 times a day, 10 milligram dexamethasone IV daily, or none of the above? Thank you. Does that work, this thing? No. Timer there? Oh. Thank you. You guys have those clickers? Wow, okay, that's very nice. That majority of you are saying none of the above, but a few people are saying either A or C. So how did we learn this thing? We know that the famous randomized controlled trial was published in 2023 in New England Journal of Medicine, and it was for a community-acquired pneumonia. Patients were randomized to receive either the placebo or the hydrocortisone. So why you guys did not choose the hydrocortisone? That did actually show improvement in mortality. The people who received hydrocortisone for community-acquired pneumonia, which was a diagnosis for our patient, did improve mortality. So why the correct answer is not the hydrocortisone? Why it is none of the above? Like a lot of people chose the correct answer. Why? Anybody? Sorry? It is rapid and short, but it was studied that exactly the option was. In the Cape Cod trial, if you can see the hydrocortisone in community-acquired pneumonia, the correct answer was none of above because it was studied for a severe community-acquired pneumonia. The case I gave you was actually of a mild community-acquired pneumonia. If the patient is admitted in ICU, that does not always mean that the patient will have a severe community-acquired pneumonia. I mean, depending on the different geographic locations, people can be admitted in a progressive unit or a step-down unit, or people sometimes even not admitted, but that all depends on the geographical situations. They define the severe community-acquired pneumonia with this criteria, that if the patient is on a mechanical ventilation requiring more than 5 of PEEP, or if the patient is on a high-flow nasal cannula, or the PF ratio was less than 300, you know, the one I gave you, 3 liter oxygen, 95%, probably the PF ratio is not less than 300, or the pneumonia severity index of more than 130, then they actually got the benefit. So the case of a pneumonia or a community-acquired pneumonia I showed you was not a severe community-acquired pneumonia. That's why I have chosen the none of the above answer. What I'm trying to explain, that just don't look at the title that the hydrocortisone improves mortality, because I am seeing this common clinical practice here as well as in US, that every time the patient comes with a community-acquired pneumonia, people are starting on a steroids. Steroids might be actually harmful. For example, if you have an influenza pneumonia, out of even a community-acquired pneumonia, if the specific microbiological diagnosis is influenza, when they gave a steroid to the people with influenza pneumonia, there was higher mortality. So whenever we interpret the study, whenever we look at the study, we want to look at in the one of the common fashion known as a PICO. P stands for the population studied. I for the intervention, what kind of intervention they did, hydrocortisone versus placebo. For example, in a last session, there were 4 arms, but there was no control arm. So keep that in mind too. Here it was a control arm, which was a placebo, and the experimental arm was the hydrocortisone. The C for the control arm, like what was a control arm? Is there a control arm, or there was no control arm at all? Like in the last study, Dr. Mukherjee showed, there was a semaglutide as a control arm, but there was no true placebo control arm. Remember in that SURPASS trial, the one he showed. So you want to see all these details, and O stands for the outcome. What kind of outcome they studied? Did they studied, for example, in the last part, they studied the hemoglobin A1C, but did they study mortality? Did they study the mechanical ventilation stay? Did they study the length of stay? So what would be a meaningful outcome you want to know? That's what I will show you again and again in this PICO format, or population intervention control outcome. That's easy to remember. So this was another study, again, for a blood glucose control published long time ago. I mean, New England Journal of Medicine, very famous trial known as the ADVANCE trial about the intensive blood glucose control and the vascular outcomes. Apurva and I were talking a minute ago that what are the vascular outcomes if you control the diabetes. So for example, when you look at the the study results, they randomize large number of patients, almost 12,000 patients or 11,000 patients, either the intensive glucose control versus the standard glucose control, less than 120 or more than 120 to 150, for example, and a long-term outcome, 66 months of follow-up. So remember, it's like 6 years of the study. So not just a short time control, like you saw in a previous study, the 40 weeks versus 6 years, pretty long-term control study. And this is what they mention, that the composite outcome of major macrovascular and microvascular events were significantly improved. The major macrovascular events were the stroke, MI, cardiovascular death. Major microvascular events were renal replacement therapy like dialysis and the development of albuminuria. So these are the outcomes they have studied. And this is their, the forest plot diagram or the outcome table like you always see in the New England Journal of Medicine. So they said that the hazard ratio was low, it was not crossing the midline. So that means this is a statistical significant. So then they just published this part in the New England Journal of Medicine as a title, that if you do the intensive control of a diabetes patients, you will have a composite better outcome. Now, if you look little bit in a more depth, for example, the more interesting outcome, like macrovascular events, whether the MI, stroke, death, they did not change. All are crossing the midlines. So there was no difference whether you give a intensive control versus the convention control. Similarly, new or worsening nephropathy was the only outcome which was actually driving the entire composite outcome. So, whenever you read the word composite, be careful, because they are trying to make you fool. They are compiling everything together and then driving the p-value. Now, even if you look at how was new or worsening nephropathy was defined, then it was defined with a new albuminuria. So the only outcome out of every single outcome, including death, MI, stroke, everything for 6 years of a long-term control, the only outcome which was improved was microalbuminuria. The people who have intensive control, microalbuminuria is less, everything else was the same. Is it meaningful for your people or not? Because it comes with the downside. That did create a significant hypoglycemia with the intensive control. That did create a significant hospitalization. You know, the hospitalization is always a costly, even if you have to admit 10 people, then you will lose that whatever the benefit of microalbuminuria you got in the rest of the population. So look from the different angles, don't just look at the final conclusion line in the New England Journal of article even. So this was the author's conclusion. The strategy of intensive glucose control lowered the hemoglobin A1C value to 6.5% and yielded 10% relative reduction in a combined outcome. I think the better conclusion should be that the 5 years of intensive glucose control regime increased medication resulted in absolute decrease in albuminuria, but increase in the severe hypoglycemia and hospitalization. So that might be a better conclusion. So even in a New England Journal of Medicine article doesn't mean anything. You are the reader, you are the practitioner, you need to understand how to interpret these studies. For example, this is another famous example of a perioperative use of the beta blockers. A lot of cardiologists are here. And this was one of the another famous study. By this, actually, the guidelines even change. And whenever we say, oh, guideline says this one, I will show you in a minute. Almost 1 million people suffer from major cardiovascular events every year. These are, again, the data from a long time ago. So they actually studied the people who are going for elective vascular surgery. On one side, there was a bisoprolol, the beta blocker. On the other side, there was a placebo. It was an unblinded study, but there was a real control. And a primary endpoint was a death or a non-fatal MI during or after the perioperative time, right? So that was a consideration known as a Polderman trial published in 1999 in New England Journal of Medicine again. So they did actually original size or a sample size was of 266 patients, but they looked at an interim look, like in between, and they stopped the study at 112 patients. So again, whenever you see in the literature like this, be careful. There is something going on.
5 minutes remaining.
In a hidden arm. The primary endpoint happened in 2 out of the 59 patients, so 3.4% versus secondary, outcome. In a placebo arm, almost 34% of the people had that outcome. So they said this was significantly beneficial. And based on this, even the ACC-AHA, this is like, remember, these are the big bodies. They mentioned that the beta blockers are required for a perioperative situation. Prophylactic beta blockers actually improve the the MI or the cardiovascular death and should be given. But eventually, there was a large randomized multicentric voice control. So they actually studied metoprolol, again, little different molecule, the people who are going for a non-cardiac surgery, and they have actually high-risk situation. Intervention was either metoprolol, extended release versus placebo, started 2 to 4 hours preoperatively, continued for 30 days. So this was a better randomized control trial compared to that Polderman trial because it included only 112 people. They have studied almost, in a multicentric, multi-nation study, and they studied almost 8,000 patients. So then sample size does matter, 112 people versus the 8,000 patients. It was a blinded study as well, quite a bit, almost 100% of the people followed up. And this is again happened, the composite endpoint. Primary outcome is a composite. Whenever you see the word composite, be careful. In a metoprolol, I'm 245.8% and placebo, I'm 6.9%. So the composite arm, metoprolol was looking better, and that's why the p-value was significant. If I show you the one after the another non-fatal MI, again, yeah, important, I think that's important, was low in the metoprolol group compared to this one. Cardiovascular death were same. Non-fatal cardiac arrest was the same in both the group. Very important secondary outcome. Previously also the speaker said about a secondary outcome. Mortality was actually more in a metoprolol group compared to placebo group. Can anyone think about it? Why the people have a non-fatal MI improved? But the more people died, what do you think might have happened? Yeah, non-cardiac, something non-cardiac. For example, what happens in a perioperative period? Sepsis, infection. So what happened, the people who were on a beta blocker, Because of the beta blocker, the other markers of sepsis, for example, tachycardia, was hidden. So they actually found the delayed diagnosis of sepsis or infection, and that's why the people are died. So what you have to consider is a better outcome, even though this was a secondary outcome. Do you want your patient to have a less MI or a death? That's what you need to choose again. So then again, the conclusion always
2
is
minutes
the different.
remaining.
But then that is a very important part. In our ARDS study, exactly the same thing happened when they did a 6 ml per kg body weight versus 12 ml per kg body weight. For the first 3 days, oxygenation was better, but those people died. So do you want a better oxygenation or a death? So that's a clinical outcome you need to understand again and again. And I will show you the one last trial again. And again, this was republished or reproduced in multiple randomized control trial, and even in a meta-analysis that the beta blockers perioperatively for a non-cardiac surgery does not actually improve anything. So we don't recommend, and then the guidelines eventually changed as well, that we don't recommend the beta blockers. The last trial I will show you for the pulmonary embolism. There are multiple pulmonary embolism trials, and they are catheter-based treatment. Remember, the conventional therapy for a pulmonary embolism is simply heparin. If they are not in a hemodynamic shock state, the simple therapy, what you have to remember is the heparin or anticoagulation, right? There are millions of studies where they actually are studying. For example, this was Ultima trial. So they have a catheter-directed thrombolysis. So then they will go in a pulmonary artery, release the thrombolysis there versus the heparin arm. And what they found, or what they studied, the outcome is a RV-LV ratio. RV-LV ratio improved after 24 hours. So this was a heparin arm RV-LV ratio. So if you thrombolize people locally in the pulmonary artery, RV-LV ratio improved in 24 hours. But what happened to RV-LV ratio in the 90 days? What happened to RV-LV ratio in a 1 year? Probably in both them it was same. Whether if you consider this one or this, clinically it was not significant. I can make any statistical computation. Same way RV dysfunction, they are trying to make you a little fool with the color change, but probably 1 or 2 people remain to have a RV dysfunction. If they were on heparin, everybody else improved their RV dysfunction even at point. So whenever you see this type of a study, this is what they are saying, that the Ultima trial shows that there is significant improvement in RV-LV ratio. Will you accept the RV-LV ratio as a clinically good outcome or not? That you need to decide. And I will show you this last quote from the Marcia Angel. She was the New England Journal of Medicine chief editor for 20 years. So 2 decades, she was a chief editor for NEJM, which is the highest ranked journal in the world with a 50 plus, the points. She said that for the last 2 decades, the industry and the companies are propagating the situation in such a fast pace that my trust from all this literature, all this randomized controlled trial has significantly gone down. These are not my words. These are the words of the Marcia Angel. So be careful whenever you interpret any study. Thank you.
Good afternoon, everybody. I promise you, we collectively will make sure you'll get to lunch session on time, and we'll all be there enjoying the lunch of Gordhan Maharaj, last session. So, I'm going to talk on hypertension guidelines today. Now you are wondering, what is this coronary artery disease happening? So this morning I was supposed to be here. I was called, one of my long-time patients, brother-in-law, came to hospital with severe unstable angina. He had hypertension. But anyhow, I took him to the cath lab. I put a stent, angioplasty. Both arteries are opened up. If you go back, he was in a bad shape. If you see, this is, can I get a pointer like yesterday? This is LAD there. This is circumflex, very critical. So I did it. So first disclaimer is, my core practice is coronary angioplasty, but somehow, somewhere in the scientific committee, I was assigned a talk on hypertension. So I'll entertain you with hypertension today. So thank you very much for being here. There's been a lot of guidelines coming in the US in hypertension. Can I get that green pointer? If somebody can bring me from the pointer, green. So every few years, hypertension guidelines have evolved, rightly so. And there has been various concepts. So there was a PC concept. PC is pooled cohort group. So few thousand, 48,000 patients were taken. And based on that, the hypertension guidelines were made. Here, if you see the right lower column. Last few years, using 6 million database, American Heart Association, for the age of 30 to 79 years, developed much more detailed factors to be looked in hypertension. And that is called prevent risk model, prevalence estimation for vascular events. Clear? Okay. There, the age is expanded from 30 to 79-year group. Now they include kidney albuminuria. They include social deprivation index in America. So you can imagine that becomes even more important in our Indian context, where 50%, 40%, whatever numbers is below poverty line. And better calibration across racial ethnic groups, which is also in a way to us. And the validation was anywhere between 3 to 6 million people. So coming back to the basic slide, normal BP now is less than 120, diastolic less than 80. How many of you can claim to be normal? Raise your hands. So I see 50% not raising or 50% still sleeping. So mine is normal, but it is on medication normal. 120 to 129 is elevated. Less than 80 is consistent. Less than 80 has to be normal. So the first is evaluation, slightly elevated, lifestyle therapy, which is exercise, diet modification, stress reduction. Then they made simple 2 stages. Stage 1, 130 to 139. Stage 2 is 140. They've removed so many into normal, elevated, stage 1, stage 2. Stage 1 and stage 2, you always have to treat an elevated, if not controlled, or with associated with some even higher risk, better to treat. Class 1 recommendation, when you have hypertension, do these few tests. It should be done. And how to measure is now becoming a part of guideline. It was always sit the patient comfortably. He should not take caffeine, exercise. Aram se beso, 30 minutes wait. So first thing is, let him relax. Blood pressure device should be checked. There is a website called validatebp.org. Use the correct arm. Take a measurement. And most important, look at number 8. Take 2 or more blood pressure measurements at least 1 minute apart. That should be compulsory. And I've seen that in my clinic also. Primary doctor measures the blood pressure. Patient comes to my room. After a few jokes, I like to joke with the patient. I talk about family, etc. You recheck, it has come down. Home blood pressure monitoring is mandatory now in America. Mandatory by certain guideline. So let me tell you, all your patients, if you have pharmacy related to your clinic close by, ensure, however basic is education is, Gamlana patient, Gaon ke patient, at least make sure they have one good BP instrument at home. We mandate that now. They take home blood pressure. There also you teach them, and you can also ask them to bring the machine to the clinic. We don't do primary blood pressure clinics, none of us cardiologists, we are interventionalists. But we do have almost 90% of or 80% of patients with high blood pressure and almost 50% patient diabetics. So we really now have to teach them about diabetic management and hypertension management. So these are the simple guidelines. Again, to repeat, now what they have brought in also is that what you measure in the clinic is what has been established as the hypertension guidelines. But it has to be corroborated with a 10 to 20% lower blood pressure at home. Get it? So their home blood pressure has to be low. So let us say somebody has a 110, 120 blood pressure nighttime at home. If you see here again, the likelihood of him having 135, 85 or 140 in the clinic is very high. So what they are saying is that home blood pressure should be even lower than the guideline recommended. So what is the guideline recommendation? 120 by? But what is guideline recommending off guideline at night time? What is the optimal? 100 by 65. What is nighttime optimal? Even if you are hypertensive, 120 by 70. So this is a very simple table. Start memorizing. Once you have the targets, start treating them. Standard threshold, high risk. High risk is 1. Because I think even they don't mention, but Asian, Indian, inherently is high risk criteria. Simple pharmacologic measurement. For years we have used beta blockers. Now they are saying don't use beta blockers. Beta blocker is becoming slightly on the sideline. Thiazides, always been used for 70 years. SC inhibitors, ARBs, calcium blockers are reviving again more or less. Always been there. But context-specific choices I want to emphasize. CKD albuminuria. How many of you who have hypertension patient, direct or concomitant diabetics, hypertensive, you always check albuminuria? Good, 70-80%. Diabetes, we always check, but how many of you check HB1AC? Always check HB1AC. Lot of sugars are normal when they come to the clinic, but HB1AC is 6.1, 2, which is practically diabetes now. And then you have resistant hypertension, and then now first time they're including device in their guidelines. So renal denervation. So I'll now show you, and I'm emphasizing to you, we love our catheters, but we use our catheters ethically with proper guidelines. Can you raise the voice, please? Sound.
Uncontrolled blood pressure may have an overactive sympathetic nervous system. Renal denervation
wake up,
aims
guys.
to suppress this elevated
And don't
sympathetic
talk.
drive. The Simplicity renal denervation system ablates the renal artery nerves that carry the efferent and afferent sympathetic signals, which has been proven to reduce blood pressure. The Simplicity spiral catheter and Simplicity G3 generator offer an extremely efficient and simple method of performing renal denervation. The Simplicity spiral catheter offers exceptional deliverability
So
and
I'll
ease of
stop
use,
here. I
short
showed this
procedure and
yesterday
ablation.
also, day before. And this briefly also, that we have been routinely, our group has been doing this renal denervation. Now I'll ask you a very key question. How many of you have referred a patient for renal denervation? Zero, practically zero. Which already shows that guideline recommends how many drugs after which you should recommend renal denervation? How many? How many? 3. With combination medication also, we give 6 medications sometimes, 7, triple combination. It is not your choice. Let the patient decide. If he doesn't want to spend 8-10 lakhs, that is his choice. Are we banned having a nice Toyota car? Are we banned having a Mercedes? Are we banned in BMW? So why are we opinionated not to refer to them? Please refer your cases with high and let him decide. So, and then I'll go to the extreme other side. Intervention with technology device is now part of the guideline. It is 2A, 2B. They are varying. European is coming with 2A. America is 2B
5
right
minutes
now.
remaining.
Lifestyle intervention is always there. Diet, weight, structured exercise. I exercise 2 hours a day and 1 hour yoga every other day compulsory, every other day optional. Special population, keep it memorized. I won't go into detail, it's a long talk, but CKD, diabetes, heart failure with preserved ejection fraction, and yesterday Anish told about phenylalanine, accurate measurement, team-based care, self-monitoring of BP, home monitoring of BP is mandatory. If patient is not bringing these numbers to you, enforce it, tell your assistants to teach them. Major updates, again, look into this criteria. So take home messages. Use prevent. Prevent means preventing events. Initiate therapy, 140/90, everybody, 130/80 for high risk, 120/80, red zone. Out of office BP management is very important. Thiazide, ACE, ARB, CCB, first line. Resistant hypertension has to be addressed early. Lifestyle therapy, number 7. Number 8, self-monitoring, telehealth. Telehealth with you, patient can communicate with you. Integrating, number 9, social determinants, poverty, less affordability, cardiovascular, kidney, metabolic risk, diabetes, very important. Albuminuria, very important. Target intensity based on risk, not just blood pressure. Pregnant elderly require tailored strategies. Use system level tools for population impact. Question answer session. According to 2025 guidelines, which is the preferred method for confirming diagnosis of hypertension. Do you have this pads today with you, or they've removed it? Hey? Okay, you have it. Start the timer. Single office, 3 readings, average more than 2 readings on more than 2 occasions, preferably ABMP or home base. Answer on the screen. So good. 75% have been listening. 25% are still thinking of the lunch food. So wake up. Correct answer is C. Emphasizing 2 readings, 2 occasions, home blood pressure important. In which patient scenario should antihypertensive be initiated at 130 by 80? Healthy 45-year-old, 70-year-old with orthostatic, CKD or diabetes with a high 10-year CVD risk, pregnant woman. Timer.
2 minutes remaining.
Still 25% were sleeping earlier. Easy question means you should have 100% correct. Let's see. It is not as easy as you think, Dr. Mukherjee. We tell our doctors, learn how to treat patient, and in between we tell them we do very good interventions. See, which of the following patient meets criteria for stage 1 hypertension under the 2025 AHA-ACC guidelines? Stage 1 hypertension was my 3rd slide. Which criteria? A, B, C, D. Timer. If you get half wrong, no lunch. Answer. I think I'm faster than the computers. 20% people, so out of 120, 150 people. And that is the guideline, I'll tell you. This is the concept we are bringing to teach doctors basic medicine, all of us. Which of the following medication classes is considered first-line therapy? Beta blocker, alpha blocker, thiazide like calcium blocker, central sympatholytics. So let's see, this is the most simple answer everybody should know how to write. Dr. Mukherjee is encouraging. Still 10 people are wrong. So thank you very much, everybody. Thank you very much. Enjoy the next 2 talks. Dhiren is talking about heart transplant. You should listen to that because heart transplant patients, we are the 2nd highest center in India. And then Dr. Apurva Patel is talking of real life experience of weight reduction, which you should not miss. After that, we'll open the forum for 10-15 minutes of question answer. We are back on time. Thank you very much, everybody.
All options were C. Didn't even have to think.
Thank you. Okay, good afternoon. After that exciting talk from Keurbai, now let's move from hypertension to heart transplantation. Both are HT. Heart transplant is also HT and hypertension is also HT. So how many of you have in your clinical practice seen a post-heart transplant patient? Great, good numbers. So I think so this is very important in present scenario with increasing number of patients getting heart transplantation. Every physician should know what is the basic thing that you should see when you're investigating a heart transplantation patient. The ultimate truth, there is a birth, there is a death. But in between, there is a maintenance. And that is where the difference that we can give to a heart transplantation patient. If we can maintain them in a good shape, then definitely the long-term outcomes are going to be good. Heart transplantation is a miracle. We know we are giving a second life to a person who was not supposed to live for another 1 or 2 years. But important thing is it is a marathon. And always tell to my patient that it is just the starting point. Surgery, it is not just like any other surgery like appendix hernia or bypass surgery. You do the surgery and you forget. No. You have to follow a very disciplined life. That is very important. So it is a starting point. Surgery is just the starting point, and you have to run a marathon for a better future outcomes. So the presentation goal is to give you an overview of once the patient undergoes a heart transplantation, what all things you are supposed to see when you see a patient of heart transplantation. So more than 135,000 heart transplantations have been performed world over, and last 10 years, almost 36,000 transplants have been performed. And over a period of time, the survival rate has improved significantly because of the advancement in the immunosuppressive drug, understanding of the pathophysiology of the heart transplantation. And if you look at the survival, every decade, the survival has been increasing, and now with the mean survival reaching almost 15 years, that is 50% of the patients, they survive 15 years after post-heart transplantation. So it's a matter of giving 10 to 20 years of life to a person who was not supposed to live for 1 year. Important thing is after heart transplantation, it is not just the relief of symptom, but improved functional capacity. That is what we are supposed to give to that patient with a better psychological well-being. Now, in heart transplantation, in normal patient or in normal life of any patient, lot of things are unpredictable. But in a heart transplantation patient, certain things are very predictable. And if you know what are the things that are going to happen over a period of 5 years, 10 years, or 15 years, then definitely you can catch hold of that problem early, that pathology early, treat that pathology early, then you can give a better long-term outcomes. So this is a chart you should remember what all things can happen in first 30 days, in first year, in 1 to 5 years, beyond 5 years. These are the set of complications that normally are seen in heart transplantation patient. It's very predictable. And if you catch hold of these things, then definitely you can treat this patient in a better way. So first and foremost thing, all these patients are on immunosuppressive drugs. And if the patient is on immunosuppressive drugs, then definitely it is a double-edged sword, because you give immunosuppressive drugs and you are inviting infection, you are inviting long-term complications of immunosuppressive drugs after 5 or 10 years. So when a patient is discharged, this is the set of medicines which are given at the time of discharge. So these are the medication for 6 months. After 6 months, few medications are stopped. This is the set of medication. After first year, normally they come down on immunosuppressives. They are normally on 2 immunosuppressives, that is tacrolimus and MMF. Steroids can be stopped after 6 months or 12 months based on the patient profile. Ecosprin AV, antihypertensive if required, and calcium supplementation for at least 2 to 3 years after first year of heart transplantation. So what is the immunosuppressive protocol? 3 drugs for first year. Again, from center to center, it may change. Some may stop corticosteroid within 6 months, some may continue till 1 year. I'm not going into detail about all this thing, but there are various immunosuppressive, though 4 immunosuppressive drugs you should be able to understand and remember. Steroids, MMF, tacrolimus, and sometimes in few patients we start everolimus. So these are the basic immunosuppressive drugs that we give to the heart transplantation patient. Very important thing is all these patients are on tacrolimus, so you have to see their tacrolimus level at a regular interval. So after first year, every 3 months, they should get their tacrolimus level, and the level that has to be maintained is around 4. If you can maintain tacrolimus level around 4, the chances of rejections are less. In spite of these immunosuppressive drugs, this patient may get rejection at any point of time. First year, the chances are highest. After the first year, the chances are really reduced significantly. So if you look at the incidence rate, 45% of the patients will already have had an episode of rejection by the end of 5 years. Important thing is identify that rejection, and very important thing is this patient may complain very subtle symptoms. They may say, I'm not feeling well, there is a misbeat, some palpitation is there, I have lost appetite. See, these are a very simple symptoms, but when you catch hold of these symptoms early, this may be a rejection. You have to investigate, you do an echo and ECG, and you will identify it as a rejection. So first year, we have to do endomyocardial biopsy, first month, 3 months, 6 months, and 12 months. After 12 months, there is no need of biopsy. Only if the patient develops a rejection, then a biopsy is required. These are the treatment regimes for rejection if they develop. Then the graft rejection. The chances of graft rejection, that the graft fails, EF again goes down for various reasons. The chances are very high in the first month, that is almost 28%, and then gradually it reduces. Then again it rises after 10 years when CAV enters in, and then it starts, many patients, they get graft failure. Infection, again, very common in the first year of transplantation, because these patients are on 3 immunosuppressive drugs in the first year. After first year, once the steroids are stopped, they are practically on 2 drugs. Then the chances of infection are less, but still, these patients are the patients who can get rare infection. We may not find aspergillus commonly in our routine cases, but in transplant patient, you do get a lot of patients getting aspergillus. Even rare viral infections, CMV infections are common in this patient because of immunosuppression. So you identify the organism and treat them at early stages. So this is basically the type of infection that you can normally see in your post-op period of transplantation. Cardiac allograft vasculopathy. Again, this is a very unique problem, unique complication of heart transplantation, which increases over a period of time, and by 10 years, 50% of the patients will develop CAV. And what is CAV? So basically, if you look at atherosclerosis, there is an eccentric accumulation of the cholesterol deposition, atherosclerosis. In CAV, it is a diffuse disease. It is a concentric hypertrophy of the endothelium. Histologically, it is intimal hyperplasia. It is rapid in onset, and it can be very deadly. So if you look at the angiography, these are the pictures of CAV. This may look just like your atherosclerotic plaques, but they are not. They are intimal hyperplasia, concentric intimal hyperplasia. So how to deal with CAV? Aspirin and statins are basic drugs that we start right away after the patient is discharged. Nowadays, there is data suggesting that if you start everolimus, within first year of your transplantation, the chances of CAV are reduced significantly. But then you are adding another 1 immunosuppressive drugs. Still, it is not recommended as class 1A indication. But yes, majority of the centers, they start with everolimus after the first year of heart transplantation, once the steroids are stopped. Chronic kidney disease, again, because you're giving tacrolimus to this patient, the basic side effect of tacrolimus is renal dysfunction. And all these patients should get urine analysis. Spot urine albumin and creatinine ratio should be obtained at least every yearly.
5 minutes remaining.
Malignancy, yes, because of long-standing immunosuppressive drugs. These patients, they have a high chance of getting malignancy. First year, 2.6%, 5 years, 14.1%. By 10 years, almost 30% of the patients may get any form of malignancy, and the most common are skin cancers and lymphoproliferative disorders. So 24% of the death after 5 years directly linked to the malignancy. Lymphoma is more often common seen in the young adult patients. So treating malignancy, obviously, again, everolimus has shown a better outcomes in preventing malignancy. So again, along with CAV, if you, this is a beneficial effect of everolimus when you add after first year of transplantation. Regular screening of abstenor virus load, and regular screening for all the malignancies in the body after 5 years is mandatory for all the transplant patients. New onset diabetes after transplantation, again, a side effect of steroids and tacrolimus. These patients, they develop new onset of diabetes. Almost in the range of 50% of the patients who are non-diabetic will be diabetic after 5 or 10 years. Neurological complication, heart transplantation, yes. Seizures, if the patient develops seizures, you have to reduce the dose of tacrolimus, that is CNI doses needs to be reduced. A very special issue occurs or pathology occurs in transplant patient, that is the posterior reversible leukoencephalopathy, PRES, after heart transplantation. It normally occurs because of toxic levels of tacrolimus level. So what you have to do is you have to reduce the dose of tacrolimus and substitute with CNI, other CNIs, and treat hypomagnesemia. And you can treat these seizures. Hypertension management, again, the treatment is the same. The only difference is you should not start beta blockers in this patient because this patient's heart are denervated and they don't have autonomic control on the heart. So normally we have to keep their heart rates above 90, 100. That is the mandatory thing. You should not reduce that heart rate below 80 because there is, I would say, denervated heart is there. Prophylaxis of corticosteroid-induced bone disease, you need to give them calcium supplementation. You have to give them vitamin D supplementation so that their osteoporosis is not there. The other complication that we have seen at our center, which are rarely seen, but yes, you have to be watchful. Pulmonary embolism, infective endocarditis post-EMB, that is biopsy, aspergillus infection, parvovirus infection, diarrhea due to cryptosporidium. In your routine practice, you won't see this diarrhea, but yes, in heart transplantation patient, we have seen in 5 patients developing this diarrhea. Persistent RV dysfunction due to high PVR and its management, and misdiagnosis of transplant patients and its wrong treatment. This is very important. In periphery, people, they are not aware what all complications this patient may develop. They diagnose it something different, they treat it in a different way, ultimately we lose the patient. So key to longevity is surveillance and adherence. It is very important that patient is very compliant, patient has to visit hospital at a regular interval, should get all investigation as per prescribed by the transplant team at a very regular interval. We give them a follow-up book with the dates mentioned that on this date you have to do this investigation, this date you have to do this investigation. They have to religiously follow this. This is their Gita, wherein they have to read this book every day. You also go through that book, and then accordingly you can get all investigation done for these patients. So pregnancy is special consideration. After heart transplantation, pregnancy is possible or not? Yeah, it is possible, but it should not be planned in first year of heart transplantation. After first year, it is yes. And if the patient is planning for pregnancy, stop MMF and just keep them on CNIs and corticosteroids. Future innovations are on the horizon for making their life better. So non-invasive diagnosis for rejection, novel therapeutic drugs are there, immunosuppressive drugs with less toxicity, and alternative organ resources are being evaluated, that is xenotransplantation, bioengineered organs. And last but not the least, take-home message. Personalized immunosuppression is important. Each patient will need personalized immunosuppressive drug, which the heart transplant team will decide. Proactive surveillance and risk management is important, which I have discussed in detail. And holistic and multidisciplinary approach for a heart transplant patient is important for their better outcomes. Thank you.
After these two great talks on hypertension and heart transplant, let's see if I can do some justice. So my name is Apurva Patel. I'm an interventional cardiologist at Lenox Hill Hospital in New York. And I'm going to speak on my personal experience on weight loss. And unfortunately, I chose the tougher path away from the GLP-1 agonist. And this is what worked for me, and I'm just going to share my experience. These are my disclosures. I love food. Okay, these are my favorite food from Ahmedabad, and I make sure that I have each and every one of them. So obesity with the current definitions and how the trend has been is clubbed into overweight and obesity together when you have a BMI of more than 25. So with the current NFHS study based out of India, if you are above the age of 20, the chances of you being overweight or obese is 18%, and as you grow older, it is almost close to 40%. So like 25% of Indians are obese. And when you look at America, it is close to 40%. So everybody knows, like, what is the benefit of weight loss? How much weight loss is good? So we know from science that 3 to 10% of weight loss has its medical and personal benefits, like reduction in blood pressure, cholesterol, diabetes, insulin resistance, obstructive sleep apnea, disability, osteoarthritis, lung function. Everybody is happy. Endocrinologists are happy, obesity people are happy, sleep people are happy, cardiologists are happy, you can fit into clothes, so wife is happy, everybody's happy, so good. Kids are happy because you can work with them, play with them, etc. The weight loss, it's an individualistic thing, everybody's different, right? Like we all know, we are all people associated with science, no difference, but men tends to lose weight much more easier if they wish to. And it's a hormonal thing as well. It depends on the body weight, size, muscle mass, personal individual metabolism, other comorbidities that can affect it, example, thyroid, activity level, and exercise habits. So, everybody's perception is like, you go to the gym, exercise a lot, burn the calories, you lose weight, right? So we have different type of individuals. So individual number one, gym enthusiast, 2 hours in the gym every day, right? You can lose weight. And you have individual number two, who's also not a gym enthusiast, okay? So like he has done 8 hours of heart transplant surgery and he's like, I can't spend 2 hours in the gym, come on. I'm like him, it's not possible. So what are the strategies that you can use to lose weight? So these are my strategies. So you can burn calories or you can restrict them. Restricting calories is potentially an easier option. That's what GLP-1 agonists do. They do not make you hungry, so you don't eat. So calorie restriction, followed by high protein diet, which I'll go into detail how that works. Some level of aerobic exercise, which is not that fun, and some level of resistance training. So calorie restriction. So for men, on an average, depending on the age, where you are, on a daily basis, they require 2,000 to 3,000 calories. Women tend to require lower, around 1,600 to 2,400 calories. So let's start with 25% reduction in your calories, right? That's the goal that you want to achieve, around 500 calorie reduction per day. And the goal is to reduce 0.5 pound to 1 pound of weight loss per week. Everybody's different. Some people will be much more faster, but this is sort of the goal that we are looking for. So there was a study done, calorie study, they followed up to 2 years, and basically they said that if you do 25% of calorie restriction, and this was done over a period of 2 years, you have a weight loss of 8 to 10%, which is a good sign. Your total cholesterol reduces, triglycerides reduces, insulin resistance reduces, your mean blood pressure reduces. So good things. They also looked at whether you can decrease the oxidative stress that is related. So they looked at urinary F2 isoprostanes levels. Those were reduced as well. So an indirect biomarker says that your oxidative stress in the body also reduces. They also looked at like the biobank analysis to see that whether there is any reduction in biological aging. They also found evidence towards that. The only downside to calorie restriction is bone mineral density reduction. So concern for osteoporosis and stuff like that is a concern when you just do calorie restriction. And that's why resistance training, protein diet, calcium supplementation, all those things comes into play. So the calorie concept model was if you have chronic calorie restriction, whether you can increase your health span, yes, because your mean time to disease for hyperlipidemia, diabetes will go down. And at the same time, your biological aging can also be reduced. So you could look younger even though you are old. That's what this concept eventually tries to prove. The other option is high protein diet. So like, the current guidelines would say 0.7 to 0.8 gram per kilogram per day. Tell me honestly, for an average human being weighing around 70 kilograms, let's say example, how many of you consume 70 grams of protein a day? Be honest. 1, 2. When I started this program, my average protein intake was 25 to 30 grams. Like honest. So what a high protein diet does, right? Like it works under multiple umbrellas, but it increases your diet-induced thermogenesis. Fat maybe less than 5%, calories, carbohydrates are 10%, proteins 30% diet-induced thermogenesis. What that does, it increases your satiety, at the same time changes your energy expenditure, pushing other things getting burnt. The second option, there are satiety hormones, GLP-1, cholecystokinin, peptide tyrosine. Those levels go up and the ghrelin goes down. And with that combination, your satiety level goes up. Your blood amino acid level goes up, your gluconeogenesis is pushed into that. They all increase satiety, meaning that forces you to eat less. Apart from your diet-induced thermogenesis, your resting energy expenditure is also increased. So it forces your body to increase, use the fat deposits, use the other calories for energy expenditure. Together, you have negative energy balance, you lose weight. And it helps to improve your fat-free mass. It does not take care of your fat-free mass. That is restored. So everybody says that in Indian vegetarian diet, what is the protein that you're going to consume, right? When I started this program, my initial inspiration were my 3 children. I'm 37 years old. So when my daughter, who's 1 year old, I'm like, okay, at 47, if she wants to play soccer, will I be able to run behind her? Then I paid a whole amount of money towards the program, and eventually that became my biggest inspiration. Atla paisa kharcha hai, to it has to be successful. You can't go away from that, right? So I'll tell you, these are my sources. 1.5 cup of non-fat Greek yogurt, which I basically make a chash out of it. That is 40 grams of protein off the bat. Every day, 1.5 cup of Greek yogurt, 40 grams of protein, okay? The other things I use is extra from tofu that gives you protein. And this is what I do on a weekly basis. This is basically what I eat. Paneer, chana, which are considered to be good protein diets, unfortunately has large amount of calories, so you are restricted by that. String cheese, which is a good snack item. 1 string cheese, which is like basically about the size of my finger, that is 7 grams of protein. And this protein shake right on the lower bottom. It's like a milkshake. Like you have 2 bottles and that is 60 grams of protein. So 1 chash and 2 shakes. That is 100 grams of protein that you're starting off the bat. Everything else is just an additional thing. So you have lots of Indian options as well. I started using these keto buns and keto breads, which are available in India as well. There are 35 calories per slice of a bread with 9 grams of protein. Not bad at all. And they taste just like a white bread. No difference. So there are trials that prove the high protein diet strategies, okay? They reduce body weight, BMI, waist circumferences, and at the same time, the most important thing, which I'll tell afterwards, there will be weight regain, okay? Whatever people start with, eventually the interest fizzes out and you will regain your weight. Continuing with a high protein diet, there have been strategies and studies that have shown that there is 50% less weight regain because your diet induced thermogenesis and your energy expenditure still continues to be the same. So calorie monitoring, very important. So whenever you want to start something like this, you really have to be honest to yourself. And there are apps, these are free apps. MyFitnessPal is a free app, which is available in India through the App Store, where you can monitor your calories. Honestly, track what you eat, and you will exactly know how much calories you consume. And whenever you do that, that will actually help you to realize that the amount of garbage or bad stuff that you eat. And Amazon also sells these weighing cups and
5
weighing
minutes
scales
remaining.
To help you decide how much you eat. I tried the macro strategy, which you probably may have read on social media. Unfortunately, in my personal experience with Indian food, being very stringent on macro is not possible because we are a very high carb and fat diet. So getting your carb levels down to less than 30% didn't work in my personal opinion. But if it works to your personal opinion, it's fine. But what I figured out that calorie restriction and high protein diet is something that I could do easily and could maintain for a period of more than 6 months. Aerobic exercise, 7,500 to 10,000 steps. It's basically to keep your joint moving, maintain, to have a good baseline energy expenditure, as well as reduce your baseline heart rate. There is no proven benefit of more than 10,000 steps a day. So, by the way, 30 minutes on a treadmill, that is 4,000 steps. So 1.5 hours on the treadmill will put you close to a 10,000 step. But if you just track your steps during your day-to-day practice, you will easily come close to 7,500 steps. Resistance training, which in my opinion was the best thing, that helps you lose fat much faster, as well as have a fat-free mass. I only did 30 minutes, maximum 40 minutes, 3 times a week, twice Saturday and Sunday on the weekend and 1 day during the week. And this was a program that was set up by a trainer who basically helped me do simple stuff, which is normally divided into the upper body and the lower body. So these were my weight loss trends. I started back in December of 2024. I started off at 180 pounds. And around July, I reached my nadir, which was 150, which is difficult to maintain that thing. And so I eased off on some of the calorie restrictions, and I've been maintaining around 155 at 1 year. So my BMI, which was 26.6, overweight, is now settled around at 23. So as I was telling before, people will regain weight. There has been lots of studies that there is a decline in treatment adherence. You may be the best person, whatever, but you will not adhere to that therapy at all. I had food for the last 3 days. That is my disclaimer. So there are cheat days and there are not, but overall, if you are in that thought process, you will get results. Maintenance strategies, the toughest part. Keep your BMI less than 25. High protein diet, 1 to 1.5 gram, it's actually easily doable. I just showed you. 100 grams of protein through yogurt and milkshakes is very much doable. 7,500 steps is easily doable. Resistance training 2 to 3 times a week is easily doable for 30 minutes. The 10 to 25% calorie restriction is the toughest part to maintain, in my experience. So that is something that you really have to work on. What did I do? The lowest I went to was 1,272 calories a day, which was very difficult. My mind would go crazy at the end of the day. But right now, I maintain around 1,500 to 1,800. Like on the weekdays would be 1,500. And on the weekends, I would go up to 1,800 calories. But I still consume 100 to 130 grams of protein a day. Thank you.
Thank you, Dr. Apu. I request Dr. Satya Gupta to present the last talk of the session, of course, last talk of the JIC 2026.
Yeah, good afternoon. This is the last session of our GIC. So here I'll be talking about the management of cardiovascular disease in the elderly population. We have been talking for the past 3 days about the coronary artery disease, valvular heart disease. I have no conflict of interest for this presenter except that my mother is a old age. And I am one of the author of the geriatric textbooks of medicine, and I am regularly updating that chapter. So coming to the demographic, yesterday also we were discussing that elderly population is increasing. If you see the trend in the USA, in 2030, the population is increasing, but not as that pace. But by the 2050, in US also, there will be exponential rise in the elderly population. And you see the data from the India, like 2010, there are hardly elderly population was very less. But now with the increasing longevity, increasing the age of the elderly population, I think India also by 2030 we will be going to have almost 25 to 30% of the people more than 65 years of age. So you see that yesterday we were discussing that whose future is bright. So I think those who are taking care of the elderly people, they know how to handle the elderly person. I think their career is going to be very good. And I always say age is proportional to the coronary artery disease. As the age increases, the coronary artery disease also increases, hypertension increases, diabetes chances increases. And by age of 75, almost 75% of the population will have some of the underlying coronary artery disease. So as the age increases, the coronary artery disease increases. So geriatric medicine, those who are taking their career in the geriatric medicine, definitely they are going to have a good future. And somebody was telling that for the interventional cardiology, I think for cardiologist role is never going to be less. Say for the clinical cardiologists, for the preventive cardiologists, interventional cardiologists, their role is going to increase day by day. So as the elderly population is growing, I think interventional cardiologists always have a role in management of the elderly population. So now I am going to discuss the effect of age on the cardiovascular system. As the age increases, our myocardium or the muscles being replaced by the fibrofatty tissue or the collagen fiber, beta-adrenergic receptor number decreases, they become less responsive, and sinus node function and endothelial function diminishes. So overall, if you see, compare with the 20 year of age and 80 year of age, almost 25 to 50% reduction in the efficiency of the heart. And which is too much. Like the age of 80 years, you can't expect a person doing a job or a person doing a same activity which used to do at the 20 years. So we have to accept that. And as the age increases, there is a pulse pressure which widens. The diastolic blood pressure goes down, the systolic blood pressure goes up, and these are the all physiological changes that we must accept. And as the age increases, the conduction system, our conducting tissue, nervous, they all replace with the collagen fiber, elastic tissue. The SA node become less responsive. There is calcification in the skeletal muscle and the myocardial muscle. Patient become hypertensive. Patient with underlying coronary artery disease. There is a lot of infiltration in the myocardium, and the myocardium becomes stiff. So most of the patient, they develop the diastolic dysfunction as well as the systolic dysfunction if they have the coronary artery disease also. They are more likely to have the arrhythmia, but basal, like preventricular mature, ventricular mature, beat, atrial premature contraction, they are very common. And so many patients are likely to develop the atrial fibrillation on the long standing. They may have the heart failure, they may have the heart failure with the preserved ejection fraction. Even because of the less responsive the SA node, they develop the sinus arrhythmia, they develop the sixth sinus syndrome. And if they have the organic heart disease, I think the bad. The coronary acute coronary syndrome, I think presentation is same in whether it's elderly or whether it's a young population. They may have the because of complete occlusion of the maybe unstable angina, or there may be non-ST elevation MI. The important thing here is the presentation may be totally different. The few patient elderly can have the typical chest pain, but most of the time they will tell pain maybe at the different location, different kind of pain. They will be having most of the exertional dyspnea and fatigue. Sometimes the elderly patient just they will tell extreme fatigue. You may not realize that he is having heart problem, but if you do the ECG, you will find out that he is suffering from acute coronary syndrome. Sometimes the elderly population can just complain the apprehension, nervousness, sudden mania, psychosis, confusion, and the syncope. So these are the presentation which you should be knowing that what elderly population can have presentation as acute coronary syndrome, and sometimes they may have the just GI symptoms, just gastric upset. And you do the ECG, you will find they have the myocardial infarction. Some patients, they just present with the congestive cardiac failure or maybe peripheral embolization. So the presentation is totally different. So you have to consider that whatever presentation they have, you have to investigate the patient. Diagnosis is the same like in the young population. There is no different management for this. And management, yes, the management again is not different from the young population, but individualization is very, very important. Should not have low threshold for thrombolysis. Sometimes we heard that, though age is 72, sir, should I thrombolize? Why not? If patient is fit, he is walking, talking, weight is adequate, go ahead and thrombolize the patient. Or if patient is suitable for the PCI, just go ahead and do the PCI. So age should not be considered restriction. It's never be a contraindication for thrombolysis as well as the PCI. And but dose has to be titrated based on the body mass, because as the age increases, the body mass reduces, and almost 30% of the patient need aggressive invasive management. So in our scenario, like after age of 70, 75 age, mostly physician also say, sir, age thai gaya, tyara se kasu karwan jarut nahi, aisa nahi hota hai. Almost 30% of patients need aggressive intervention. And remember, if you do a evidence-based medical or clinical or interventional practice in the elderly population, you get a better result. And all drugs can be given which are suitable for the acute myocardial infarction: aspirin, clopidogrel, ticagrelol, ACE inhibitor, beta blocker. But apart from the medicine, you have to think for the diet, exercise, family, and the psychological support. Because these are the patients where they have fear of dying. So you have to counsel your patient, you have to convince your patient that you will be all right. You have to reassure your patient. If you do practice like this, I think patient will be more receptive and they will be more listening to you. And stable angina patient management is same, but you should be very cautious by giving the nitrates. Whenever you are giving the nitrates, tell them or educate about the postural hypotension. And if the patient is asymptomatic, just remove the nitrates from the prescription. So as the patients come to follow up, he is asymptomatic, just remove the nitrates from the prescription. And remember, as the patient comes for the follow-up, try to combine the medicine, because at the age, as the age increases, the forgetfulness also increases. So the patient may not remember to take so many pills. So when the patient comes to follow up, try to combine the medicine and make the medicine less number of pills for the patient. Management, as I said, is the same for the ST elevation MI, less than 12 hours, patient symptomatic, just go for thrombolysis or may go for the PCI. No contraindication, age is not a contraindication for the thrombolysis as well as the PCI, but you have to see very carefully what are the indication, contraindication of the thrombolysis in this patient. What about the drug? Because as the age increases, our body mass decreases, total body water decreases, intravascular volume reduces, and the muscle mass reduces. That's why you have to be very careful about the dosing of the drugs. Sometimes the aspirin can be given the lower dose, 165 to 325 milligram. And aspirin has been shown to be useful in all age group patients, whether it's elderly, whether it's adult, whether it's vascular event also reduces with the aspirin. Nitroglycerin, as I said, give only if required and educate the patient about the postural hypertension. Thrombolysis, you have to be more careful about the contraindications. So educate, just ask yourself whether this patient is really having absolute contraindication, and you should be more worried about the relative contraindication also. In the elderly population, you should thoroughly see whether this patient is having even the relative contraindication thrombolysis. If there is no contraindication, definitely you can go ahead with the thrombolysis. And the important thing, you have to take precaution, because how much heparin you have to give, how much aspirin, clopidogrel you have to give, that you have to keep in mind. Patient weight has to be kept in mind. Patient is having prior stroke. Sometimes when you are in confusion, either before thrombolysis, you can even get a CT scan of the head done. So if you are worried that patient is having some lacunar infarct or whatever, then you can make sure that patient does not have any asymptomatic infarction or the hemorrhage. So thrombolysis, again, can be considered at any age until unless there is a contraindication. And as I said, 30% of the patients require the invasive treatment. So don't be having the low threshold for the invasive treatment. If patient is symptomatic, elderly patient, you feel that patient can do better with the invasive, I think this patient should go for the, and there are data which show that thrombolysis and angioplasty comparison, angioplasty is always better than the thrombolysis treatment. The death is less, re-stroke, myocardial infarction, even all the meta-analysis of the data have suggested that death, re-MI and the stroke, if the patient undergo PCI or angioplasty, the survival is better and the outcome is better. So if required, you should send your patient for the intervention. Yes, beta blocker can be given, but because of the prominence of the low sick sinus syndrome chances, just make sure that whatever beta blocker you start, you recheck the pulse. You can give ACE inhibitor ARBs to your patient, but recheck the creatinine at the frequent interval. HOPE trial has suggested that even the age of more than 70, less than 70, ACE inhibitor is going to help in the patient with the coronary artery disease. Just a few points about the statin. Don't reduce the dose of statin just because of the age. But once you starting the statin, just check the LFT. Every once in 3 weeks, one in 3 months, you can check the LFT. You can check the CK level, total CK level. If there is a rise in CK level more than 5 times the upper limit, you can reduce the dose, or even, because statin has a class effect, so you can minimize the dose. And if there is a 3 times increase in the liver enzymes, I think you can reduce the dose of the statin. So statin should be given to all the age group patients, irrespective of their status. And all the statin trials have suggested that there is a significant relative reduction in the mortality, say for all-cause mortality, CHF mortality, non-fatal MI, need for revascularization, the stroke. So statins should be given to all the elderly patients. And all the trials have suggested that till the age of 80 or 85, patient can definitely easily can go for the CABG or PCI, but after the age of 85, the risk significantly increases. So after the age of 85, you have to be very careful. If you are sending a patient for CABG or PCI, yes, all the parameters suggested that invasive treatment is always better than the non-invasive treatment. So if patient is doing okay with the medical therapy, you can continue, but otherwise patient can go for CABG and the PCI. So all the revascularization decision for the elderly patient depend upon so many factors. It's not only one single factor, but based on the so many multiple factors, you can decide which patient should go for a medical treatment, which patient should go for the intervention. Just a case scenario 2-3, 75-year-old male, diabetic dyslipidemia, upper angina class 2. He is able to do his routine activity, not on regular medication. ECG, STT changes, EF is normal. So I think this patient can be very well managed with the medicine. He doesn't need an intervention, even he doesn't require the angiography also, because he is doing good, he is asymptomatic with the medicine. Now this is a different scenario, 80-year male, diabetic, dyslipidemia, rest angina. He is not able to perform his routine activity. On regular medicine, STT changes are there in the ECG, EF is still normal. So I think this is the patient, he is having unstable angina on medicine, so this patient should be managed with the PCI or angioplasty. I just remember here one patient here, very famous hotel, this owner of the hotel, grandfather. He is 90 year, he was 90 year, and he was having symptoms after the aggressive medical treatment.
2 minutes
They
remaining.
came to me that whether I can do something for my father. I did angioplasty, and post angioplasty he is absolutely fine. Now the 2 year has been passed. He is 92 now, and he is enjoying his work. He regularly goes to a restaurant, and he is managed. So you have to ask the patient whether he is really symptomatic, or if the on medicine symptomatic, then you should do something. 73-year-old male, diabetic, dyslipidemia, upper angina, ECG significant STT changes, not on very regular on the medicine, presented with acute inferior MI. And post-MI, he was continuous to have the chest pain. And the family were not willing to do anything, and he was not going to field because of the chest pain. And they came to me. I'll just narrate a story later on after finishing this. About the valvular heart disease, I think Apurva and so many for the last 3 days, they have narrated that in elderly population, TAVI, TMVR, MitraClip, and the PMBC are the choice. So for the valvular disease, until unless there is a symptom, the patient can be managed medically. If on treatment a patient is symptomatic and if you feel that the symptoms are because of the valve problem, and in the elderly population mostly they have the three type of problem, I'll just not go into detail. Aortic stenosis, mitral regurgitation, and secondary tricuspid regurgitation. So aortic stenosis, mitral regurgitation, if you see the risk of procedure is less than the risk of the sudden cardiac death, or patient is too much symptomatic, I think these patients should go for the intervention procedure. If they are okay with the medical management, I think you can continue the medical management. So in conclusion, I would say there is a rapid growth in the number of patients, elderly population in India. Mortality for cardiovascular disease is very high in elderly population, and evidence-based therapy is very effective in this elderly population, and careful selection and tailoring of such therapy mandate the elderly patient with the cardiovascular disease. And if you live long, someday he or she has to die. Our job as a physician to delay the death while he is in the good health, and choose your treatment based on the patient. Be aggressive with the healthy elderly and save the inheritance of the sick. It's very important. Very sick patient, you think that is not going to survive, don't waste money or inheritance on just prolonging his life. You do whatever is justified, what is the guideline based. Treat the patient with the care and concern as if that patient is your father or mother. And after all, add one more medicine to the patient, the medicine of trust, assurance, and hope. Because this elderly patient, they always have fear in their mind that they are going to die. So if you reassure the patient, and last slide I included care at home. So as a physician, I would always say that if you are treating an elderly patient, just make sure that some non-specific things can be managed at home. If you are able to video call the patient, you can manage small thing on the video call. I think that patient will be more reassured, he will have more trust on you, and his family also will be like, no, having more trust on you. So try to manage elderly patient as you are treating your mother and father. And if you do this, I think you will really enjoy practicing, and I think you will not regret managing elderly patients. It's very important. Thank you so much. Yes, sir. So case slide was just a 75-year-old male. He was diabetic hypertensive. He was not on any medication, and he was having angina. And we started medicine, and he was all right. That's why we just want to continue the medical treatment for this patient, because he became asymptomatic on medicine. So then there is no need of angiography, angioplasty, or whatever revascularization in this patient.
What if the patient has left main disease?
Yeah, patient is symptomatic left main.
So for so my contradiction to a whole lot of things here, I'm going to stick my neck out. So without knowing the anatomy, how can you decide medical therapy? There is no medical therapy for left main disease. I can run 5 miles with a left main disease, but there is no medical therapy for left main disease. Your sudden cardiac death risk is significantly higher. So there are lots of ways to understand anatomy, non-invasive ways, be it CT scan. I'm not even talking about angiography, but at least know the anatomy. Make sure it's not a left main or a left main equivalent, and after that, medical therapy, no problem.
Yeah, I think Apurva, your point is absolutely right. That's how world has studied all such stable angina patients. But in Indian scenario, we do have to carve our path through so many other aspects. You rightly know that. But point is well taken. If we rule out significant left main disease by whatever method, that's always a safer area. Coming to your point, Anu, Apurva, heads off, huge compliments. Had all the guts to look back to yourself, correct yourself, and put it to the people. I do got inspired personally, obviously exercise, etc. program is on, but taking that high amount of protein, I do not take as much. My personal belief, maybe whatever reason is, I'm not too much protein centric, though allopathic science is, and that's where many people have data. And personally, maybe whatever, my genes, etc., I'm okay with 40 to 50 grams of protein, doing a lot of resistant training, maintaining huge lean body mass, fat percentage close to 13-14%, but I will take that point, will increase my protein. And this talk next time we'll keep in the students. I mean, see, today there is a quiz running at hotel where all MD students are there, 240, 250, maybe 300. So they will be more inspired with this talk, I'm very sure, because 30 to 40% students are obese and hardly few of them are following good lifestyle. Appreciate.
Even yesterday lunchtime I asked, Apur, what did you do? Means you become so, yeah, it was really inspiring. So.
Yeah, actually, after talking to Dr. Apurva Patel, I've increased my protein intake, but my wife too. And I think any mode of weight reduction, most important, Professor Lucas yesterday mentioned, day before in the town hall session, that the newer drugs which reduce weight, the most important thing is protein replacement. So proteins are very important part, otherwise proteins get burned. So from this conference and from interaction with Apurva, and the second message again to all of you is, exercise is a very integral part of longevity now, with improving of VO2 max. So that's important. Thanks.
So,
anyhow.
so just to add one more point to longevity, like in the past 3 days, like, we have talked about, and coming to this geriatric talk as well, we are doing everything to make them live longer, but at the same time that when they get older, then we should give them all the potential options to even keep on living longer. Because you can't say, we made you live longer, now we cannot offer you any other options. Okay, this is me talking as a pure interventionalist.
Dr. Apurva,
yes, sir.
My question. See, now patients are coming, even if many relatives are consuming protein powder,
Yes.
other than that. And in my few patients, I have seen their creatinine level is increasing. Not, but if their baseline is 0.9, 0.8, then 1.2, 1.3. So just your opinion regarding protein powders available in the market, whether it should be consumed or not, then the protein. And second, few patients are non-vegetarian. So what kind of diet plan should be for that? Because then if red meat, chicken, it will increase cholesterol. So what should we plan for that?
So let me answer your second question first. So regarding non-vegetarian, I don't consume it, so I cannot tell from personal experience. But from what I read and what my trainer basically said, that if you want to research about, there's a lean meat and a fat meat. So if you look at lean meat, those are the ones that you have to consume, like where egg white comes into play. There are different types of meat like ham or etc. Red meat comes into the fat meat category where the fat content is higher. So you have to do research on the lean meat, and that will tell you which has high protein, low fat. Coming to the first point, so there are multiple protein powders, milk-based protein powders, plant-based protein powders. Across the board, multiple trials, they have not shown worsening of kidney function. Okay, I did not put that slide up, but I have read through that data. It does not increase creatinine or anything. So now, individualistically, there will be people who may see it, whether there have been dehydration, whether they have exercised a whole lot, they've spent 4 hours in the gym, you have muscle injury causing creatinine elevation. Do they take any other supplements as well on top of it? So it's an individualistic thing, but from just an overall perspective of having 130 grams or 150 grams of protein a day, there is nothing. Like 150 grams of protein a day is commonly recommended after orthopedic surgery for faster recovery. They do not see
5
any
minutes
creatinine
remaining.
elevation.
A comment I have, just a small comment, when you mentioned age. My mother, I did angioplasty when she was 85. She's 94 now. If you Google, put a Google, Keyur Parikh, 107 years. This is a patient whose son had done intervention when he was 75. Patient got critical in Mandsaur, 3 times admitted to local place, 3 times discharged. Patient was brought by the son saying, we want mother alive. I did intervention with total, all kind of signature of consent that I can't take the risk because 107. This was based on not only Aadhaar, but some evidence, it may be plus or minus. It's been 3 years, she's still alive. So age in India is our mental block. Believe me, it's a total mental block. I know Milan having done 90 plus years and people have done well. So there is so much mental block that, okay, so what Apurva said is very key. If you want to make patients and people live longer and wait till all these new drugs, Monjaro, etc. are shown to make you live longer with microdosing, I'm not suggesting, but maybe 2 years from now. So age is all relative. Okay, Anish.
Yeah, adding 2 points to the previous issues. Number one, protein supplements. Like, see, I know and I have tested and tried a lot till before last 5 years. There are many wrong and extremely poor quality sources. So please, for yourself, for family members, and for patients, don't let them have any kind of sort of whey protein. So many humbug things go on. You go to any gym, all gym trainers are interested only in one thing, that you become their personal client and they keep on selling a lot of wrong things. What personally, based on my experience, the way I studied my body language, body signals, the mind, my test, I believed whey protein from one science and optimum nutrition. These two sources, I mean, I have nothing to do with the business, but these two sources I felt good and I did not have adverse effect. I tested so many and few of them did cause serious adverse effect to my body and mind based on my personal understanding. Second point about creatinine. In fact, very low level of creatinine is a poor sign for longevity because it predicts your protein intake is less and your muscles are poor. So those who have significant amount of muscles and those who take reasonable protein, they will have creatinine, not higher than normal, but on the upper side. So having too low creatinine, which many Indians have, is a very, very poor sign.
One question to Dr. Mukherjee, sir. Just wanted to know about the weight regain after you stop the tirzepatide and the worsening of glycemic control after you stop the tirzepatide.
So I think this was my topic in Swasthacon yesterday. That what happens when you stop the anti-obesity drugs? Data available is
2 minutes remaining.
This data available for both semaglutide and tirzepatide. Semaglutide, the first trial was a step 1 trial. After 68 weeks, they stopped the drug. Half the people stopped, half the people followed for another 1 year. Weight regain was almost 70%. And the second trial with semaglutide was step 4 trial, where they stopped after 30 weeks. There also weight regain was to the tune of 70 to 80% within 40 weeks. After that, data is not available. With tirzepatide, is only one trial called a SURMOUNT trial, SURMOUNT 4, where they stopped after, I think, 32 or 36 weeks. Again, followed up for another 40 weeks. Patients regained the weight back. Just Google BMJ 2026. The Oxford group did a meta-analysis, only of 11 papers, including these 2 from semaglutide, 1 from tirzepatide, 7 with liraglutide. Just got published, I think, this couple of days ago. I just showed the abstract yesterday in my talk. They did a further calculation, projection, and you read the conclusion that within 1 year, you will regain all the weight that you have lost, and by 2 years, you will probably start regaining the weight. So that's what I said yesterday in my talk. Whenever you're starting semaglutide or tirzepatide, I mean, don't just start to make the company happy. Start to help the patient. So if you're starting, start thinking it's a lifelong treatment, just like antihypertensive and anti-diabetic medications. And that's why what I wanted to give advice to Apurva, that all lifestyle-based weight loss, you have done wonders. So you see, I mean, I have the slide, it's a meta-analysis. All lifestyle-based weight loss programs, people do wonderfully well, like you've done, well done. It's not easy to get to where you have got down. My sincere hope and advice to you is, you gave all the reasons of failure to maintain the weight loss. All of them are applicable, unfortunately, because all trials of lifestyle have failed by 8 to 10 years. I'm not discouraging you. I'm just saying that stick to the lifestyle modifications.
So that's the biggest challenge, right?
Yes.
So the medications are a pharmacological behavioral deterrence that suppress the hypothalamus, make you not eat.
Correct.
Lifestyle management, you learn it by yourself, and then you figure out. So basically, you can start with lifestyle management and then go to microdosing of GLP-1 agonist. I'm just kidding.
I mean, no, what he says is not wrong, because there are already people suggesting that you might take microdosing. My last question is about proteins and renal damage. I would not recommend more than 2 grams per kilogram. Don't go beyond that.
Perfect. 2 grams per kilogram, that's okay. I mean, that is what he's taking.
Yeah. So, 2 grams per kilogram.
For me, it was 100 to 130. Yeah.
There's no randomized control trial data, what you said, but above 2 grams per kilogram, I'm a little bit hesitant to take.
So Apurva, now there will be thousands of eyes will be critically evaluating you for next so many JICs. But believe me, that's a very positive push, and that is the push with which I am living so happily, because I did it before 22 years, and then I'm the same after 22 years. So I believe those eyes which look at you with that criticality, that let us see, those eyes are the biggest source of inspiration.
So basically, I've shot myself in the feet by giving this talk. So if I get invited to JIC, I have to make sure that I maintain every year, right?
Just one question, sir. Suppose a person having hyperuricemia is on febuxostat.
I can't hear you, sir.
Suppose a person is having hyperuricemia of 8 to 10 and he is on febuxostat. can he omit the protein or he should take?
No, that needs to be consulted very particularly to see how the patient responds. Because if you're like, what is the response on the medications with the uric acid level, what type of protein you can choose and drink, then you cannot go at this high level. These are for people who are young and want to go into weight loss without any significant comorbidities.
Thank you.
I mean, before conclusion, let me put the last point to what you asked. Very unfortunate, in India, 90% doctors cut down the protein intake when they see uric acid of 6.57. Please, asymptomatic uric acid of 8.5 and symptomatic more than 7.5, please do not cut protein. That's a very serious business. Unfortunately, doctors बहुत disservice कर रहे हैं society की. Uric acid देखा नहीं कि fabric लगा दी और protein बंद कर. एक तो Indian sarcopenic है, मर रहा है बेचारा protein खाए बगैर, उसका protein कैसे? So in practice, please don't stop protein of anyone. That's it. Take a practical point, you will help the people.
But normal protein, not high protein.
Yeah,
that's it.
secretly, you don't need to stop.
High dose should
Exactly. That's where people die earlier. Yes, yes. So I think with the due permission of all of you, let's conclude JIC 2026.
Thank you, everybody.
All the faculties, all the speakers, all the chairpersons, all the
Join
delegates.
us for lunch.
Event management
Last
team,
lunch of
pharma, trade, everyone. Thank you very much. 8, 9, 10 January 2027, hopefully with a new team leading the show. Thank you.
Old team always there.